From Nagatami, like plus we get honor a guest speaker. Please, Nagatami, you are the first. You moderate this.
Distinguished guests, speakers,
Hilang suaranya? From Nagatami, I cannot hear your voice.
Ada.
distinguished guests, speakers, delegates, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. The Honorable, the President of ASEAN Congress of Neurological Surgeon, Professor Yoko Kato, MD, PhD. The Honorable, the President of Indonesian Neurosurgical Society, Professor Abdul Hafid Bajarnal, MD, PhD. The Honorable Vice Rector of Mataram University, Mr. Agustin, SA, MBA, DBA. The Honorable the Chairman of the Committee, Dr. Hadi, PhD. And also professors, doctors, all speakers, ladies and gentlemen, we love. Distinguished guests, speakers, delegates, ladies and gentlemen, thank you very much for your coming on pre-conference, Second ASEAN Congress of Neurological Surgeons. Before we move on to the next agenda, let's take a moment of silence to pray. Pray, start. Thank you. And now, we will be entering the first session, Workshop Neuroendoscopy, with Professor Sri Maliawan, MD, PhD, as a moderator. Before I hand over the session to Professor Sri Maliawan, please allow me to read his CV. Professor Sri Maliawan, MD, PhD, was completed his medical doctor's studies at Udayana University, 1982. He continued his specialist studies at Airlangga University and graduated as neurosurgery specialist in 1991. In 2000, he became neurosurgeon consultant. He completed his doctoral studies in 2005 at Udayana University. And in 2008, he became professor in Department of Surgery and Neurosurgery. There is the short CV from Professor Sri Maliawan. And now, I hand over the session to Professor Sri Maliawan. Time is yours.
Good morning, everybody. Good morning, our distinguished guest speaker, Professor Nakagawa from Nagoya. Today, we will doing the second virtual ACNS Congress. So today, this morning, we will start a neuroendoscopic workshop. So here, we will start from 8:30 until 10:30. We have six speakers, and this workshop will be moderated by me and Professor Nakagawa. So thank you for all speakers. It's already present right now. And then we have all of the participant neurosurgeon, a young neurosurgeon or trainee neurosurgeon. So thank you for your participation to this second virtual ASEAN Congress of Neurological Surgery. And thank you for the president of this Congress, I mean, in Lombok, Dr. Rohadi, PhD. Thank you. Thank you,
Professor.
committee. Thank you. I let's you, Dr. Nagatami, add the introduction for this. Thank you.
Thank you very much, Chairman. So, yes, I'm now attending from Nagoya. Yes, yes. So the neuroendoscopic surgery, I think they started 20 years before, about 20 years before, and then they're progressing day by day. So increasingly we need education. So such workshop as today is very, very important, I think. So I am very happy to chair this session, and we are looking for the very nice presentation today. Yes. So yes, shall we start the lectures or?
Yes, we are on time.
Yes.
Yeah. So the first speaker will be me. Let me share the presentation. Okay.
You chair the
first you chair it.
First, yes, and later I chair. Yes.
Yeah.
The last half I will chair. Yes. Okay.
Okay. So I send screen right now. Okay.
Yes.
Yes, Prof.
Yeah.
Maybe direct share.
Yeah. Do you got my picture?
We cannot see the image yet, Professor.
Oh, I'm sorry. There is trouble here. Can we move to the second speaker, and then I will change this for this trouble a little bit. Please, Professor Nakagawa, move to the second speaker, next speaker, and then I after that. Sudah open. Share speaker, share.
With the first speaker. Yeah.
Please change to the second speaker, and then I the next because the trouble here a little bit.
Yeah.
Okay.
Second speaker is Prof. Azmi alias from Malaysia.
Yeah, yes.
Maybe because Prof. Azmi cannot join in this morning. Prof. Sri, we maybe committed have you for the share slide.
Okay, it's okay. Halo, tolong ke tempat saya nih, nggak bisa ini apa ada masalah nih share gini.
Actually, may we proceed to the next speaker first? While we're waiting your presentation, we will be presenting Mr. Tadashi Watanabe. Dr. Tadashi Watanabe's pre-recording.
This is Tadashi Watanabe from Nagoya, Japan, and thank you for giving me an opportunity to make a presentation here, Professor Rohadi. And today's my topics is endoscopic and exoscopic minimally invasive neurosurgery. I am working on minimally invasive endoscopic neurosurgery for about 20 years. I started this endoscopic keyhole approach since 2007. So initially, I was doing very simple cases like this, but by development of the tools, gradually we are doing complicated cases recently. Yeah. So in 2019, when I moved to Aichi Medical University, we have got a 3D vision by Stoltz. So we started to use exoscope with this approach. So since then, we are doing almost all the scheduled cases of brain tumor cases with this exoscopic and endoscopic approach. So we can switch the viewpoint of outside and inside the surgical field to obtain an appropriate view. And surgeon and the scopist proceed to the surgery together. This is the 3D vision. We wear the 3D glasses, and this is the hand controller. We can adjust the focus and zoom with this switch. So what is the advantages of exoscope? First of all, it is small. Like this, it is smaller, much smaller than a microscope. So it means good handling. And we can switch to macrosurgery easily. And this is a microscope. It is much smaller than microscope. And the second of all, it has a free visual access. Like this, we can see the objective with a horizontal visual access. Even we can do a lookup surgery also. So it provides us a comfortable posture of surgeons and the patients. Yes, compared to a microscope. And the scopist control and adjust the position and focus and zoom, so surgeon can concentrate on the surgical procedure. And all the staff can share the same field of view as the surgeon. So it is very good for education also. and it is cheaper than my microscope. Actually, these advantages are almost same as the endoscopes. And the most important one is it is exchangeable to an endoscope as appropriate, because it is the same heads-up surgery. So by looking at the monitor, we can seamlessly change to endoscopic surgery. So about the disadvantage, in this system, it is still insufficient images with high magnification. And actually, the visual axis and the optical axis are slightly different. So when we look at the deep side from a small craniotomy, some small problem will happen. And sometimes it is the white out happen with the white tissues or draining of the bone. So adjustment of the exposure is a little bit complicated. But the scopist will adjust the exposure or and change the position, and also of course the endoscope will resolve the image problem. What about endoscopic keyhole surgery? The advantages are from smaller entrance, and we can look at the wide viewing angle, and underwater surgery, we call it wet field technique, is available. And the drawbacks are there is confliction of tools with the endoscope itself. And sometimes the shallow part of the surgical field can be a blind area. So we use curved or flexible tools to avoid a confliction. And also scopists will control the position to avoid the confliction. And sometimes the exoscope will resolve the shallow part manipulation. The scopist provides a precise adjustment of the endoscope to maintain a good field of view and to avoid a clash of instruments. And the scopist move the endoscope along with the instruments to prevent the tissue damage. And always put the finger on the shaft to make a meticulous movement of the endoscope. These are the curved or flexible tools. And this is the setup of our operation theater. And this is the hand controller. And this is the scope stand. We can put another scope here. And this is Junior. Is a floor standing pneumatic holder. So I'm going to show you the video of a case of CB angle epidermoid cyst with a trigeminal neuralgia. So now craniotomy is done with a surgeon with a small skin incision and about 2.5 centimeter craniotomy. So everyone can see what the surgeon do on the monitor. So 2.3 craniotomy is done. And from the dural cutting, the surgeon is looking at the monitor, and the scopist is controlling the position and the zoom and focus. So now we are drainage the CSF. So the scopist is moving slightly for a surgeon and adjusting the focus. So when the whiteout happened, we can control the exposure like this AEL button. We can control the exposure. So now we can look at the white tissues, nerves and epidermal cyst. Clearly we can see. So in this approach, the patient is placed in a supine lateral position and the head is rotated 90 degrees. So it is easy to set up the patient position. So as you see, you can do a microsurgery without any problem with the 3D exoscope. So we can control these tiny vessels on the tumor. So we are dissecting around the petrosal vein with the exoscope. So now below the eighth nerve, seventh, eighth nerve, there is a tiny vessels, the tumor. As you see, the assistant can serve the patty, cotton patty, because there is much space here above the surgical field. So now we change to the endoscope. So quickly we can change to the endoscope. So the scopist will control the endoscope from with the surgeon. So put the finger on the shaft of the endoscope. So endoscope and the tools are going into the surgical field together. So now you can see the much wider viewing angle compared to the exoscope. So now you can see that this tiny vessel is feeding the brainstem. So we have to preserve these small vessels. So we are now dissecting these small vessels from the tumor. So this part, ventral side of brainstem, is difficult to observe by exoscope, but easily to observe by endoscope. So this is the last part of the tumor dissection. Then we can removing the membrane from the fifth nerve in wet field technique. So mostly the tumor is resected. So the tools and the endoscope is moving together like this. So we can get safety. And now we are changed to the angle scope, the 30-degree scope, to look into the internal meatal canal. Because the tumor is a little bit embedded into the canal. So we confirm the tumor is left inside the meatal canal in the underwater field. So all the tumor is gone. So we change to the exoscope again and we close the wound. Okay, I show you another examples. This is the middle fossa meningioma. In this case, when we do a microsurgery, we always remove the digomatic arch to make a craniotomy just on the tumor. But in this case, by using an endoscope, we can remove the tumor like this. So we don't need the zygoma cutting. So we could remove the tumor with a small craniotomy. And this is the metastatic tumor here, just beside Fox. So the best way to approach this tumor is from medial, from a Fox side. So in this case, by setting the the patient head like this, maybe 80-degree rotated with a small craniotomy, the gravity will make the brain sinking down. So we can make the space between Fox and the brain. So by endoscope, we can easily observe the middle side of brain. So we could remove the tumor. Also, this is the parasagittal meningioma. Just above the tumor, there is a diploid vein and also the bridging vein also. So we approached this tumor from frontal side. So this side of craniotomy at the midline is made, and we are observing from frontal. We dissected the tumor from the brain. There was a tough there's a tough attachment, so we changed to endoscope. So we are detaching the tumor from the Fox and sagittal sinus, and we could remove the tumor from frontal. The craniotomy is here, so we are looking at the tumor like this. This is C1 meningioma of 86 patient with a minimum wound or just a hemilaminectomy of C1. We could remove the tumor with the exoscope and endoscope without retracting the brainstem. This is a case of petroclival meningioma, which is extending above, compressing the pons and the midbrain up to ambient cistern, and also it is extending into the Meko cave. So with the suboccipital, lateral suboccipital approach, we did surgery. By using an exoscope, we decompressed the tumor, and by using an endoscope with a wide viewing angle, the detachment and the dissection from the brainstem, and leaving the nerves, third nerve, and this is the PC, and the fourth nerve. We left every cranial nerves, and all the structure is confirmed, and we left a small part of the tumor at the Meko cave. Otherwise, we removed all the tumor, and the compression is relieved. And also we do MVD with this approach. Mostly we do with field surgery in this case, in these cases. These are the experience of us in this 1.5 years. This is the conclusion. Using exoscope and endoscope, the viewpoint can be switched between outside and inside of a surgical field to obtain appropriate image. And these advantages of exoscope: it is small and it has a free visual axis, and it is exchangeable to endoscope anytime. On the other hand, the disadvantages are still insufficient image for a highly magnified view and a deep and a narrow area. So it will be resolved by the endoscope, which has the advantages of wide viewing angle from a small entrance and close-up observation and underwater observation. But it has a disadvantage of a clash of instrument with the endoscope. So ingenuity of tools and scopists will resolve the clashing problem. Okay. Thank you for your attention.
Thank you for Professor Watanabe for very interesting and clear picture, and we can understand very well about the approach and so on. So we come. This is I will speak today. Right now, the second speaker will be me, and please, Dr. Nagatami, moderate this session. I will share the slide.
Please start your lecture. Okay, yes.
Can't sense it.
Yeah.
I will share the screen.
Yes, you need my lecture start. Yeah.
Yeah. Okay.
Okay. Yes.
Can I share right now? Please stop the first speaker's presentation. Share off, and then I will share my. Share. Okay, sudah nih.
The second, can I start now? Okay.
Okay, I share now. Who the second speaker?
Because yeah.
Yeah. Nggak bisa. Okay. I cannot share it. Who is the second speaker, Dr.
Second speaker is Prof. Sri Maliawan.
Okay.
Third speaker is Prof. Azmi. And second step is Prof. Nagatani after many.
It's difficult to share, but can you make me to be the co-host so I can share it? Okay. Okay, can you see my slide?
Yes, yes, okay, yes.
Okay, thank you.
Very good.
Thank you.
Okay, endoscopic third ventriculostomy. I am Sri Maliawan. I am now in the biggest hospital in Denpasar, Bali. Maybe Dr. Nagatami have been to Bali, I hope. I will talk my own experience in doing endoscopic third ventriculostomy. Until now, I already done 285 endoscopic for hydrocephalus. Yeah, this is the last 10 years ago when I for the first time come to Bali. This is the profile of hydrocephalus who come to my center. Most come from village remote area, so in big and very severe, already disabled. This is Bali, the island almost at the center of Indonesia, Bali Island. in the literature, the incidence of hydrocephalus 2 per mil, but we have now at that time 4 per mil. This is 6% complication to 812 patients, proximal catheter dislocation, sun defect, and so on. So whoever doing this VP sun, we almost can get this complication. Sometimes there is one cases reported after 31 years old, unfortunately was treated with 56 times of some sun revision. And this first ETP, it was done in 5th of March 2005. I was supervised by a pediatric neurosurgeon who personally I invite and come and stay for 10 days in Bali, and then supervised me to do first ETP. Why you should learn it? ETP is an option for about a quarter of children with hydrocephalus. A lower risk for infection for ETP, less than 1%, compared with the sun infection risk around 10%. Most ATP failures occur within the first 6 months of treatment. Complications always occur in the first 100 procedure, a learning curve. And after 100, technically, there is a low error rate, and technically, after 100 procedure. And then ETP, right now, it done for obstructive hydrocephalus due to aqueduct stenosis, to Dandy Walters malformation, hydrocephalus due to myelomeningocele, secondary intracranial hematome, but not acute phase. Later, after VP sun, when there is problem, we should change to ETP. Hydrocephalus associated with craniosynostosis, and combination of ETP with choroid plexus cauterization, tuberculosis meningitis, after malfunction of the sun, I did it, many cases, secondary hydrocephalus due to posterior tumor. It's very good result. And normal pressure hydrocephalus. Some literature say the successful rate for normal pressure hydrocephalus is around 60%, they said. Because what? Because there is still a different pressure between ventricular system and subaround space. This is a variation in anatomy of ventricle with bone, most variation. This is the classic hydrocephalus. We followed from plexus choroid, foramen Monroe, and then we can clearly identify the mammillary body, and then recess and pedibulum. At least in mind, you should think about basilar complex, stalk, hypophyseal. So when we doing ETP, we should concern about this, where to be penetrate of the base of third ventricle. And this is ETP success score. It's contained of age score, etiology score, previous sun score, percentage probability of ETP success. So the higher the score, the more the good, the more better outcome we can get. The most simple definition of success for ETP is freedom from a sun. Criteria for defining success: clinically, resolution of the preoperative sign of risk ICP, radiologically, decrease or stabilization of the ventricular size over a period of 3 months. Most marked change is noted in the case of acute hydrocephalus and the reduction in size of the third ventricle. This is literature, the ETP success score and success rate. Patient selection, this is maybe the most important part of this successful rate of ETV. The patient selection. Sometimes if there is a multiple anomaly associated with hydrocephalus, very complex structure of ventricular system and so on. So the indication is obstructed hydrocephalus after shunt removal, subdural hemorrhage after shunting, dead phase, slit ventricle syndrome. Relative contraindication because low success rate, they said, communicating hydrocephalus, normal pressure hydrocephalus. Equipment, I prefer rigid endoscope. I use a 30-degree angel length, ITP specialscope, proper light, and monopolar. We're familiar with monopolar, and then Forgati catheters, 3 francs or 4 francs. We have from, this is also stores. This is my first equipment, like this. And this is operating room setting. You see, 3 of us focus on the monitor work. And then a surgeon and assistant must look straight to the monitor, and supine headrest elevated 30-degree. This is, after my experience, the best position for this. The trajectory, it must be nearly straight to the foramen Monroe and foramen Monroe. So if you do wing a little bit lateral, the trajectory on the foramen Monroe will be a little bit oblique. So sometimes we got difficulty if too lateral. So make sure that the trajectory straight to foramen Monroe. So because our scope is straight, it is direct, we can identify foramen Monroe following the plexus choroid, and then identify thalamostriate straight vein, infundibulum, recess, intibular hypophyseal recess, infundibulum, and then sometime if the base of third ventricle translucent, we can identify the basilar complex. Curvilinear incision, cruciate dura opening, always prepare periosteal flap, because sometime it can leak to the burhole and then leak to subgaleal, the subgaleal space, the liquor cerebrospinal. And this is what we did in Sanglah Hospital. We prepare this plexus choroid, thalamostriate vein, and then go direct there. This we identify infundibulum recess here, hypophyseal, and stop a bit. And I do monopolar fenestration at the mid part between clinoid and basilar complex. We did monopolar and then dilated by 3 franc Forgati catheter. You pull it slowly, otherwise you can torn this vessel. It can make disaster slow. Yeah, after that, we should expect, what to inspect the penetrate base of third ventricle, because what we can identify, there is sometimes you can see the stalk and liquid membrane. This is a basilar artery, basilar complex there, and pulsation of the base of third ventricle. You can doing a little bit, one small to dilate it, slow. Yeah, then withdraw. After that, you withdraw the scope slowly and inspect, is there any bleeding or not. That's enough. be careful. If you have difficulty to identify foramen module, you just follow plexus choroid. You can very easy identify foramen module and go. There's bleeding. Sometimes if there's bleeding, you just watch. It will stop bleeding like that. You watch, and then for a moment, it will stop spontaneously. So always remember to inspect what happened there. Sometimes the operation not going smooth. For this case, for example, it's very clear and they go everything identified. It's very good candidate for ETP, and we're doing penetration and open it. And after this, the blood come there. Yeah. So it cannot, by washing, it cannot stop the bleeding. So in this case, we should quarter it, stop it by quarter. It's better you have bipolar catheter. We do monopolar. It cannot, doesn't work. And we do the second time. We repeat again. Then the literature said the bleeding like that, you can wait. Yeah, washing with the, what we see, sometimes with saline, normal saline. Now the bleeding is stopped, clean. For multi-septa hydrocephalus, we're doing the same way with ETP to connecting all septa, become communication. So we have only doing one PP SAN or ETP. For this case, always inspect before you withdraw the scope. It look like good result, but when we go in, there is a very thick liquid membrane. You should lyse properly this liquid membrane. Sometimes there is blocking due to part of the brain when we introduce the scope come in. So you just wash it with saline, it will be clean like that. This is the ideal spot for penetration. This midway between the complex, bacillar complex and sella, tuberculum sella complex. This midway is very simple there. Or if you think the distance between the tuberculum, cilia, and bacillar complex very narrow, you just direct the scope as near as possible to the clinoid. It will shift. There's a variation when we doing endoscopic, more variation, but make sure that you just follow the plexus choroid in case of very difficult to identify the foramen module. So variation anatomy like this, plexus choroid like that, sometimes like that, and this very complex structure. Just go in fundibulum, you can come in and you will identify in fundibular recess and just doing like that. In my experience, after doing 5 to 10, we will be very familiar with the ventricular system. The floor of the third ventricle must be thin, very good candidate, and translucent enough to permit visualization of the bacillar artery and mammillary body. 4 to 5 millimeter opening is big enough. After penetrating the floor, check the vessel and liquid membrane. Maybe excessive stretch to the floor of third ventricle that I said before can damage nearby basilar artery perforator or the hypothalamus, creating sometimes bleeding disease and so on. Possible ETP complication like this. In my series, I have a complication just for what leakage of the liquor from the incision site and bleeding, mild until severe, one dead. In my cases, difficulty to identify impossibility for ETP, 4.3%, due to difficulty to identify the third ventricle floor, narrowing of third ventricle system. So I cannot introduce the scope because too small. Vascular anomaly, there is ETP for congenital hydrocephalus. My first research, age between 1 to 72 months, Ivan ratio like that, follow up 6 months to 3 years. Successful rate is 91%. Not respond to ETP, 8.4. Not respond to ETP. When did we say not respond to ETP? You cannot say after less than 7 days. So you say after 7 days because what? For obstructed hydrocephalus, we need at least 4 to 7 days, to open subarachnoid to the absorption system. So after 2 or 3 times lumbar puncture can buffer the excess liquor cerebrospinal to extradural and the lumbal area. Besides that, you can get more free flow from the third ventricle to subarachnoid space. And after 2 and 3 times lumbal puncture, if it doesn't work clinically, you cannot identify any progression, you should change to PB-SAM. Be careful of bulging of the incision site. In my experience, bulging at the incision site, that good prognosis, because at least there is communication between the ventricle to subarachnoid space. And second, as long as there is no leakage you can avoid by you structure the galea watertight, and then the skin closer not penetrate the galea. So you can avoid leakage at the operating site, maybe 100%. Early complication, mild hemorrhage, always well controlled with washing or coagulation. Subdural hemorrhage, one of my cases, death of uncontrolled bleeding. We have this one. Advantage of ETP, high successful rate without any implant device, avoid open drainage, lower infection rate, very low. The conclusion, the endoscopic approach must be considered the first choice treatment of obstructive hydrocephalus and in the most of the communicating hydrocephalus. It permits permanent recovery in most of hydrocephalus patients. In some cases, it's possible to remove the cause of the hydrocephalus pathology with cause and symptom. In other case, permit to make tumoral biopsy. The lower total percentage of complication permit to apply this procedure in almost all types of hydrocephalus, leaving the sun only for the cases that not respond to endoscopy. Thank you for not putting sun in my head. He smiled, and the doctors also smile for this. Matur suksmo. There is a Balinese word for thank you. Thank you, Mr. Chairman.
Thank you very much. Thank you, Sri Mariawan. Yes, very nice presentation and very good opportunity to hear such a lecture. And I think also the educational values. Yes.
Thank you.
Yes.
Thank you.
So we move to the next speaker.
Sorry, sir. Prof. Rohadi is out for the moment. For the next lecture is from Prof. Asmi Alias from Malaysia.
Okay. Dr. Asmi Elias, are you ready?
Yeah, ready.
Yeah, you share your slide first.
So can I start now?
Yeah, you can start now.
Okay, thank you very much.
No. I just introduce you, Asmi Elias.
Yeah.
Everybody know you. Most in Indonesia, everybody know you, Asmi Elias. Thank you, come again. Thank you for your participation. Yeah, just start, okay?
Okay, thank you very much. Thank you, Prof. Sri Malawan. I enjoy my time in one of the meetings recently in Bali. So congratulations to Prof. Rohadi Abu Faiz for taking this challenge to organize the second International Virtual Conference of ACNS. And today I will talk about the endoscopic treatment of intraventricular tumor. And endoscopic neurosurgical procedure can be divided into three. One is endoscopic neurosurgery itself, or people say that pure endoscopy or channel endoscopy, where you use everything through the working channel of the endoscope itself. So for example, like ETV and what I'm going to present today. And sometimes you can use endoscope to assist. You use microscope as a primary tools, and you assist when you see at the corner using your endoscope. That is endoscopy assisted. Or you can use endoscope itself as a primary visualization tools, for example, in endonasal surgery, and your equipment are working parallel to that. So today I will focus on all technique that to remove tumor and cyst in the ventricle system using a channel or pure endoscopic technique. And you can use endoscope in the brain for various reasons. Diagnosis, you can take a biopsy, you can remove a tumor. Therapeutic, you can do ETV, release the CSF, excise the lesion, and you can use a lot of indication in CSF pathway obstruction. And sometimes you can use endoscope to guide the placement of your shunt. And I have cases where I use to remove foreign body like gunshot wound in the brain using endoscope, because endoscope need a space. Endoscopy means looking in the cavity. So the cavity must be larger than the endoscope, and the cavity in front of the endoscope must be larger enough to allow your equipment to go, because if it is too small, then your equipment, for example, your scissor will not be able to open within the channel. So you need to know. And the problem with the endoscope, you can only see what is in front. So you go through, you're so excited to see what is in front, you forget about the back. Yeah. Sometimes you looking at the target, as you move, you cut so many structures, including the brain, and sometimes you destroy your foramen or monroe. This is very important for you to understand that how does endoscope work. Okay, so you need a space. So there are potential space in the brain. One is the preformed space, like your ventricle, subaural space, subdural. And when it is expanded by disease, for example, hydrocephalus, then you got a very nice space and place to work that you can maneuver it. So this is a basic for beginners, because I see the list a lot of young, I think trainees maybe. For experienced one, this is maybe very basic to you, but this is important. For you to do any cranial endoscopy, you need to do your landmark. So you usually for ETV, so I just use a coronal suture, I feel it. Yeah, you can use the measurement like showing in that. And then I use a pre-coronal burr hole. Yeah, so that is at mid-papillary line. That is just good enough for ETV. But in a big hydrocephalus, usually quite easy. But very narrow ventricle, this is quite a good landmark. Then I usually make a linear incision. Okay, in most of the cases, I only make a flap for selected cases if I want to put Omaya reservoir at the end of the surgery, or I want to open the dura in concentric shape. Maybe the brain is not enough, so my CSF, so I have to stitch. So I do a flap. Yeah, but most of the time, linear incision, infiltration just on the dermis and the subcutaneous, and I make a peritoneal flap like that, and I flap it either right or left. It doesn't matter. Yeah. Okay. But for a lesion that more you need angle, you want to see contralateral, you want to do septum pellucidotomy, for example, like colloid cyst, yeah? Because colloid cyst is not only in the third ventricle, but also on the opposite side of the third ventricle. So sometimes you need to do that. And I do my burr slightly on the lateral part, which is at the outer canter of the eye. It depends on the type of the cyst, yeah? So then you can go parallel to that. Sometimes you can do contralateral approach to get into the thalamic through the foramen Monro. Okay, so this is a summary of basic incision. I like to use to draw this cartoon strip incision, and this is coronal suture, and then pre-coronal burr hole, yeah, and then flap raise, and then make a burr hole. Usually, if I need big craniotomy, I will do like that. Otherwise, I just use perforator. I collect the bone dust. And then I cover that area with sandwich of Sagittarian gel form, and I put the bone dust on top of it and put back the flap, and I stitch. I put a few anchor stitch to hold it. Yeah, so like that. Sometimes I put EVD for selected cases, for example, tumor that bleed during surgery, or you can see a lot of blood product. So you want to control the CSF, I put EVD. So this is a 6 weeks follow up with the technique that if you use a bone dust on top, and below that is sandwich of gel form and Surgicel. Okay, so now the first case, CSF prober production by correct plexus papilloma. So you can use two techniques. Microscope, some people say it's very easy. You go straight, bipolar, finish. Yeah, but can we do it with endoscope? Yes, but for endoscope, you have to think. If you go straight here, you're going to see a tumor. And then for pure endoscopy, it's very difficult for you to handle correct plexus cyst tumor because it's bleed. So you need to tackle the pedicle, yeah? So you have to come from in front. So I make a burr hole and I come from in front. I focus on the pedicle. So you have to cauterize because the pedicle is from the correct plexus. They have artery and vein, yeah? So this is a 3-year-old girl, walking imbalance, vomiting, and went to another center with Pishandan, but complicated by severe abdominal distension, and patient had difficulty in breathing because too much of CSF and the abdomen cannot absorb. So you can see here, so I put an endoscope and then find the target. Monro is a landmark. Look for obvious landmark. Septal vein, thalamus-striate vein, follow the correct plexus, and you start to see a very ugly a tumor here, down here. Yeah, okay. So then we start to use bipolar. So when you use bipolar, always make sure that the tip of the bipolar always seen. Yeah, you cannot burn blindly, because you may burn structure beyond it. So once completely cauterized, then only I cut, then I take the tumor out, grabs and pull together with the endoscope, because impossible for you to grab the tumor and take out through the working channel, which is only 1.4 millimeter. It's going to be stuck. So you hold it and take together with the endoscope. Okay, so now second example, multiple tumor. This child has a synchronous tumor. Okay, actually HPE came back as pilocytic astrocytoma. So you can see one tumor in the thalamus. You got mural nodule and cystic component, and another one actually on the anterior aspect of the third ventricle. And you can see here. So what we do, we use endoscope. We come from contralateral, this direction, so that I got direct contact to the mural nodule, because I'm going to excise this mural nodule. If I come from here, I have to go through the thalamus, and very difficult. I have to push the thalamus, so there will be damage. So we go transventricular, Monro, go to the cyst, and in this case, I use navigation. So you can mount your navigation through your endoscope. This is Minok from Ascolab. So you can register using a certain technique. And then with that, you can slightly have some idea that where your endoscope position is. Of course, there will be a shift, yeah, because when you put ventriculostomy, the brain moves, yeah. But at least you have some idea, yeah. But make sure that you simulate first before you do ventriculostomy. Once you do ventriculostomy, there will be a significant shift. So at least you have a rough idea where to move, how much, and the target, yeah. Then you do ventriculostomy, you insert your endoscope, and then we proceed with attacking the cystic neuronodule. Yeah? This is a neuronodule. You have to do burn, cauterize, and remove the tumor piecemeal, bit by bit. Yeah? We cannot use QSA because Minok working channel is small. So there is in market, I think by Zoring, but you need to use GAP endoscope. We don't have GAP endoscope. So we have to cauterize biopsy. Cauterize biopsy. It's a little bit like tidy, a meticulous procedure because every time you biopsy, it's going to be bleed. And then this is underwater surgery. So every time bleed, everything red. Then you have to wait, you have to irrigate. So you have to be very patient if you really want to do endoscope for such tumor. ETV, cyst may be quite a different challenge, but tumor is a different challenge because sometimes it can bleed. So always cauterize, look at the feeder, and then only remove in piecemeal. So once we remove the neuronodule, we withdraw our endoscope and we look at the implant and we found the second tumor. And this one quite easy to remove. Just cauterize, similar technique, and we remove with coagulation. This is actually the scan of the previous patient post-op. Okay. All right. Now we go to ETV biopsy in pineal region tumor. This is a very good indication where you can avoid VP shunt, where you can avoid multiple procedure, including open surgery. Because quite significant numbers of pineal region tumor, they can be radio and chemosensitive. Yeah. So how do I decide whether I can do a simultaneous ETV and biopsy? Based on my few first experience, I will look at the tumor on coronal view. If the tumor encroaching the interthalamic mass, yeah. So means you can use your pre-coronal borehole. You can do ETV and then you can do biopsy. Because ideally, if the tumor go very backward, at the back, you need to do ETV and you have to go backward. You need two borehole. Yeah. So, but you can do, this is a typical technique, two borehole. But what I do is I do single borehole pre-coronal, make it elongated or undermined, so that I can go there and I can rotate my scope to look at the back of the pineal region. So in the first few cases, we mount it on our navigation because we have navigation. We maximize the utilization of it just to have rough idea. But once you experience, you can move on without navigation. Yeah. So this is example. I do ETV first, okay, because we want to treat the hydrocephalus, and then I rotate the endoscope. Can you see the view of the scope is changed because you have to rotate and then you have to cauterize it. Some tumor beyond interthalamic, easy. But some tumor behind the interthalamic mass. So you got to stretch a little bit of your Monroe, cauterize, biopsy. And during office hour in our hospital, we will contact our pathologist to stand by. We send frozen section. This is just to make sure that we get the histological tissue. And then if they say, yes, they found a tumor, we take a few other assessment, then we stop. And if especially the tumor came back radio chemosensitive, finish. Okay, don't do further because you're not going to remove everything. So then before you close, you go back to your edge stoma, you do again, you repeat the procedure, look at it. Sometimes there's a blood clot that can cause closure of the stoma after ETB. So you don't need shunt. Most of the cases, we don't even put EVD or Omaya post-op. So this is one example, pineoblastoma in 6-year-old girl. So just to show you the technique, yeah. So this is another case that we can stretch. You can see here, this is ETV, then no way that we can see the tumor. But you have to be very careful. This is septal vein, a thalamostrial vein, quite small, sometimes can be very big. So we use the scope, slightly we stretch over a period of time. Don't overstretch. Then you go like that, rotate 90 degrees, and then you go down. And you must remember as you rotate, your biopsy, everything in front. Yeah. So then you can start to see the tumor and you can do biopsy. This is 3 weeks after biopsy, and this is after 6 months after ETB biopsy, chemoradiation, the aqueduct reopened. You can see clearly, yeah. And then the ETB pathway also widely open. Yeah? So sometimes you can have supracellular lesion, but you can see here, we think that it's good to do ETB biopsy. Yeah, beta ECG alpha pito is mandatory, but it's normal. Then it could be germ cell tumor, turn out to be geminoma. Again, we mount our endoscope just to familiar the system. But in this case, actually, not really indication. But since we want our trainees to learn, yeah, how to use navigation using endoscope technique. You can see here a lot of tumor seedling. Yeah, this is quite easy. You don't have to biopsy behind. You can just even biopsy on the tumor seedling and frozen section and turn out to be geminoma and very good chemoradiation. Strip incision. Okay, another pineal region tumor. This is actually pineoblastoma. They did a shunt infected, HPE inconclusive. Yeah, and then the shunt patient deteriorated, remove shunt, put EBD. So they sent to us. So we blood clot, okay, and then you can see a lot of adhesion. The Monroe is blocked by a lot of adhesive tissue. So you have to clean it. You have to do adhesiolysis, yeah, and then only we get down there. We take a biopsy on the supracellular area and also on the mother itself, right, on the pineal region tumor. So it's cannot to be pineoblastoma and of course followed by chemoradiation for these cases, yeah. Okay, so you can, this patient also have craniospinal radiation because he got CSF, seedling. Actually, he got quite a long segment, extradural tumor. So we went in, do laminectomy and remove the tumor. Yeah. So this is a postulated ventricle, similar technique, single hole, rotate, then we can do a biopsy for such a case as well using ETB and simultaneous biopsy. Yeah. So this is just summary of the cases. So this is a very unique case. Initially, we thought intraventricular cyst, but we went in, okay, and then you can see here. So it looks like cyst. We sent a biopsy. They say columnar epithelial cells. They couldn't make any other histological confirmation. So we treat it as arachnoid cyst. Yeah? So, but over a period of 5 years, the lesion grow back, but the child remained okay. But we a bit concerned. So we went in again. We do strip. We prepare in the worst case, and we find out to be actually teratoma. You can see hair and then sebaceous material. Then we have to convert to open cranial surgery, and we change the incision like omega instead of just a flap like that. And then we take out the tumor using a microscope technique. Okay, big tumor. Can we do endoscope, pure endoscopy? Very difficult. For this case, we use it to assist the tumor and the condition. So we made a strip incision like this, small craniotomy, 3 x 2 centimeter. We raise the flap of the pericranial fascia, put under microscope. We make incision on the arachnoid, go in between the sulcus, and then we put our endoscope just to see how the tumor looks like. You can see a very ugly vascular tumor that impossible for pure endoscopic technique to remove it because it will take very, very long time. Burn, cauterize, biopsy, burn, cauterize, repeat the same procedure is impossible using a pure technique. So we convert back to microscope, yeah. So and then we complete the surgical technique and removal using a standard technique. Then later we put back our endoscope to make sure that the CSF is clear, no blood clot, and we irrigate the area, yeah, to minimize complication. So now we go to cyst. This is a prepontine arachnoid cyst. You can see very bad brainstem compression. We can go from above. So same like ETB, you go to the Monroe, and then as we enter that, you can start to see a cyst is bulging up. Yeah. So we do cauterization because arachnoid cyst, you have to do partial excision. Yeah? So then we grab it and we cut. So we remove part of the dome of the cyst. And then we get into the cyst. You can see this is like a valve effect. And the CSF go in but cannot go out. This is oculomotor nerve. then you have to make another perforation down there. In fact, the cyst go down to C4. This is down to C4. So you do cystocystinostomy, partial cystectomy, remove part of the arachnoid cyst, and cystocystinostomy, so that it becomes like a continuous pathway. Even the CSF go in can always go out. It won't trap. And then the patient improve very much, and the brainstem go back to this original place. Yeah. Okay. Now I think. Okay. Sorry, I go back. Okay. Sometimes patient may have post-infective hydrocephalus. This is the case, hydrocephalus secondary to meningitis. So when healing the process, especially in children, so they form a membrane. So this membrane will cover the child, cover the shunt. So the child actually survive on one tiny hole on the shunt because the addition block it. So in this particular case, so we have to go in and then we make a few perforation and we use scissor to cut it. And then similarly, this is like partial excision of the arachnoid cyst. Yeah, you use scissor and subsequently we release the addition from the shunt, and then we put a new shunt because in this case the obstruction is not only on the trap arachnoid cyst, but also he has other issues because it's post-infective. So just pure endoscopic technique will not solve the problem. So he still need a shunt. So we remove that shunt, we put a new one immediately after we partially excise. Compartmentalized hydrocephalus, you can simplify, put one shunt and communicate the area. Okay, the final one, I will talk about choroid cyst. So this is another good example. You can use endoscope, 43-year-old lady, and children also can happen. So what we do, we put the incision slightly on the lateral canter, go in, and the important thing, first you must cauterize the choroid plexus because choroid cyst is wrapped by the choroid plexus. So you have to cauterize it. And number two, make sure that it does not spill into the ventricle because it can cause obstruction to the ventricle. And then the third one, you have to aspirate the content. So in this case, we use infant feeding catheter. We cut slant like a sharp. We make a small perforation using the bipolar, and we insert the catheter direct into the hole. We aspirate just to prevent that. Because this content, the colloidal material, can block the CSF after surgery. And we have cases where colloidal material cause aseptic meningitis. So, and then the patient deteriorate. We just empirically give rosapine. We do not know how does it work. And then in choroid cyst, somehow it works. So, so you try to avoid that. And when you pull, remember the choroid plexus in the opposite side is holding it. So you must cauterize the pedicle, cut, and then grab and take out the cyst together. And in the process, make sure that you do not damage the fornix. This is very important. Sometimes the cyst can be quite easy to remove one piece. Okay, but sometimes you have to do septum pellucidotomy. So this patient, the cyst was very solid. Right? We aspirate, we puncture, it cannot work. So we do septum pellucidotomy. We push it from here, goes and pull back from the ipsilateral Monroe, and using the same technique, and it come out one piece. But make sure that the fornix does not damage, and make sure that your choroid plexus all under control. So this is actually come out one piece, but very hard. Choroid cyst. If you not careful enough, bilateral fornicial injury will cause permanent acute memory loss. So that is my end of presentation. Thank you very much.
Thank you, Professor Alias. Can you continue the second or rest? The second.
I think, can I rest short while?
You continue. It's okay according to the schedule. Okay.
Okay,
You continue the second presentation according to the schedule. Yeah, you are on time. Thank you.
Okay.
Let's share your first slide.
All right. Thank you. So I share.
Anyway, thank you for very great presentation and very informative. Good for us all.
Okay. Where is my cursor? Okay. Oh, sorry. It's gonna be Lavash. Okay. All right. Okay, can you see?
Yeah, very good.
All right. Okay.
That's
Let's
fine.
take. Okay, thank you very much. So you tell me when should I stop. Sometimes it can be overshoot. So my second topic is about intraventricular lavage, or I call it IVAL. So for infective hydrocephalus and intraventricular hemorrhage. Yeah. So this is a concept that probably some already familiar, but some may be not familiar. So that I would like to introduce. So IVAL refer to combination of direct neuroendoscopic technique. You see, you aspirate, and you irrigate. Okay, so you see, you aspirate means you remove the infected material direct from the ventricle. So in the early years, so when you have infective pyogenic ventriculitis, what we used to do, we put an EVD and we wait, and no way that the pus will voluntarily climb out through the catheter and move, especially a lot of pus inside. No way. So the solution for pollution is dilution. You have to irrigate. You have to replace the infected CSF with a new one. Okay, that will prevent further damage. That will accelerate recovery for the patient. So this is IVAL. Yeah. So cleaning out the content of ventricle and replace the affected CSF. Okay. So the idea come actually, you start with a problem. So when I came back from, I think, Germany Mine, where I got the opportunity to watch the prototype of exoscope as Sapanesky received the Olympus exoscope in Mine. So it's very nice. I enjoyed very much Watanabe lecture. I wish that I can have the equipment, but until now, we have no opportunity to buy it. Anyway, so when I came back, we found that our infection rate in Shan very high. Yeah, almost every 1 in 3 or 4 patients will come back with infection. So this is very sad. So we decided to do a prospective analysis to look at our Shan survival in children, less than 12 years old. So interestingly, we found that almost only 60% survive over 12 months, and the rest have some problem. And to our surprise, our infection rate was very high. About 23 cases are infected. So means as a national reference center, and our infection rate is very bad. So this is very bad to start with. So we think that something needs to be done. And the mortality also from severe infection was high. So one of the problem was pyogenic ventriculitis. Because we received quite numbers of complicated cases, because sometimes straightforward case, people will manage. Not straightforward case, difficult one, they will send to you. So you have all big problem. So one of the problems is pyogenic ventriculitis. It's a rare complication of severe intracranial infection, and it has a potential life-threatening. And mortality rate very high, especially gram-negative like E. coli and so on. So therefore, we need early diagnosis and aggressive treatment. So this is an example of 6-month baby, hydrocephalus, secondary to prematurity IVH, and she came back with infected shunt. Can you see? Ascending infection. Okay, shunt was removed immediately as emergency, externalized with EVD, antibiotic started. So we wait for a couple of days, and then we get a CT contrast. So typically, so when you have that, okay, you have to have some diagnostic imaging before you go in, because there are a few things that you need to know. You cannot just simply go in with the endoscope without knowing what you are going to face. So usually, number one, I will select cases also, make sure ventricle dilated, ependymal enhanced, and you can see sediment down there. So this is typical pyogenic ventriculitis, and this is one of the cases that we lost. Actually, we opened with microscope, and then patient had severe infection and died finally, because you can see pus come out after craniotomy. So this is a classic CT scan finding, all right? And then of course supported by your biochemical analysis, elevated ESR, and then quite important to get the culture and sensitivity. So remember, feeding catheter in cholexis we cut slant, but for lavage we cut straight. So I like to use infant feeding catheter because number one is translucent. You see what is the content that you suck. Number 2, there is a blue line or green line tag that you know the depth inside that you know how much you went in. That you can see here, this is a blue tag, this is pass, aspirated, you know. And number 2, so this is a lot of water we use. We use actually Harman solution warm at body temperature, minimum 6 liter. Yeah, so sometimes we can use up to 24 bottles. Usually about 3 or 4 liter, but sometimes up to 24 bottles. And the range of time can be very short, by at least 1 or 2 hours, because you have to replace the CSF in a timely manner, and sometimes can be very long. We have cases where you drag until 3 to 4 hours just to irrigate, to make sure we try to remove the debris as much as possible. So you see, this is actually we cut slant for cholexis, but we cut straight. This is available in the pediatric ward, the infant feeding catheter, very cheap. So now first we get into the ventricle, do not irrigate, okay? Because once you irrigate, and everything will fly away. You cannot aspirate the pus under direct target. So then you go close to it. As you must remember, as you go deep, as you go deeper and deeper, your ventricle will start to collapse and collapse. Yeah, and then you lost space. Yeah. So you must try to remove all this sediment as much as possible. You can see just now when we enter, everything looks quite yellow, very proteinaceous. Yeah. And then once we have find the big component and we start to irrigate, so we force irrigation so that whichever stuck at the bottom, we fly over and then we take out, or we make sure that irrigation out. Yeah? And then you can see here interthalamic mass, and we stretch a little bit of Monroe, and you can see the aqueduct. Now aqueduct is open. If you just leave the pus there, no way that the pus can voluntarily out. You give intrathecal antibiotic, it doesn't work. Antibiotic kill the organism, maybe, but it doesn't remove the slough. Yeah, so the slough will be there and take its course, which is further infection, empyema, pus, septate, addition, the brain loss compliance because very stiff, yeah, following infection. Now you can see it's much better. So you try to remove as much as possible, but very careful. In acute setting, sometimes the epidermis is still inflamed. You over aspirate, it bleeds, then you got IVH back to square. Yeah. So this is the immediate post-op. Okay, an example. So this is underwater. But if you use microscope, you use dry technique, air. But endoscope need underwater. You cannot irrigate in the air because the scope will be fogging. You cannot see. So we use a gravity feed irrigation, put on the drip stand, put it higher, so you gravitate down and push. We use 3-way syringe, suction, irrigation, and sweeping, grasping technique we will show shortly. And this is a lot of water we use. Make sure that you have a pocket of collectant so that it doesn't spill over the patient. Otherwise, patient may have hypothermia because of if the fluid leak and wet and the draping, then the patient become hypothermia. So you have to be very careful. Maybe you, if you have money, you use non-resorbable or non-penetrable or water impermeable draping. Yeah? Okay. So in our initial experience, we use one side, ipsilateral, and we do septum pellucidotomy, and we also use foramen Monroe to clear the third ventricle. But we found that there are a pocket of pus which you cannot see. Yeah, if you try to see, actually, even you do septum pellucidotomy, you push, you will damage the fornix and the mammary tract. Yeah? So we found that fail if you do one side. So we convert that based on first case, and then we have to go in again to complete the second one. So from then on, we always do bilateral because you got a very nice target, because you got to remove, if possible, all slough. Adhesive slough you don't touch because it's something can be very problem. So this is what we describe as fish biting. The fish like to bite like ikan. I don't know what you call it, ikan betuk. You got it in the paddy field. They will bite like that. So using that technique, so you can see I introduce my sucker. Yeah, and I control the suction. I myself control that. If too much suction, it will aspirate the epidermis, it's going to be bleed. Too deep, it will damage. Too short, it will aspirate the content, the ventricle collapse. Yeah, so you have to know the timing. And this feeding catheter is quite flexible. You can see that the blue tag and then you start to slowly like a vacuum carpet. You can even sweep it because it is quite not so stiff and not so soft. And careful on the correct presses. You can see now it bleeds from the correct presses. So you have to be very careful when you go to correct presses, because removing that slough on the correct presses will create hemorrhage. So if hemorrhage happen, irrigate, wait. If still bleed, cauterize. Okay, then you see I use tip of endoscope, I use minob. Minob is blunt end. So I go to the ventricle, actually I sweep it. Like you elevate a carpet using part of the endoscope, and then elevate, and I use grasper to remove it. So you can use this grasping technique, or be careful on the raw ependymal area. So it can bleed if you're not careful enough. Some very tiny, this is why you see ependymal enhancement because of this structure. Sometimes you can pull out nicely. If you bite too deep, you're gonna cut. Can you see the difference before and after you do lavage? Okay, so we did a quality improvement project. So first focus on 8 cases, okay, and then a various etiology, mix of gram-positive and gram-negative. The initial outcome was quite good. All patients survived instead of 70% died. And then we completed all cases with 6-week antibiotic. Only 50% shunt dependent, the rest are shunt free. So this is very amazing. If you wait, you're gonna shunt goes abdomen infection. Then you got on and off. We also published chat with in the child nervous system with Professor Jo Pujari. Okay, and we expand our indication, not only for pyogenic ventriculitis, but also for recurrent shunt malfunction, because sometimes your shunt keep blocking because the debris inside there. So you can remove it. Sometimes high proteination material, so you can change the CSF to more clear CSF and then less clogging. You can improve your shunt survival, intraventricular hemorrhage, and sometimes we use post-aneurysm clipping, we lavage for IVH, and sometimes for ventricular lesion. So this is example of a child with recurrent ependymoma. Okay.
Dr. Professor Elias, you have 3 more minutes.
Okay, sure. I will show this last. Okay, this last case. So you can see here a tumor, and then he came with infected shunt. So you can see high proteinaceous material, and then you can start to see yellowish proteinaceous, and then as we go in, we remove this debris, and then later, as we do lavage, you start to see a lot of tumor seedling. Can you see all tumor seedling? So with the endoscope lavage, you can not only improve the infection, but you also can give a prognosis of the patient. The MRI could not detect this. MRI looks very clean. It's all this tiny nodule was not seen on MRI. And of course, we take a biopsy and inform the family that the patient have CSF seedling, prognosis which is not good. So oncology and palliative treatment. Sometimes I think the IVH also using the same technique. Okay, we lavage, and then just to show you post IVH in children, you can see high proteinaceous material. You can see the difference before and after lavage. You see the Monroe was blocked and the Monroe much more relaxed. And this is why you got stiff ventricle, sleep ventricle syndrome, because post-infection, post-hemorrhage, it healed, but it make the ventricle very stiff. So you can see before and after. So this is just doing lavage alone, without doing anything. Okay, so with that, I end my presentation. Thank you very much.
Thank you, Bapak Elias. It's very interesting and very good and very informative lectures. Workshop also, we enjoy it very much.
Thank you,
now we come to the next speaker. It would be Professor Takeuchi from Japan. Basic technical for endoscopic cylinder surgery. Please stop sharing, Dr. Elias, and then let the next speaker to share his. Professor Nagatami will chair the next session after this.
Good morning, everyone. I'm Dr. Takeuchi, Nagoya University, Japan. Today's my topic is basic technique for endoscopic cylinder surgery. Surgical treatment for the deep-seated lesion is still challenging. Surgeons should pay attention not to damage the normal brain during removal procedure. So the various kind of brain retractor was invented and used for this region. This is a review study published last year. In this article, tubular retractor was also listed here. In this article, tubular retractor is introduced as the most successful retractor. While retraction pressure is applied in one direction in the normal spatula, the tubular retractor can distribute the pressure evenly, thus preventing retraction injury. The use of tubular retractor in neurosurgery is invented by Professor Kelly. He used a strategic maneuver for insertion of the tube, and a microscope was used for visualization. There have been several reports of the use of cylinders since then. This is the report of the endoscopic use in tubular retractor. Professor Kasan used 11.5 diameter translucent cylinder in this surgery. They used the navigation guidance instead of stereotactic frame. This followed by the development of specialized transparent cylinders. After this, many endoscopic cylinder surgery have been reported. Last year, 2 review articles on cylinder surgery were reported. One is a 13 mm cylinder named Brainpass, and the other is an oval-shaped cylinder named Bucite. It is considered to be mainly for deep-seated regions, and removal rate and complication rate are comparable to those reports using spatula. The advantage of this cylinder is a translucent retractor that can allow us to observe the retracted tissue, and this version of the force can induce the spontaneous hemostasis, and a cylinder can protect the normal brain, so we can reduce the risk of accidental parenchymal damage by insertion or withdrawal of the surgical instruments. In contrast, there is a disadvantage. That is reduced maneuverability. For this reason, most of the cases were treated with exoscope and microscope rather than endoscope included in these studies. In Japan, we use endoscope rather than exoscope or microscope in cylinder surgery. The reason why endoscope are mainly used in Japan is that our cylinder surgery originated from hematoma removal surgery. This is a paper on endoscopic hematoma removal reported by Dr. Nishihara in 2000. Very sensational report of hematoma removal using a 6 mm diameter cylinder. But now it is widely used in Japan. It's very famous. Professor Tambara will show you in later session. I strongly believe that there are many advantages of the endoscopic use in cylinder surgery. Therefore, I will introduce our endoscopic cylinder surgery technique. This is the cylinder I used in my surgery. I mainly use 10 mm or 6 mm diameter cylinder for tumor removal. Firstly, I want to introduce a cylinder insertion. Endoscope tip is calibrated by the navigation system here, like this. And endoscope is inserted into the transparent test-up needle. This one had inner lumen here, so we can insert the endoscope into this tetrad needle. For doing so, we can get a direct viewing of the needle here, and we can also get the location of the endoscope tip with the navigation guidance here. Our removal technique is divided into two: one-hand surgery and two-hand surgery. In one-hand surgery, the endoscope and the suction monopolar are mainly used. The sheath is held by assistant, and the main surgeon holds the endoscope and other instruments. It is possible to change the direction and operation field dynamically by tilting the sheath. It's very good for the hematoma removal or suckable tumor removal, but it's not good for the hemorrhagic tumor or hard tumor. In two-hand surgery, endoscope held by endoscope holder like this one, and surgeon holds the suction and other instruments, so like microscopic surgery. It's very good for the precise dissection, so it's good for the eloquent area tumor or hemorrhagic tumor. But in two-hand surgery, we need a wider space, so the larger diameter sheath is required in this technique. If using the larger diameter sheath, the surgical maneuverability improves, but the surgical corridor becomes large. So it depends on the case. I use the wet field technique as well. Endoscope gives a bright and wider view even underwater. In underwater surgery, we can get wider space after the removal of the tumor. This is dry field. After the injection of the saline, we can get wider space like that. The tumor bed can naturally expand. And in this condition, we can find the hemorrhaging point very easily, like that. And we can coagulate it with a pinpoint coagulation, like this. This is our surgical tools and surgical techniques. This rotating movement is very good for the dissection inside the sheath, and this malleable forceps and malleable bipolar forceps is very good for coagulation or holding the tumor inside the cylinder. And this is a pneumatized endoscope holder. This one or this one is essential for the cylinder surgery. Then let's move to the clinical cases. This 28-year-old female appeared with headache, and MRI revealed the tumor here in frontal lobe. So we insert the cylinder from here. We use a 10 mm diameter cylinder in this case. After the insertion of the cylinder, this tumor had a very clear tumor border here, so we dissect it with open and closing movement of the forceps. The tumor debulking was performed, and then dissecting the deeper side like this. This is the most deeper part, deepest part. We coagulate the feeders like that, and then remove the tumor. Now we encounter the lateral ventricle. the most part of the tumor was removed. After that, the surgical field was filled up with water to confirm the hemostasis and close the arachnoid membrane and close the wound. The skin incision was only 6 centimeter. Post-operative course was uneventful, and no additional neurological symptoms were observed, and the surgical trajectory was minimal here and here. The next case is 27-year-old female. She was suffer from headache and appear with third ventricular tumor here, and the MRI revealed slight hydrocephalus like this. We use a 6 mm diameter sheath, this one, Neuroport Mini. 6 mm diameter cylinder is small enough to insert it into the third ventricle from a Monroe. This is a video. We coagulate the choroid plexus, and this is the anterior septal vein, dissect it and coagulate and cut to dilate foramen Monroe. We insert the cylinder into the third ventricle. The tumor was covered with massa intermediate, so we coagulate the ependyme and dissect the tumor from the surrounding brain with the opening and closing movement of the forceps, like this. The tumor was removed piece by piece fashion. Like this. This rotating movement is very good for dissection. After the dissection, we introduce the tumor into the cylinder like that and remove it. Gross total removal was achieved, and the damage to the foramen Monroe is minimal, like that. This is a post-op MRI. It revealed a very small trajectory injury like this. The next case is a 21-year-old female. She would suffer from left hemiparesis and mild aphasia. The MRI revealed a cystic mass in the frontal lobe, maybe the cavanoma. The cavanoma located in under the primary motor cortex here. So we performed the MRI DTI. Yellow line is pyramidal tract, and green line is SLF. So the cavanoma was surrounded by the very vital fibers like this. This is the surgical trajectory planning. We insert the cylinder through the this sulcus here. This is surgical video. At first, we performed the 2 cm craniotomy, and cortical stimulation was performed, and the motor cortex was here. We dissect the precentral sulcus and insert the cylinder through this sulcus, and this is the bottom of the sulcus. Now we encounter the cavanoma here. At first, we cut the membrane and evacuate the hematoma component inside the cavanoma. Then the cavanoma shrunk, and after that we removed the cavanoma piece by piece fashion, like this. After the debulking of the colonoma, surgical field was filled up with water with a wet field technique. In wet field technique, the colonoma membrane is float up, so we can very easily notice the border of the colonoma here. We remove the colonoma membrane piece by piece fashion by a two hands technique. And this is the last membrane, also removed here. After the removal, we perform the direct subcortical stimulation, and the pyramidal tract was located in this area. This is a venous anomaly. We preserved it, and the damage to the cortex was minimal, like this. Post-op MRI showed the gross total removal, like that, and her symptom was resolved immediately after surgery. And this is a T2 weighted image. We inserted the cylinder through this sulcus, so there is no damage around this sulcus, and the surgical trajectory only this one. This is the final case. 59-year-old male appeared with double vision and left facial palsy. And MRI revealed the carcinoma located in the dorsal surface of the pons here. The tumor was protruded into the fourth ventricle here. We performed the endoscopic cylinder surgery for this case. We insert the cylinder through foramen majandi. 6 mm diameter cylinder is small enough to insert into the foramen majandi. We perform the 2.5 craniotomy here, and dura was incised, V-shape, cerebral tonsil. There is no adhesion between the bilateral cerebral tonsil, and so we can very easily to insert the cylinder to the fourth ventricle. We perform the direct cortical stimulation to confirm the location of facial nerve, and debulking was performed. We perform the dissection with opening and closing movement of the forceps, like this, and remove the carcinoma piece by piece fashion, and sharp and blunt dissection was performed, like that. This is the bottom side. We are very carefully dissected because this is the pons. This is the final part. We cut it and remove it. After the removal of the carcinoma, we confirm the gross total removal with a 30-degree and 70-degree endoscope. The damage to the cerebral tonsil is minimal, like that. Post-operatively, his symptom was resolved, and gross total removal was confirmed, like that, and trajectory damage is minimal, like that. In conclusion, endoscopic cylinder surgery can reduce the risk of trajectory injury. The small diameter cylinder can be inserted into the region through the cerebral sulcus and foramen, Monroe or Majandi. For safe and smooth surgery, specific surgical instruments and techniques are required. So, please attend the hands-on course before you start this surgery. Thank you for your attention.
Thank you, Professor Takeuchi. Yes, so this presentation is done by video. Yes, so we want to go the next speaker. Next speaker is Masao Tambara from Japan, Fukushima. Yes, he'll speak about the endoscopic removal of the cerebral hematome setting and techniques. Yes. Please start and lecture. Okay.
Fukushima Medical University, Japan. Today's my topic is the endoscopic removal of intracerebral hematoma. The efficacy of endoscopic intracerebral hematoma removal is currently controversial, although there are some reports. But however, in our experience, there are often cases that not only life-saving but also show functional improvement. In this presentation, we will introduce our method of endoscopic intracerebral hematoma removal and some of the cases we have performed. When performing endoscopic hematoma removal, hemostasis is often the biggest problem. Therefore, it is necessary to check for any conditions that may cause coagulation abnormalities through blood tests and medical history. It is also important to evaluate the existence of abnormal blood vessels by CT angiogram. Endoscopic surgery requires special instruments different from the conventional craniotomy and microsurgery. In particular, we consider port and coagulation suction tube to be mandatory for surgery. In addition, the surgery for cerebral hemorrhage is an emergency surgery, so we may not be prepared for navigation, but intraoperative ultrasound is very useful to confirm the location of the hematoma. This is disposable transparent port used in endoscopic surgery. It is marketed by a Japanese company. Neuroport regular is mainly used for intracerebral hematoma removal, such as terminal and subcortical hemorrhage. 4 mm and 2.7 mm rigid endoscope can be used. Neuroport Mini is used for endoscopic third ventriculostomy, and interventricular rigid endoscope is also used. The ventricles are narrow, so a smaller port is better. If a larger port is needed, a Bucite is used. Brain pass is not available in Japan. Continuous irrigation can stop bleeding if it is from small vessels. In endoscopic cerebral hematoma removal, one hand holds the endoscope and the other hand holds the suction, so it is not possible to hold the bipolar in one hand. The suction tube in the other hand is as microscopic surgery. Therefore, using a coagulation suction tube makes it possible to perform hemostasis while suctioning. This is a very important tool and is used in the dry field. The coagulation suction tube is coated with an insulation except for the tip, which prevents the endoscope from being charged. If the endoscope is charged, it may shut down, so be careful. Today's cases as below: terminal hemorrhage and interventricular hemorrhage, cerebral hemorrhage, and subcortical hemorrhages. First, I described the surgery for terminal hemorrhage. With the patient is supine position and make a bar hole about 10 or 11 centimeters cranial to the nasal or hairline, and about 3 to 4 centimeters lateral to the lesion. The skin incision should be straight. Use the periosteum here. is flap-shaped, it is easier to close the bar hole. This is a case of terminal hemorrhage. The patient is a 59 years old man presented with aphasia and severe right hemiplegia. The hematoma volume was 33 milliliters and CTA did not show any spot sign. In this surgery, bar hole is first made on the forehead ipsilateral side, the hematoma, and then drilled and enlarged to the size of less than 2 centimeters. At this time, electromagnetic navigation is used. The cross incision is made and make corticotomy like this. With navigation, confirm the position of the hematoma and insert it into this is neuroport regular. And this is actually his hematoma. This hematoma is very soft to evacuate. It's very easy. They're almost clear. And after that, with the continuous irrigation like this. And you can see here the perforator, and we can confirm the hemostasis and there is no residual hematoma. After that, we back to the dry field and insert the cell here, hematoma cavity, and put off this and suture the dry matter and put on the Duragene or clogging sponge, and then fill the bar hole with bone cement. This is a post-operative CT scan. The hematoma was removed without any problem. The right hemiplegia has improved and the patient can walk. If the pyramidal tract is only compressed, hematoma removal will improve the hemiplegia. This is a high-weight case, and the patient is a 57 years old man who was transported to the emergency room with disturbance of consciousness. He presented with interventricular hematoma from right-coded graves. In this case, we will perform a right anterior horn puncture to remove the interventricular hematoma under endoscopic techniques. The goal is to remove the hematoma from the right anterior horn to the third ventricle and the entrance of the aqueduct, and to place a ventricular drain tube after the hematoma removal. This is a case where ventricular drain may be needed bilaterally if endoscopic hematoma removal is not performed. As the puncture is made in the right forehead, ventricular puncture is performed with standing needle from cohort point along the tract of the anterior horn puncture. Neuropotomy is inserted into the anterior horn of the right ventricle and endoscopic observation like this. The first hematoma in the right anterior horn is aspirated and removed until the foramen of Monroe becomes visible under the observation of the rigid endoscope. Then flexible endoscope is inserted like this. Hematoma in the third ventricle is directly aspirated out through the channel of the flexible endoscope. After that, we can see that clearly in the ventricle. This is the ventricle floor. And mammary body is here, and this is aqueduct. The aqueduct is very clear, and this is breathing point. Let's just stop the breathing. And this case is a blowout septum like this, and we press a ventricular drain like this. This is a postoperative CT scan. In this case, the EVD was removed on the postoperative day, and there was no evidence of hydrocephalus depth. Next, I will talk about cerebral hemorrhage. The patient should be positioned in a semi-lateral position with the head fixed in a horseshoe headrest, so that it faces approximately 90 degrees to the contralateral side. If the surgeon is not comfortable with this position, the head may be fixed with a head pin, or the patient may be placed in a prone position. The puncture site should be below the transverse sinus, approximately at the midpoint of the inion to asterion. After dural incision, intraoperative ultrasound is used to confirm the direction of the hematoma. If the fourth ventricle is filled with hematoma, the hematoma should be removed as well. The patient is 83 years old woman. Although she was elderly, she underwent surgery because her pre-onset LDL was good and her symptoms were expected to worsen due to the large amount of hematoma. The patient is placed in the right lower semi-lateral position with the head turned 90 degrees to the left and the chin slightly down, and the head is fixed. The occipital area has thick skin, so skin incision and the perforator can easily to be safety, so care must be taken. After making burr hole, you should check with intraoperative ultrasound to see if there is a hematoma directly under the burr hole. As long as the burr hole is correct, the hematoma removal itself is very easy, like this. Very easy to remove, like this. And we make a hemostasis using the coagulation, like this. Very easy. The coagulation suction is used in a dry field. In the wet field, we cannot use the coagulation. Confirm the hemostasis and put the cycle. final view. This is postoperative images. The hematoma was removed without any problems, and in this case, the hematoma in the fourth ventricle was not clear. The barhole is about in the middle of the ilion and mastoid tip, like this. Subcortical hemorrhage is very easy to insert the port because hematoma is extremely superficial. However, in young patients, hemorrhage may be caused by vascular abnormalities such as severe arteriovenous malformation or moya-moya disease, and preoperative CT angiogram is mandatory. In such cases, hematoma removal is basically performed with the aim of lowering ICP. This case is a 50 years old woman who was sent to the emergency room with sudden impairment of consciousness, aphasia, and right hemiplasia. A head CT scan was taken less than an hour after the onset, and the hematoma was still faint, like this. A contrast-enhanced MRI was also taken, which shows a long hematoma occupying the left supratemporal gyrus. There is a contrast effect with the hematoma in the hematoma cavity. It seems to be some kind of abnormal blood vessels. Postoperatively, DSA was performed and there was occlusion of the right middle cerebral artery, which was diagnosed as moya-moya disease. Since the hematoma was subcortical and white matter had been destroyed by the hematoma, we decided to remove it from the posterior temporal lobe. For subcortical hemorrhage, it is necessary to swing the port sufficiently, so we made a small craniotomy. It's like a fountain, very high ICP, so it came out. And we use this time also airport regular. Remove the hematoma is very easy, like the previous cases. And this time we take out some vessels, but it's preserved. And we confirm the prosthesis, the continuous irrigation, and tiny vessels must bleeding stopped. And also insert the sacil and make the hemostasis. The hematoma has been clean removed. Her right hemiplasia was improved, but her aphasia remains, and she is currently undergoing rehabilitation. For endoscopic hematoma removal, it is important to do the preoperative examination. In particular, evaluation by CTA is very important. It is also important to check for coagulation abnormalities and history of drug use. In order to perform the surgery safely, it is important to always be prepared for the transition to craniotomy. Intraoperative ultrasound and, if possible, navigation are also very useful. Thank you.
Thank you for Professor Tambra. So okay, we have a few minutes for the question time, so the discussion time. So yeah.
Professor Nagatani.
Yes.
Question. Two questions from the audience
Mm-hmm.
to Prof. Maliawan and Prof. Azmi Alias.
Prof. Maliawan, you have to unmute.
Okay, thank you. Maybe I will answer the first question, Professor Nagatami.
Yes.
It turned out that ETP has more complication than PP-SUN. ETP is still the best choice. Okay, as I mentioned, that ETP, when I doing a randomized clinical randomized study about ETP and PP-SUN to compare about this, ETP is less complication than PP-SUN. And most of complication just after we did the first 100 ETP. So by the first 100, I mean we are already familiar the variation of ventricle, variation of the liquor drainage system. So in my research, there is ETP is very simple. And if we exclude the preparation and anesthesiology preparation, we can finish completely the ETP in 10 minutes. Very simple. So it's still the best choice for all addressables we can try because low rate of complication, even for good to try when you have normal pressure hydrocephalus, because still good result also. Let me answer to Raiko. Thank you. Prof. Azmi Alias, there is one question for you.
Oh, I think I have two questions.
Oh, yes.
Yeah. I think the first one, what is your opinion and experience about two techniques, wet and dry technique for intraventricular tumor? Okay. As I mentioned in my lecture, there are three types of endoscopic procedure. One is pure endoscopic or channel endoscopic, and the other two is endoscopic assisted and endoscopic control. So if you do pure endoscopic technique, so everything through the working channel, you can only do underwater. Because if you do in open, so the scope will be fogging. So you cannot see and you cannot move. Yeah. So, but if you do endoscopic assisted, mean you make a small opening, you use microscope and then looking at corner and you use all the manipulation, same like microscopic and endoscope to assist you. Yes, best to do under dry technique because microscope cannot see if the water is there. It has to be dry. Yeah. Or you use endoscopic assisted, like you do endonasal. So you put a tube, they call it tube surgery. Endoport, for example, and then you put your scope side and then you put your instrument side. Then you can do dry technique. Yeah. But because each endoscope have different things. So you can do both wet and dry, but depend on which technique that you use, either pure endoscopic or you use the endoscopic assisted or endoscopic control. So I hope that answered the first question. Yeah. Because dry technique is easier to control hemorrhage. Wet technique, everything red, you cannot see. Dry technique, actually the bleeding, when you dry it, actually bleeding is very small. Yeah, but because of underwater, small bleed will make it red. So that is a problem with underwater surgery. So sometimes we convert to dry. We dry it and let it clot, and then we full it the water again. So you can use combination. So that is another trick that I didn't share lah. Okay. How to make ETV if tumor located in third ventricle? So you must remember the third ventricle is like slit and elongated. They got three parts: anterior, middle, and posterior. If you look at by statistic, most of the third ventricular tumor located at the back. Okay, it causes obstructive hydrocephalus, and then ETV you want to do it in front, so no problem. Okay, but even a small tumor located in front, then you cannot do ETV because the pathway of the ETV is in front, unless the tumor actually located at the roof. But if the tumor located at the roof, for example, like choroid cyst, you said block foramen Monro, you do not need ETV because you remove the tumor, it release the Monro. Why you need ETV? So it doesn't make sense to do ETV in choroid cyst, in my opinion. So if big tumor located anterior along the pathway of your ETV, yes, you have to do shunt. You cannot do ETV. So you need to know the location and exactly the size. Size maybe not matter if the location is free from the target for you to do ETV. Septum phalangostomy, yes, sometimes you want to communicate both sides. For example, patient you want to shunt one side and then you divert it, or the tumor block one Monro that you cannot remove, then you divert it so that the other Monro can take over. And sometimes you do septum phalangostomy just to look on the opposite side for diagnostic reason. You want to see that side also clear. Yeah. Sometimes you do the septum phalangostomy as part of diversion to make sure that the compartment are communicate. So I think I answer your question. But I would like to add on the ETV more complication than BP shunt. I agree with Prof. Sri Mulyawan. Actually, no complication by right. If you do it right and your case selection is good, but you must be trained. Yeah, but nowadays endoscopic ETV actually in my center, all registrars should be able to assist and all specialists must be able to do ETV on their own. Yeah, so it's a basic thing like a BP shunt. Yeah, and ETV has less complication if you do good case selection and appropriate and shortest procedure. We have more shunt complication and more problem. This is completely two different game and procedure to compare in terms of safe or not safe complication. They are different category actually. So I hope I answered that question.
Thank you. I think Professor Nagatami, the time is over for this first session.
Yeah.
Yeah.
So time is over. So we will move to this and the next sessions. Okay.
Sorry, Professor Nagatami. We have 5 speakers, and if you don't mind, I will chair the first 2 speakers. After that, you. Okay.
Okay. Yes.
Okay. Thank you.
Yes.
Yes, for the committee, can I continue the second session?
Yes. Yes.
Okay.
Yes, Professor.
Okay. Please, I invite Dr. Yuichi Nagata. He will speak about clinical anatomy and technical standard for endoscopic endonasal approach. You have 20 minutes. Please share your slide.
Good morning, everyone. I'm Yuichi Nagata from Nagoya University. Today's my topic is clinical anatomy and technical standard for endoscopic and nasal approach. Endoscopic and nasal approach has been a standard surgical treatment for pituitary adenomas. Recently, other paracella regions, for example, craniopharyngiomas and tuberculum cerammeningiomas, are also safely and effectively dissected by extended transsphenoidal approach. But in endoscopic and nasal approach, operative field is quite narrow because surgical maneuver was performed via the narrow nostril, and several critical neurovascular structures exist along the surgical corridor. So, it is necessary to have enough anatomical knowledge in order to perform safe surgery. The most important chip in performing endoscopic and nasal approach is wide sphenoidotomy. To achieve wide sphenoidotomy, the anterior wall of the sphenoid sinus should be fully exposed until the medial aspect of the medial pterygoid plate can be detected here. After the enough exposure of the anterior wall of the sphenoid sinus, it is drilled like this. In this situation, the care must be taken not to injure the septal branch of sphenopalatine arteries. The practical method is shown in the video. The anterior wall of sphenoid sinus is drilled from the natural ostium to the bottom. Septal mucosa should be lateralized by suction to prevent injury of the septal branch of sphenopalatine artery. Then, the top of anterior wall of sphenoid sinus is drilled between the bilateral natural ostium, and it was removed. After the wide sphenoidotomy, anatomical landmarks to be identified in the sphenoid sinus are shown here. That is, pranum sphenoidale, tuberculum sera, sera thoracica, and clivus vertically, and lateral and medial optical carotid recess, optic canal, and IJ prominence. These anatomical landmarks should be identified to make a sufficient surgical corridor and to perform safe surgery. After wide sphenoidotomy, enough surgical corridor to the sphenoid sinus is obtained, and ICG fluorescence reveal bilateral ICA and sinuses. Another important chip to achieve effective tumor removal is enough cell bone removal, that is, Four-Bruce concept reported by Professor Kassam. Four-Bruce comprise the superior and inferior intercavernous sinus and bilateral cavernous sinuses. Enough cell bone removal to detect these four sinuses can offer enough surgical field in tumor resection. There are two important techniques to remove a pituitary adenoma, that is, intracapsular resection and extracapsular resection. Intracapsular resection is a common technique used for non-functional pituitary adenomas. Here, I show an illustrative case. The preoperative MRI showed a pituitary tumor with moderate suprasellar extension. The operative video is shown here. The cella dura was incised like this, and fast tumor debulk was performed. Usually, pituitary adenomas are soft and suckable, so tumor can be removed by suction like this. Tumor removal should be performed to detect anterior pituitary lobe circumferentially. Double suction technique is quite useful in intracapsular resection. Suprasellar part of the tumor was also removed, and total tumor resection was achieved by intracapsular resection technique. The postoperative MRI showed total removal of the tumor. Another important technique to remove pituitary adenoma is extracapsular tumor resection. The pseudocapsule of pituitary tumor pathologically contains small tumor cluster, so postoperative endocrinological remission cannot be achieved by intracapsular tumor resection alone. So, extracapsular tumor resection is quite important technique for functional pituitary adenomas. Here, I show an illustrative case with acromegaly. The preoperative MRI showed a pituitary tumor in Ceratasker. The operative video was shown here. After the dural incision, tumor was debulked and tumor removal was achieved in intracapsular tumor resection technique, like this. After that, the pseudocapsule of the tumor was detected, and it was circumferentially dissected from the adjacent pituitary gland, like this. The pseudocapsule is a soft and thin membranous structure, so be careful not to leave any part of it behind. After the pseudocapsule resection, total removal of tumor was achieved by extracapsular tumor resection technique. The postoperative MRI showed total tumor removal. After tumor resection, cellular reconstruction is a quite important maneuver because postoperative CSF leak is one of the most major complications of endoscopic and nasal approach. Traditionally, autologous tissue graft, including free fat graft and fasciolator, has been the most reliable material for cellular reconstruction. The left video shows an illustrative case of cellular reconstruction with free fat graft. After the tumor resection, free fat graft was plugged in the Ceratasker, and the dura mater was sutured with 6-0-proline double-armed suture, like this. And a knot was tied and tightly cinched with a curette. Watertight closure can be obtained by this technique. Recently, several artificial cellular reconstruction materials become available, and Duragen is one of the most reliable materials for cellular reconstruction. The right video shows an illustrative case of cellular reconstruction with Duragen. After the tumor resection, a piece of Duragen was laid in the Ceratasker as an inlay graft. After that, the dura mater was sutured with 6-0-proline double-armed suture in a similar way, and a knot was tied and tightly cinched with a curette. Then, another piece of Duragen was patched epidurally as an onlay graft, and fibrin glue was applied. Secure cellular reconstruction method is essential for safe endoscopic and nasal surgery. And I'm convinced that dural suturing technique is the most effective technique to prevent postoperative CSF leak. In conclusion, endoscopic and nasal approach is a first-line treatment for cellular and paracellular lesions. However, enough anatomical knowledge, experienced tumor resection technique, and secure cellular reconstruction technique are essential for safe and effective surgery with minimal postoperative morbidities. Thank you.
Thank you. Very interesting topic and very good presentation. Now we come to the second speaker, endonasal extended transpinwid surgery in craniopharyngeal mass. We invite Mr. Tatsuya Nagatami from Japan. Please. The next speaker after this will be chaired by Professor Nagatami. I have a very urgent problem about this. Okay.
Yes. My topics, the first topics is the endonasal approach for craniopharyngium. Okay, yes. Can you hear me? Okay.
Professor.
Yes. Still this tumor is very challenging because of the tight adherence to the surrounding tissues, surrounding structures, and very frequently occur the recurrence. What important issues there is the progress of the endoscope techniques. This approach is very decided advantage to access the inferior aspect of optic nerves. So we are heading this approach to the craniopharyngioma from 2009. So this is our basic concept for the approach selections. So we divided the two. One is the sagittal plane, the second is the coronal plane. The most of the tumor can be treated by the transplanum approach because these tumors are located in the mid portion and the mid. But sometimes we need another or additional approach. So, for example, the tumor extended to the lateral chiasma or third ventricle or posterior fossa. So we need the transdorsum approach, and also the tumor which is extending laterally, lateral extensions. So we need more approach. We prefer to use the combined approach with transplanum and supraorbital keyhole approach. Yes, these are our basic concept for the approach selections. So the firstly, we mentioned the anatomy of the landmarks. This is the view from the entrance of the the sinus. You can see this prominence and recess of these prominence and recesses. Among these, as I want to stress on the most important is the here medial OCR, because this wide line is the opening of the cell floor, and we usually start this point, medial OCR. So this is very important landmark. Next, this is the intradural anatomy. So among these, of course, the SHA suprahypophyseal artery is the most important structures. This artery should be reserved for all cases for craniopharyngium. This is a very, very important structures, important arteries. Yes, this is our basic positioning and setting up. We use the 3-hand techniques with the scope is fixed, mounted on this type of the scope holder, and also the assistant move the endoscope to adjust the very nicely position for the surgeons. So the surgeons never touch the endoscope. This technique is most crucial for our style. Yes. So we use the 4 millimeter endoscope, 0 degrees and 30 degrees. Usually we use the two types of the endoscopes, but sometimes we use 45 degrees and 70 degrees endoscope for sometimes. And also we use now the high vision camera, and we usually use the 2 monitors for the surgeons and the assistant. Yes, and the tools for tools we use the thin and flexible. For the old endoscope skull-based surgery, these types of tools is very mandatory, we think so. And then the monitoring VEP and MEP is also very important for such kind of surgery. And this is the basic style of the reconstruction techniques. So if the CS leak is low flow, so we use a very simple using inlay graft and only graft and only bony reconstructions. So if the CF leak is high flows, we use the arachnoid plasty, and for craniopharyngium, we use the fat for inlay graft, and for meningiomas, fascia for inlay graft, and cordon, fat or fascia case by case. So, and put only graft with fat and bony reconstructions. And then finally, we covered by the vascularized mucosal flaps. This is our reconstruction techniques. So again, our technique is this schema. The most important is to fix the inlay graft to the dural edge. So we want to leave the edge of the dural edge as much as possible, and to fix using the suture techniques. And also we want to stress on the, ideally we have 2 teams, dedicated teams for the reconstruction, because the surgery of craniopharyngioma using the endonasal approach is very, very tough and very stressful for the surgeon. So ideally, we have 2 teams, one team for the reconstruction team. This is ideal, yes. But sometimes it's very difficult to find another team, yeah. This case is a very typical craniopharyngium case, but partially you see the cystic part, and but tumor is limited in the suprasellar area, not widely, not laterally extended. This is a very good indication for the transplanum approach. So then we open the cell floor. We prefer to remove the one block fascions. And now we cut the dura and coagulate the sinus, and then we cut the diaphragm. So open the dura bilaterally. So now we dissect the tumor from the left side tissues, and we prefer to cut the pituitary tissues to open to the surgical field. This is the SHA. So carefully we dissect the tumor from the surrounding tissues. Many cases very stick to the optic nerve or optic chiasm. Sometimes we use the sharp dissection techniques using the scissors. So in this case, it is difficult or impossible to preserve the pituitary stalks, but after that, the tumor is completely removed. Yes. The next case is the case with the posterior extrusion. So we need the dorsum approach. I show the technique of the transdorsum approach. So the bleeding from the bony tissue. So we use some material for the hemostasis, and then cut the dura, and here you can see the optic nerve. So optic nerve is running a relatively lower position. So we need to open the surgical field lower and lower. But according to this techniques, we can do this surgery very nicely. So another point is the tumor extend to lateral. So for such case, this is not craniopharyngium, but the adenoma. But the same thing, we use this technique. So grade E or grade DE. So the tumor is embedded to the ICA or optic nerve. We use another craniotomy. In 2017, we report our experience. So in this article, so we stress on our concept of the conductor and non-technical skill. So the conductor has a good leadership for communication between the surgeons and surgeons. We need two surgeons for this surgery, but and also we need a very good communication of two surgeons. This is one example. This is a craniopharyngioma case of the extended to right side here. So optic nerve and right ICA is here. So we use these combined techniques for this surgery. This is view from the endonasal side. So this is the posterior communicating arteries and tumor. Tumor is very thickly adhered to the posterior communicating arteries. So we are nicely covered by each other's surgeons. So the tumor is completely removed for this patient. The post-operatively, yes. So this is the scar, very minimally. So we divided the two period, so early period and later period. The early period is 2009 to 2013, and the latter is after the 2013. So finally, the group, this early period, group A, it achieved gross total removal is 50%, and subtotal is 18%. But group B, we achieved over 90% is the gross total removal. So the summary is that group A, that the group B is like this. So this is a significant, statistically significant. So and also the gross total removal and subtotal and partial removal. Compared with these groups, there's also the significance. This is the Kaplan-Meier, the long-term follow-up. So also the group A and group B has the significance. So what is the contributed to this improvement? I think the camera is changed to the full high vision cameras, and the method is changed, 3-hand techniques and combined approach. We often use this combined approach, and transdorsal approach is also. So tools, dedicated tools, we have now many various tools for this surgery, and monitoring is now the routine use. So these factors are contributing this improvement of the long-term follow-up. Adverse effect is as follows. So from this, I want to stress on the importance of the perforating branches injuries. So we have 3 cases for the extended approach, including adenomas and meningiomas. So one example I see that this is a recurrent case of the craniopharyngioma. Here, the tumor is very deep area, and here is very difficult to remove from the endonasal approach. This is the video. This area is very hard and very stick to the tissues. So you can see the very thin membrane here, and once you get the membranes, never lose this membrane. And also around this, the perforating branches running. Here you can see this very tiny branches. So step by step, you dissect the tiny branches from the tumor membrane, tumor capsule. Yeah. So never lose the membrane during the surgery. So piece by piece, the tumor can be removed. Yes. So conclusion number one, to summarize, we report the long-term outcome of our experience, focusing on the recurrence and the regrowth. The radical resection through the transnasal route provide a better outcome and long-term tumor control. And so for the future goals, the preservation of the pituitary stalk is the next steps, next goals, I think. And also the long-term follow-up, further follow-up, and the role of the SRS should be clarified in the future. So thank you very much for attention.
Thank you, Professor Nagatami.
Yes.
Very difficult cases, and you are gently remove all the tumor. Thank for very interesting lecture. Now, you continue the next session.
Yes.
Yeah, the meningioma tuberculum celi. Please.
Yes.
Please share your slides. Next.
Okay. Yeah. Sorry. Okay. 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 So the next topic is the extended transmedullary surgery for tuberculosis meningioma. Yeah. Yes. Yes. Tuberculosis meningiomas is we think the one of the important tumors for the this approach for the, but mostly we have the using the microscope for the management of this tumors. But I started on the 2013, we started this surgery. This is our techniques of the cell floor reconstructions. The upper is using fascia, the lower is using fat tissues. For meningiomas, we in many cases we cut the dura matter very widely. So basically we use the fascia data for meningioma surgery. From the 2013, we performed the extended approach is about 150. So among this, the tuberculosis meningioma, we did 15 cases, about 10%. So this is, I think, the one of the important pathologies for this surgery. So the method is very similar to the craniopharyngeal or other extended surgery. We use 3-hand techniques and 4mm rigid scopes and high vision cameras and the image guidance and thin and malleable tools, and usually we use VEP monitoring. And this is our principle of the indications. The most important is laterality. Lateral is the limitation is the internal carotis arteries, and the size is basically maximum diameter is within 3 centimeters. But now it is not the limitation we think. So approach is the mostly we do the extended surgery, but sometimes we use the combined approach with TSS and supraorbital keyhole approach. This is the summary, but sorry, it's a very busy slide. So next slide is the summary. Yes. The men is 3 and female is 12 cases. The age is average 57 years old, and follow-up period is average 56 months. And for these patients, all patients has visual impairment and headache for 4. And no symptom is here 3. And visual impairment with 12 patients. Yes. And this is tumor size. In most patients, it around 2 centimeters, and the maximum size is about around 3 centimeters. So this is not so big size. And then the attachment of these tumors is for midlines, 8 cases, and for laterally, 5 cases, and midline with lateral, 3 cases. And for 3 cases, they have in the optic canal. And so on. So next pathology is the meningocerial, is 7 cases. The 4 cases for transitional and 2 cases for some matas types. And we have 1 case for atypical type. So K67 is below 2% for 9 cases, and 3 cases for below 5 cases, and over 5% is 3 cases. So during the follow-up period, we have no rigorous cases. This is a clinical outcome also very busy, so we summarize this here. So the surgery time, skin to skin time, is average 384 minutes, and follow-up period is 46 months, and blood loss is average 132 millimeters. Symptom grade is 4 cases for grade 1 and 10 for grade 2, and 1 is grade 3. Yeah. Post-visual acuity is here for in 12 cases of symptomatic cases. So 90 cases is improved for 76%, and 17% for no change, and deteriorated is 8%. One case is, yes, and the adverse effect of CSF leak is 2 cases, and 1 case is for visual loss, and 1 case is for cognitive dysfunction, and 1 case is overpacking. So, yeah. So the most importantly, this tumor is very different from the craniopharyngioma because of the anatomy. Tuberculous meningioma is covered with the arachnoid membrane like this. So naturally, this is a very advantage for the removing from the endonasal approach. Using these membranes, you can remove the tumor without injure the surrounding structures. But the craniopharyngioma is very stick to the surrounding tissues directly. And this is a very different point of these 2 entities. So this case is very typical case. Is so a very similar approach as the craniopharyngium, and then cut the dura and coagulate the intercavernous sinus, and also we cut the diaphragm. So you see this is the arachnoid membrane here. Arachnoid is left, so like we are peeling off the arachnoid membranes, you dissect the tumors. And for meningiomas, we prefer to use the ultrasonic aspirators. And then they open the optic canal and coagulate. So this is very typical surgery for tuberculosis meningiomas. So in some cases, we have non-responder or poor prognosis about the visual acuity, visual function. So we have 4 cases of the non-responder or deteriorated cases. So this is 4 cases. So most case is the non-response for visual field. For example, the case 2, the right side visual field is not response, not change, no change. For example, the number 12 cases, the visual acuity was deteriorated after the surgery, 0.8 to 0.3. So what is the contribution to this? So maybe the tumor size or age and attachment. 3 cases out of 4 is attachment is located off midlines, not on midline. So this is the case 11. So this case is very big size, relatively big size, and unfortunately, this case is deterioration after the surgery. So another discussion is how to preserve the SHA, and also this the sharp dissection is very mandatory. This is the number 3 case. So behind the tumor, you see the SHA is running. Yeah, this is the SHA, and this tumor is also very stick to the optic nerve. And at this situation, we use sharp dissection techniques, and very tiny amount of the tumor should be here left. So technical basics is here this to do sufficient volume reduction and preserve SHA, and to use sharp dissection techniques to leave some amount. And also, it's important to keep attention to VEP monitoring. Some review and some papers reported transtenoidal and transcranial comparison. So they compare the, in most cases, transtenoidal approach is better outcome for visual acuity. And also the some report said that the poor prognosis factors is the pre-operative optic acuity, optic disc atrophy, and symptom of duration, and laterality of the tumor origin. Yeah, these are the key factors for affecting visual outcome. So in conclusion, we reported our experience in treated in tuberculosis meningioma through the nasal corridor. So the decompression and sharp dissection technique with monitoring control is the mandatory for this surgery, we think. So for better outcome, the tumor location and size and timing for the surgery is very important point and should be considered carefully. So, and finally, I want to say that we should remind that the tuberculosis meningioma is unilaterally originated pathologies, not on the midline pathology, not central part, but the unilateral originated pathology we should remind. Thank you very much.
Thank you, Professor Nakagami. Very good presentation and very so interesting and very informative. Yeah, it maybe inspire us to doing that. Yeah. The last of this session. Next, we have the discussion. Now we continue. The next speaker would be chaired by Professor Nagatami. Please, Professor Nagatami, chair the more to session. Thank you.
Yeah. So next speaker is Atmi Arias. Professor Arias, okay? Yes.
Okay. Can you see my slide?
Yes, sir. Yes, sir.
Okay. Can you hear me?
Okay.
Okay. Thank you very much. In the last, I think almost 1 hour, we listened to very nice presentation by both Professor Yuichi Nagata and Professor Nagatani, and they demonstrate very well about how endonasal approach and keyhole approach you can reach a tumor at the skull base and elegantly shows how you can preserve it. But when you do endonasal approach, as your experience increase, then you will start to embark on from easy to more difficult case. And we know that with the technological development and technique, so we can reach the endonasal approach to the entire midline skull base, right from the foramen of cecum in front, sella, and of course it can go down to C2. So you can view all this, this is a cadaver specimen, but Professor Nagatani shows very nice live cases that when you touch, in this case you touch, it doesn't bleed, it's okay. But in a real case, all this critical small structure can cause problem if you don't handle it carefully. So problem with endonasal, they have a limited nasal corridor. Yeah, so in order for you to do difficult, you have to expand it. Okay, and along the process, you may traumatize the nasal mucosa. The nasal mucosa is very important because like air conditioning system, the nasal mucosa itself, not only for the flap, but it will filter the organism, it will humidify the air before you inhale into the lung. You will never inhale a dry air, similarly to the air conditioning system. So if you destroy the mucosa, you already destroy your first protection for the air to get into your lungs. So mucosa need to be preserved. And when you go endonasal, so you have to encounter to the key structure. One of it is pituitary gland. You can have a complication from the hormonal impairment. So the water will leak when you do endonasal expanded approach, especially for tuberculosis meningioma. You have to do extracapsular. You cannot do intracapsular. Pituitary, maybe. Some can do subcapsular. Some you have to do both combination. And there are a lot of critical structure there. So there are various complications. This is a list of complications that you should avoid whenever possible. So you need to know how to avoid. But sometimes you cannot avoid. It happens especially when the cases are more difficult. And the most complication that we worried, we really feared among neurosurgeons is vascular complication and infection. Of course, you have rhinological complications. So today I select few cases that my personal experience, which I think I learned and I would like to share, mainly on two complications, which is arterial as well as infection. As we know, nasonasal mobility, if you do with the NT, usually they will see, but majority of cases will complain of anosmia. Yeah, they have a scarring. They can have this kind of crusting. And usually they see the ENT surgeon. So neurosurgeon say everything went well, but not. Yeah, because if you do not respect the mucosa, you can have all these problems. So you need to know the anatomy of nasal cavity, even though you are not ENT surgeon. Yeah? Then only you respect. So the first case is a case of what I really learned. So this is, I think, the first 3 cases that I started endonasal in 2005. Yeah. So upon my return again from mine, so this is a 24-year-old gentleman who presented with actually abnormal behavior. She become more forgetful and loss of vision. Actually, almost legally blind. She cannot see well, but some view are still intact. So if you can see huge tumor, for some reason, the parents and the patient himself, he's actually depend on the father to take care of him, refuse any cranial surgery. But they say you can do anything, but don't touch the head. I say, okay, fine, we can go from below. And they agree, because the tumor has eroded the skull base. So this is very nice. You can do endonasal approach. You can see a very nice, what they call it, necrotic area. Once you decompress, the brain will push. So the tumor will come to you, and then you can do a nice dissection. So this is, I think, almost the end of it. So you can see we preserve the arachnoid, but there was one part of the arachnoid layer. Okay, you must find tumor arachnoid margin. This is extracapsular because tumor is big. No way that you can do subcapsular. It's a combination of both. It was torn and leaked a little bit. But as it leaked, the brain retracted downward. So we don't have enough instruments. So very deep inside. You can see from here to here is already 7 centimeters as it descend down. So plus the nose, so it's only about 12. So we can see, but we cannot reach. We try to plaster the hole in the arachnoid, but we fail. But anyway, so we go as a standard technique, nasoseptal flap, and we repair with fascia lata. So then post-operatory CSF leak, and we do it over weekend because my list always on Friday. Then it leaked on Saturday. So we say, wait, do lumbar puncture and external lumbar drain. Okay, so that's what we did. We thought that can control the leak. But day 5, he started to have fever, and then we went in. So when we went in, number 1, we find that the flap is retracted, and there was a hole, actually a defect at the fascia lata, and you can see early evidence of infection. Yeah, so because you do nasoseptal flap, then it vascularized, so you can recycle. But we realized that we have made few mistakes. Number 1, the fascia lata that we have was actually there was a little bit hole. So I decided just to put a stitch and repair it. So I thought that is fine. So it leaked from that stitch area. So that's number 1. And number 2, you must remember when you do nasal septal flap, it will contract about 20%. So your nasal septal flap must be long and bigger than your defect. If you take it just enough, it will contract. So this is what happened. The flap is contracted and retracted. And because this is quite early experience, I think my colleague ENT was a little bit small. So that is not enough. So then we remove that fascia lata, which was already got a hole and infected. So we put a new fascia lata, and then we construct the fascia lata, and then we put a flat fat. So I like flat fat. The flat fat in the tight just above the fascia lata, and we enforce it peripherally, so it's not at the periphery. Glue, and then we have to put back the previous flap, but that flap is small because it's already retracted. So we have to hold it by putting the Fogarty catheter. So this is a balloon CBG for the bladder, urinary catheter. So we use that balloon to tamponade. So this actually not routinely, which you have a good flap, you don't have to put the balloon. Yeah, it just sits nicely. Because if you over tamponade, 2 things can happen. 1, it push back your construct into the hole. Number 2, too much of compression cause flap necrosis. So defeat the purpose of vascularized flap. So in this case, we have no choice because the flap contracted. So we have to release a little bit and we put a balloon. So we thought our problem settled. No. So she started to have fever, seizure, meningitis, and then hydrocephalus, and the problem all come. Ventriculitis, panhypopite, diabetes insipidus, septicemia, pneumonia, and blood profile deteriorated. And then we have no choice to put EVD. We tell the father, sorry, eventually we have to touch the head. Yeah. So we put an EVD and it bleed along the EVD tract because sepsis caused coagulopathy. Okay. So, but he survived over 3 months. So she recovered. Yeah. But he was ventilated almost 2 weeks in ICU. He developed deep vein thrombosis and so on. So lesson learned. When you do endonasal leak, you go in early. External lumbar drain doesn't work because the leak is big. You create the leak and you know the defect is big. External lumbar drain does not enough to control the leak. You have to prepare and properly raise the flap. The flap needs to be big enough, long, and passively follow the contour. So this is very important. Actually, when you do endonasal, the planning starts with the flap. Yeah. So you need to know and you measure your flap before you open. Don't open, then you realize that your flap is small. So then you start. You may have to use another technique, either double flap or so on. Okay, so that is lesson number 1. Case number 2, 54-year-old lady, progressive lethargy. You can see again, pituitary, non-functioning pituitary adenoma. Family refused shunt because patient have obstructive hydrocephalus. They say, we don't want shunt, can we proceed with surgery? And then it happened that, okay, we get almost next available list. So we put the patient, but you can see from the MRI, okay, his tumor is already encasing the vessels and part of the thalamus, and I think brainstem also involved. Yeah. So we know that, and it also go back there and almost touch the basilar artery. Now we know that we will never be able to remove everything safely. So we tell them that we may have to leave some portion of the tumor for safety reason. Yeah. So this is a summary. So you see the tumor bulge there. And then you can see we already entered the ventricle. This is the diaphragmatic sella. This is the snowman. You go to the snowman head, you get into the ventricle, but we have problem along this part. Yeah? So it stuck to the thalamus, and then whenever we try to remove, it bleeds. So we have to do irrigation. You can see this is a further view. Yeah, and then for somehow at the end is quite good control. Yeah, and then it's quite clear. So we decided to close. So same technique. This one we put a gel foam a little bit. And then I think this one we put gel foam only, gel foam. And then we put glue. And then we put a flap because the flap is very nice. Very long, big, nice flap. So you can see it nicely glue over the gel foam and then flap and then glue again. This is a glue. Okay. Then post-op. The patient not waking up well. So you can see there was a clot accumulate in the tumor cavity. Okay. And then we have to put EVD. Yeah, because we thought that could be the cause. The ventricle is already dilated pre-op, but we have no choice because there's a little bit of IVH. Yeah. And then she started to have high-grade fever, then require intubation. Then develop a high-grade fever. Then we do CT scan. You can see a sediment there. Actually, she developed pyogenic ventriculitis. So this is another infection, severe infection. As you can see here, she went in. So you can see a lot of slough. So when you have hydrocephalus, you have sediment, you have ependymal enhancement, and you have fever, you must think about pyogenic ventriculitis. Don't just put EVD. You have to go in lavage, take out the slough. And of course, it accelerate the patient recovery, as I mentioned earlier. The patient actually survived. I think, but her long stay in the hospital almost more than 2 months. So finally, we challenged EVD, but drainage dependent, if not mistaken, then we put a shunt. So sometimes we have a recurrent case. This is combined transcranial endonasal, huge meningioma. No way that you can use endonasal approach alone. Operated 2 times post-radiation, came with CSF leak. So we have no choice. We go in, combine transcranial endonasal. Despite redo, you can still harvest good pericranial graft. So we reconstruct the hole, but there was a defect. But we cannot put a screw properly because the bone a little bit friable. You can see the big defect. So we use split cover graft. So after we remove, the ENT went in from below because we get a very good control. No way that you can lose nasosectal flap is already tumor. And if you have also, it's very small. You cannot cover the defect. A good pericranial flap is very good option. So, and then we reconstruct and use the split cover graft to cover the defect, and we put the graft sandwich in between the pericranial fascia. But post-op, she leak again. So this is something that we're a little bit concerned because we have many complications when you have leak from below. So we went in again. We have to put a long, what they call it, titanium, titanium cranioplasty plate, and then we have to screw at the end of the orbit, so that is more harder bone that the screw can purchase. Then it sit down and no more leak. So now second part, hemorrhage. So there are many ways that you can control hemorrhage: chemical, mechanical, thermal, and nasal cavity. Endonasal have many approach and many stage, and each one has a problem. The sinonasal phase, sphenoid, sela, you can have bleeding, and easy to control by packing. Okay, so that easy. But there are also bleeding. You can have a source of bleeding. You need to know the location of each this vessel. Then when it bleeds, you have a direct target you can control with bipolar. Do not panic because you know predictable. The location are same. So this is easy to control. All right. So the flap, the anterior, posterior ethmoidal vessel, all you need to know. So that when it bleeds, easy. You go to the target easily. Mucosa irrigation usually work. Okay, sinus bleeding, we have many ways. You elevate the head, irrigation. Sometimes we can use Surgicel, gel foam, usually work. But if you have more money, you can put Flowsil. So this is easy to control. Venous bleed also, like in this case, a recurrent Cushing. So we try to do a hypophysectomy. We try to find the tumor. But unfortunately, I think it bleed. You can see here from the superior circular sinus. So Norway is quite difficult to cauterize. So what we did, we just used initially gel foam, Surgicel. So somehow it doesn't control. So we have to shoot with Flowsil. So Flowsil works. So sometimes it's worse for you to have a standby Flowsil in your OR to control it. Okay. So this is one of the cases that my first mortality following endonasal after more than 17 years doing pituitary surgery. Acromegaly, patient come with obstructive sleep apnea, reduced effort tolerance. So you can see from here, so there is actually the stalk is thickened. Okay, sorry, this is not the case. Okay, never mind, I skip that. So the last example, and this is very important for you to learn. So this is a case of pituitary adenoma operated in another center, but there was a residual. So the patient has still visual impairment. So they come to us for second opinion. So we thought it's quite easy case to handle. You can see here, okay, the tumor residual, and this is ICA. So the trick is we thought we want to go to a normal space and then go from a non-scar area. So we use navigation to find the target. We drill a little bit, and hopefully we can get control from normal to the scar area. So then we use navigation, okay, and then we find the location of the ICA, which actually somewhere around here, okay. And then there was a scar made by the previous surgeon. So we thought we drill through a normal area, and we try to release the scar, and suddenly we see a gush of blood. We thought this is just from the bone, okay. And then in few seconds, and then it start to blow. This is actually direct injury from ICA. So you see, when you do endonasal, so you need to be very fast. Muscle sometimes is not available immediately, but if you can predict it's going to be bleed, you may prepare the muscle in advance. So, but in this particular case, we didn't prepare for that because we thought this is quite straightforward. So we put 2 sucker, and then we try to use Surgicel, it push out, gel foam push out, Flowsil also push out. So we find the target, but unfortunately we cannot control, and the blood pressure start to drop, and the ECG already shows some changes. So the anesthetist is not so happy. So we got no choice. So we have to abandon the procedure. What we did, we tamponade. We have to put nasal pack and forgetting catheter to tamponade the bleed, and then it stopped for a while. about 1 minute and it starts to bleed from the mouth. And can you see it stop from nose and bleed from the mouth? Then we have to pack the mouth and we have to hold the nose and the mouth. So at that particular time, we have to do it instantly. So retrospectively, probably muscles, you can harvest from your temporalis area. And like Professor Charlie Teo, if you think that chances of bleed happen, they already mark the area, they can harvest the temporalis muscles immediately. Some surgeon, like for myself, I always prepare fascia lata. Yeah, for big tumor. Small tumor, we hardly use fascia lata anymore. So sometimes that could be, you predict it, that possible happen. But sometimes complication happen when you are not prepared for that. So we have a backup. So we have endovascular. So they went in and then it was treated with endovascular and the patient survived and improved for that. So there are various techniques. You can use muscle and some even use clip, but I'm not so sure, but you need a very good big nose and special clip in order to clip. This is actually not a real patient. It's a stimulator. So it looks like nice, but in nasal cavity, a real one is quite difficult. Okay, so I think because of time, so that I end my presentation there. Okay, thank you very much.
Yeah, thank you very much. Very exciting presentations. Yes. So next, my presentation. So
the next, so the last, we thank you, Asmi Ilyas. Right now, the last speaker for this session, and don't forget, Asmi, Prof. Ilyas, after this session, we have a discussion.
Sure,
now,
sure.
the last speaker for this session, we invite again Professor Nagatami.
Yes.
To talk about strategies for recurrent casing disease. Please, Professor Nagatami, to share your slide and speak. Professor Ilyas, tolong please stop your share and then let Professor Nagatami share his slide.
How do I do that? Can you do now?
Okay, yes.
Okay. Sorry.
Okay, yes. Yes, last presentation of this session, my third topic is the, can you see? Okay. For the strategies for recurrent casing disease. Yes, also this entity is also challenge, I think so. Yeah. So in this presentation, we will present our experience for the recurrent or remnant casing disease to discuss about the technical issues and the strategy and their strategies. Yes. From 2013 to 2019, so we have 70 surgeries for 13 cases is experienced. The man is 2 and the female is 11 cases. So yes, surgical method is the endonasal endoscopic endonasal transcendal approach. So also we use the 3 hand techniques and with scope holder and high vision cameras and some tools or special designed tools. So in this paper, my criteria, cure criteria is ACT for ACTS 15 picograms below 50 picograms, and for cortisols below 10 micrograms, and as follows. So among these cases, for initial case, we have 10 cases and repeated cases for 3 cases. So among 10 cases, after the surgery, remission is 9 and still active is 1. And for among the 9 cases, 2 cases relapsed. So we have 12 surgeries for the initial cases. And for repeated cases, among 3 cases, we have 2 cases for remissions and 1 case left active. So we have no cases for relapse for remission cases. After that, 1 active cases, we did the surgery for 2 times, but so totally the 5 cases is included for repeated cases. Another point, so we summarize this situation. So initial cases is 10 cases and repeat cases 3 cases. So finally the number 1, number 2, number 3 cases have the so-called repeated surgeries. So we discuss about these 3 cases in this presentation. So this is another case, is a very typical one. So you see here maybe the microadenomas, but you see these areas looks like very like microadenoma. It looks like, but not so sure. But this is, I think, the most typical case for Cushing disease. This is, of course, the initial cases. Maybe here is the most probably the tumor itself. But here and we see the very suspicious areas. So firstly, we cut the horizontally the very big incision, and then cut the vertically the very big incision. So inspect the inside the anterior lobe. So we find tumor tissues. So now we cut biopsy this area, but in this case, this area is not the tumor. But I think this is important to be suspicious to do another areas. So the Cushing disease, the tumor looks like small, but they sometimes very largely extended inside the anterior lobe. So this after the surgery, ACTH and corticoid level is below the normal. So this is case number 1. So this is the schema of the tumor laterally to the cavernous sinus. So we do the remove of the cavernous sinus, lateral wall of the cavernous sinus recently. So you mentioned that the to remove the bony work is very important. So as much as possible, we open the cella floor area, and then you see the medial wall of cavernous sinus, and then dissect this and cut sharply. The first we dissect the tumor of the medial side and the lateral side, and remove the tumor as a big mass. But we think it is not enough. So this is a medial wall of the cavernous sinus. The tumor is embedded to this membrane. So we want to remove this membrane, cavernous sinus walls as much as possible. And this is the ICA. And bleeding from the cavernous sinus is relatively safe controlled with some materials. So this is case number 2. This is the initial tumor, and after the initial surgery, the ACTH and corticoid level is getting lower and lower, and but after 1 year, the tumor recurs. We think here this is a tumor recurrence, and also the ACTH and corticoid level is getting higher and higher. So we decided to the operation surgery. Yeah, this is the second surgery. The tumor is here, and it looks very difficult to remove totally because this is surrounded by the ICA and of course in the cavernous sinus. And this is the initial surgery. Initial surgery, we also remove the wall of the cavernous sinus. And this is the second surgery. The second surgery, we open the cell floor open wider than the first one. So after they remove the mass region here, and maybe this is a cavernous wall membrane, and using the sharp dissection techniques, we remove the tumor. But maybe this is not enough, so we remove the tumor partially, we think. So we judge that this is further procedure is the more dangerous for this patient. So we stop this surgery here. After that, the ACTS level and cortical level is getting lower and lower. Now we are carefully watch this surgery for in the outpatient clinic. So we need more follow-up, I think. So this is case number 3. This patient has a very, very long history. The initial surgery done in the 2007, over 10 years before. From this, so we did the 3 times of transcranial surgery and 2 times of gamma knife surgeries. And ACTH and cortical level is getting lower and lower, but still is not controlled. Fortunately, the patient condition is very good and no hypertension or no diabetes. So we followed this patient, and then the fourth surgery we did. This is the MRI before the fourth surgery. You know this. Where is the tumor, you think? So second or third surgery, we inspected the inside the cavernous sinus, and surrounding the anterior lobes. So here, this is we think this is the normal ground, but finally we want to inspect inside this area. So this is the video. As the same fashion, we initially cut the horizontal incision and inspect inside this, but you see the no tumor tissues, but only the degenerated tissues like this. But it looks like not a normal gland. So we remove these tissues. We think this red area is the normal gland. Yeah. And then we finish the surgery after the removal of the such tissues as much as possible. So what is the what we can do is this procedure only. So after the surgery, the cortical level is now still over 10, but not so bad control, but we think that this is not good, poorly controlled. So we discuss about the further treatment with the internal medicine. This is the post-operative MRI. So, yes, some report says that several points. So we summarize this point. So preoperative MRI image findings. So imaging invisible adenoma often can be found in cussing disease patient by a systematic exploration of the pituitary gland. And so sometimes we cannot find the tumor itself by the imaging, MRI imaging. So this is not so particular, but often we experience. And adenoma dural invasion. This is also the sometimes we experience these kind of tumors to invade to the cavernous sinus and dural tissues. Mostly these kind of tumors cannot be removed totally, but now we have a technique for the removing the wall of the cavernous sinus. So it may be improved the outcome for this kind of patients. So finally they report that the partial and the total hyphysectomy have similar biochemical remission rate. Yes. So this is the I think the tips for the recurrent cussing disease. And so for this entities, we advocate that we should have a variation of approaches. For example, the lateral recess approach to the inferior wall of the cavernous sinus is very useful, we think. So for technical standards, the lateral extension of the cell floor opening and sharp dissection techniques is also the mandatory. And also the excision of the cavernous sinus wall is the most important techniques for cussing disease. And techniques for hemostasis and materials is the most important. Now we have very kind of such materials, so we are very happy to use these materials for this kind of surgery. So it seems very safe and very easy for approaching the cavernous sinus area. So this is final conclusions. We report our experience of the management of the cussing disease with special emphasis on repeated transcranial surgery. So tumor with dural invasion extended cavernous sinus is tend to be the active after the surgery and recur. Cavernous sinus approach with wall excision is one possible option, but we think the gamma knife surgery should be simultaneously considered before planning the surgical treatment. Thank you very much.
Thank you, Professor Nagatami. Very, I myself, I never doing this surgery for cussing diseases. Now we come to the end of the session, The last speaker already talked very interesting topic and very informative and very good to know for us. Now we come to discussion for 10 minutes. If there are any question, you can directly raise hand or via Q&A. There is Steve Elias dan Profesor Nagatami still there. Okay.
Yes. For me,
yes, please. Is there any question?
Yes. For me, any tips to reduce pneumocephalus? Yeah. Okay. Yes. I myself, the positioning of the head, of course, I mentioned that the patient positioning is, of course, the head up, but some degrees of the vertex down, and sometimes we put saline water and push water and also the surgical time, shortage of the surgical time is the one key issues, I think. So, but fundamentally, we have no good idea for the pneumocephalus. So, I think the some amount of the neurocephalus is the not inevitable, but I think the okay for some amount of the neurocephalus, for such kind of surgeries,
Okay.
No special good idea for this kind of
Dr. Asmi Elias, is there any comment or question for you?
Okay, number one, you will have neurocephalus in majority of cases if you do long hour surgery, if you do expanded approach. But I agree with Prof. Nagatani, position is important, and usually you have to fill up the saline. But I have a few cases where too much of flushing, I end up with infection. But I ask many other speakers, they say never an issue. So maybe the fluid that you inject to clear and to prevent pneumocephalus probably better from a new bottle rather than the one that you use and keep and recycle in the same kidney dish that you use when you open the nose. So that's maybe one of the trick. And position, yes, I agree. But tension pneumocephalus is the one that causes a problem. And usually because you fail to repair it properly, or sometimes you may miss the communication between the sinus, the air sinuses and the intracranium that you may accidentally open. So I think I can recall cases where we do CELA, but I think ENT, when they raise the flap in the early experience, I work with 5 rhinologists. The first few experience, they may struggle. If they raise the flap too high or they try to drill, and sometimes very thin floor of the ethmoidal sinus, and sometimes they can break the planum without them realize. So they can cause pneumocephalus when you do not realize that happened. So if that's the case, then you have to repair it. So I think pneumocephalus, no way that you can completely eliminate, but usually it will resolve.
Okay, I think there is depend on where it's supposed to be origin of the pneumocephalus, and the best treatment is the surgeon will know where it's supposed to be come from and what to do. It's very specific, very specific for the patient. So, is there any more question? If not, if Dr. Nagatami agree, I finish the session and then I give this talk to Mr. Ceremony. Please.
Videonya udah kelihatan. Ya. Thank you to all speakers for an amazing information and Professor Sri Maliawan for leading this session. Before we move on to the next agenda, we are going to take a picture, and to all the participants, please turn on your camera. Okay, for the first slide. 1, 2, 3. Okay, thank you. Distinguished guests, honorable speakers, delegates, ladies and gentlemen. Now we are going to take a break. During our break session, please take this opportunity to see sponsored video for today's event. And to all the participants, please kindly be reminded to return here at 2 p.m. Middle Indonesian time as we start the second session of this event. Thank you and have a nice break.
Thank you, Mrs. Moderator. Thank you, Dr. Rohadi. Very good workshop. It's very, very good.
Thank you, Jum'ah Pray, Prof. Thank you.
Yeah.
Thank you, Prof. Nagatani, Prof. Azmi.
Prof. Nagatami,
Thank you very much.
Yes, and all of the committee. Thank you.
Thank you.
NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections.
Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the presentation of the NeuroAid. Now, we will proceed to the next slide. This is the
NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections.
distinguished guests, speakers, delegates, ladies and gentlemen. Welcome back to the pre-conference 2nd ASEAN Congress of Neurological Surgeons. Now, we will be entering the second workshop, Interventional Thrombolytic, with Dr. Nur Setiawan Suroto as a moderator. Before we start this session, please allow me to read his CV. Dr. Nur Setiawan Suroto, SPBS, was born in Surakarta on 27th of September 1980. He was completed his medical studies at Erlangga University in 2005. He completed his neurosurgical residency program at Erlangga University in 2011. Dr. Nur Setiawan Suroto is a chief of endovascular neurosurgery division in Department of Neurosurgery at Dr. Sutomo Hospital. There is the short CV from Dr. Nur Setiawan Suroto, and now I hand over the session to Dr. Nur Setiawan Suroto. Time is yours.
Thank you very much to committee. It's a very pleasant evening in this afternoon because we will have a workshop about stroke for the interventional thrombolytic, and the speaker is from Japan. As we know that Professor Takeuchi is very famous in stroke intervention. If we read his publication, he write a lot about stroke, especially for the bridging treatment for the thrombectomy. So Professor Takeuchi is from Seisu Hospital Neurosurgery, and then he is from the Tokyo University School of Medicine, and his qualification is a stroke specialist, cerebral endovascular specialist, neurosurgery specialist. So I think we can proceed to his workshop, but unfortunately, because it's in the pandemic situation also in Japan, he cannot join us directly, but he already sent to us his presentation, his video presentation. Please.
I will be giving a lecture of the basics of mechanical thrombectomy therapy. I am Master Takeuchi. Also, there is no show in my presentation. For the treatment of acute ischemic stroke, there is no clear evidence for reperfusion before the end of the stroke. There are three reperfusion procedures: intravenous TPA, IV TPA, MT, mechanical thrombectomy, and bridging therapy consisting of IV TPA followed by MT. This slide shows evidence for each reperfusion procedure. In 1995, the effectiveness of IV TPA was demonstrated within the 3 hours of onset. And in 2009, it was demonstrated within the 4.5 hours. In 2015, Mr. Crane proved the effectiveness of MT for ICM1 occlusions when performed within the 6 hours. Similar RCTs also demonstrated the effectiveness of MT, but because IVTPA is indicated for occlusion within the 4.5 hours of onset. Bridging therapy, but not direct MT, was performed the patient in those studies. In other words, the effectiveness of the direct MT has not been proven within the 4.5 hours of onset. For ICM occlusions, 6 hours or longer after the onset, the effectiveness of MT using rapid or fully automated image analysis system has been demonstrated in patients with the mismatches. So currently, bridging therapy consisting of MT immediately after IVT is recommended for ICM occlusions within 4.5 hours of onset, while immediate MT is recommended within 4.5 up to 6 hours of onset, and MT is recommended within 6 to 24 hours of onset if there's any mismatches. It shows that effectiveness of TPA is limited. For example, passenger rates are low when it uses large vessel occlusions, such as ICM occlusions. Also, TPA is a fibrotic agent and is known that it's associated with hemorrhagic complications. This raises the question of whether TPA should be administered before MT in treating large vessel occlusions. Direct MT, which skips TPA, has some advantage, including less bleeding, elimination of the TPA costs, and option for immediate antithrombotic therapy. But omitting TPA administration may delay the start of the treatment and reperfusion, and may lower our reperfusion rate. There have been 5 RCs compared direct MT and bridging therapy, which were conducted around the same time. Our SKIP study, direct MT in China, Mr. Plain no IV in orange, Swift Direct in Europe, and Direct Safe in Australia. Inclusion criteria were basically the same. Also, the target number of the patient varied. To sum up, among the RCs compared direct MT and bridging therapy for ICM occlusions, the SKIP study was the first published results. Although we could not prove non-inferiority of the direct MT to bridging therapy, the rate of any intracranial hemorrhage was lower for direct MT than the bridging therapy, based on the data available now. Direct MT can be considered for patients at high risks of hemorrhage, but bridging therapy is essential if the time the thrombus recovery is long. We are happy to report that the SKIP study has been accepted by JAMA. Therefore, mechanical thrombectomy is an essential treatment for acute cerebral artery occlusions. The first pass effect is an important factor in the outcome of the mechanical thrombectomy. The use of the balloon guiding catheter in mechanical thrombectomy has become a standard in recent reported. Set up the balloon guiding catheter. Fill a 5 ml syringe with the 15% concentration of the contrast medium. Inflate the balloon and make sure there is no air. Place the sheath over the balloon lumen in the sheath introducer prevents damage to the lumen. stroke. There are 3D perfusion procedures: intravenous TPA, IV TPA, MT, mechanical thrombectomy, and bridging therapy consisting of IV TPA followed by MT. There are reports that balloon guiding catheters destroy the internal catheter artery. In 1995, affect the decolonization rate was demonstrated within the 3 hours of onset. And the balloon guiding catheter is guided by an immediate catheter. In figure 1, immediate catheter, the JB2 type A and the head-to-hand type B commonly use the immediate catheter. For our aortic arch classification 3, Simmons type C selected by there are many types, shape, stiffness, and degree of deflection that needs to be understood. We chose the A type as our first choice. In other words, the effectiveness of the direct MT has not been proven. Combined use of the Lyra force hemostatic valve 2. The setting of the balloon guiding catheter and the immediate catheter is shown. Compared with the Y connector A, the combined use of hemostatic valve B guides the immediate catheter for the distality, improving the stability of the coaxial. Consisting of MT immediately after IVT is recommended operation of the balloon guiding catheter within 4.5 hours of onset, while immediate MT is recommended within the 4.5 hours to 6 hours of onset. The catheter always keeps the guiding on the both the front side screen if there's any mismatches. As a basic rule, it is important to guide the 0.035 wire in the immediate catheter more distal, such as ICM occlusions. Also, TPA is a fibrotic agent and is known that is associated with hemorrhagic complications. This raises the question of whether TPA should be administered before MT in treating large vessel occlusions. Direct MT, which skips TPA, has some advantage, including less bleeding, elimination of the TPA costs, and the option for immediate antithrombotic therapy. But omitting TPA administration may delay the start of the treatment and reperfusion, and may lower our reperfusion rate. There have been 5 RCTs comparing direct MT and bridging therapy, which were conducted around the same time. Our SKIP study, direct MT in China, Mr. Plain no IV in Orange, SWIFT direct in Europe, and direct SAFT in Australia. There is a case too. Inclusion criteria were basically we also encountered difficult cases with a strong correction of the common carotid artery with a bronchocephalic carotid. In such cases, we change the guide wire to the stiffer one of the stretches, the vessel and brake guide it. Although we could not prove non-inferiority of the direct MT to bridging therapy, the rate of any intracranial hemorrhage was lower for direct MT than the bridging therapy. Based on the data available now, direct MT can be considered for patients at high risk of hemorrhage, but bridging therapy is essential if the time the thrombus recovery is long. We are happy to report that the SKIP study has been accepted by JAMA. Therefore, mechanical thrombectomy is an essential treatment for acute cerebral artery occlusions.
The first pass effect is an important factor in the outcome of the mechanical thrombectomy. The use of the balloon guiding catheter in mechanical thrombectomy has become a standard in recent reported.
Difficult cases of the balloon guiding catheter.
Setup of the balloon guiding catheter.
If the flexion from the origin of the left common carotid artery is not extended, it can be very difficult. If balloon guiding catheter introduction is difficult, this is a method to use. Brachial artery puncture, since the guiding catheter, 7 or 8 French, suspending with the gooseneck snare work, balloon inflated anchoring technique, balloon inflation floating technique,
Inflate the balloon and make sure
direct
there is no
carotid
air.
puncture. Balloon inflation floating technique is shown.
Press the sheath over the balloon lumen in the sheath introducer prevents
After the
damage
balloon inflating
to the
floating
lumen.
technique is used to guide the catheter distally. The immediate catheter can be guiding distally.
There are reports that balloon guiding catheter destroys the internal carotid artery, affects the decanalization rate. The balloon guiding catheter is guided by an immediate catheter, a figure 1 immediate catheter, the JB2 type A, and the headhand type B are commonly use the immediate catheter for aortic arch classification 3. Simmons type C is selected by there are many types, shapes, stiffness, and degree of the flexion that needs to be understood. We chose the A type as our first choice. Figure 2. Combined use of the Lyra force hemostatic valve 2. The setting of the balloon guiding catheter and the immediate catheter is shown. Compared with the Y connector A, it's a combined use of hemostatic valve B, guides the immediate catheter for the distality, improving the stability of the coaxial. Operation of the balloon guiding catheter. Case 1 is shown. The catheter with tape is guiding on the both the front side screen.
On the diagnostic image of AIS,
As a basic rule, it is important
finding on
to guide the
suspected SSI
0.035
detection of
right
the embryo
in the
T2
immediate
star, the
catheter
right,
must
difficult in the internal carotid artery due to intracranial arch factors. In 25% of the cerebral infarctions, there is a occult cerebral infarction, for which type cannot be accurately diagnosed. Presence of the specific carotid emboli and useful in the diagnosis of the type of the disease. The presence of the SVS specific for cardiogenic embolies and is useful to type of disease. Unsaturation to the oxyhemoglobin to deoxyhemoglobin takes 2 or 3 hours, and embolism from the fresh thrombus do not proceed a magnetic susceptibility. Effectively are not SPS positive. The decolonization rate of TPA therapy is SPS positive. Patient is low. The correlation between the thrombus length and SBS positivity is sandwich angiography with a microcateterization with findings at the thrombus length of the 6 mm or more.
The common carotid artery with a bronchocephalic carotid.
SBS is also used for the therapeutic procedure.
Guide wire to the upsticker. One with a stretch the vessel and guide it. Difficult cases of the balloon guided catheter. If the flexion from the origin of the left common carotid artery is not extended, it can be very difficult. If balloon guided catheter introduction is difficult, this is a method to use. Brachial artery puncture, since the guiding catheter, 7 or 8 French, suspending with a gooseneck snare work, balloon inflated anchoring technique, balloon inflation floating technique, direct carotid puncture. Balloon inflation floating technique is shown. After the balloon inflating floating technique is used to guide the catheter distally, the immediate catheter can be guiding distally. on the diagnostic image of AIS. Findings on susceptibility, vessel sign, SVS. Detection of the embryonic fuse T2 star is right difficult in the internal carotid artery due to intracranial artifacts. In 25% of the cerebral infarctions, there is a occult cerebral infarction, for which type the first type cannot be accurately diagnosed. The presence of the SPS specific to the carotid emboli and useful in the diagnosis of the type of the disease. The presence of the SPS specific for cardiogenic embolies and its useful type of the disease. Unsaturation to oxygen, oxyhemoglobin to deoxyhemoglobin take 2 or 3 hours, and embolism from the fresh thrombus do not proceed a magnetic susceptibility. Effective are not SPS positive. The decolonization rate of the TPA therapy is SPS positive. Patient is low. The correlation between the thrombus length and SBS positivity is the sandwich angiography with the microcateterization with findings at the thrombus length of the 6 mm or more. SBS is also useful as a therapeutic procedure. In this case, there is a basilar occlusions. T2 star and SLY image shows the presence of the thrombus in the basilar artery 2P1. The stent deliver is deployment from the left posterior cerebral artery. TT3 was obtained at 1 pass. Basic techniques will be demonstrated. First, the microguide wire is shaped to about 45 degrees. The J shape reduces the possibility of the vascular damage. The J shape reduces the possibility of the vascular damage, but we use this shape for vascular selectivity. A microguide wire is passed through the obstruction, followed by microcatheter. When removing the microguide wires, the catheter should be filled with water. If this is not done, air will be drawn into the catheter. Position the stent deliver in the center of the right connector and flash. remove the sheath from the stent deliver. The stent used in this study is empotrapsir. The proximal marker of the stent should be in contact with the thrombus. Here we will perform angiography to confirm immediate flow restoration. Inflate balloon guiding catheter and attach the backlock chains for aspiration. Slowly remove the stent retriever. The stent retriever was not removed intact. Remove the Y connector and check the stent retriever. The clot was received with the stent retriever. There may be residual clots in the balloon guiding catheter. Therefore, check the aspiration, the backflow from the balloon guiding catheter, and perform confirmatory angiogram. Preventing thrombus from entering the HA. This number for number technique. Deliver of stent retriever into penumbral catheter while aspirating inside the catheter of the removal of microcatheter. Increase clot retrieval rate. Captive technique. Guide the aspiration catheter to the proximal end of the thrombus. Deploy the stent retriever after starting aspiration from the aspiration catheter. Advance the aspiration catheter to the proximal thrombus. Remove the microcatheter, increase the trapping force. The distance between stent retriever and aspiration catheter is contact and they are connected together. Arch technique guides the aspiration catheter to the proximal end of the thrombus and to deploy the stent. Wait the whole minute. After the balloon guiding catheter is expanded, started aspiration from the aspiration catheter. After the balloon guiding catheter is directed, start the aspiration, the stent retriever from the aspiration catheter. The stent retriever is put into the aspiration catheter and retrieved together when the distance increases. Shaper stent anchoring for aspiration catheter in the higher recovery rate. Shape technique. After deployment, the stent retriever guides the aspiration catheter across the thrombus. After removing the microcatheter, start the suction pumps. After removing the microcatheter, start the suction pump. The suction pump is disconnected from the aspiration catheter and connected to the guide catheter, continuous suctions. The suction pump was disconnected from the aspiration catheter and connected to the guide catheter, the continuous suctions, while the aspiration catheter was suctioned with a 60-minute syringe. Correct both stent retriever and aspiration catheter. Stent anchoring, thrust, and prevention, and increased clot retrieval rate. ASAP technique. Before passing the thrombus, the proximal balloon is inflated and distal suction from the aspiration catheter is started. The stent retriever is deployed. The aspiration catheter is advanced to the immediate vicinity of the thrombus using the stent retriever as an anchor, and the microcatheter is removed. The stent retriever is recovered in the aspiration catheter and completely removed from the entire system. Continual aspiration by the aspiration catheter is proximal flow arrest to the aspiration small fragment of the thrombus and regular thrombus. To improve treatment outcomes. This is a case of the occlusion of the right internal carotid artery. SBS was seen from the internal carotid artery to M1. We have selected the Q-French balloon guiding catheter. The balloon guiding catheter was inflated and the forward blood flows are blocked. The reason for this is to prevent the clot from the displaying distally as a microguide wire and the microcatheter pass through the clot. The stent retriever was deployed. I guiding the tip to the clot while the spreading into the cat 6 catheter. Cat 6 was confirmed to be the best position. One pass check 3 confirmed. Importance of the contralateral angiography. In this case of the left internal carotid artery occlusion, a catheter is placed in the right internal carotid artery for the purpose of a retrograde imaging. Figure B, imaging the performs to confirm blood flow through the anterior committing artery. Figure C, inflated the balloon guiding catheter and aspiration aids. Figure D, removal of the clot with a central retriever or aspiration catheter. Figure E, left internal carotid artery imaging is performed because of the concern about dispersal of the radial thrombus. Therefore, performs right internal carotid artery imaging and aspiration from the left balloon guiding catheter. Figure F, after confirming that there is no radial thrombus, final imaging is performed from the left internal carotid artery. This is an actual cases. Figure G show retrograde imaging to confirm radial thrombus. Conclusion. The importance of the recanalization rate and time to recanalization in mechanical thrombectomy. The balloon guiding catheter is an essential device. Although it is large in diameter and difficult to guide. The combined technique using the both stent retriever and a special catheter has become the mainstream in Japan. Thank you for attention.
Okay, I think that's the last session of the video from Professor Takeuchi. So if there is a question from the participant, you can write on your question to the chat below, and the committee will send to Professor Takuchi by email. So as a summary, I think that Professor Takuchi is give very clear explanation that in the stroke treatment, that in the advancement of endovascular intervention, we know that even until the time period 6 hours, after 6 hours, if the imaging perfusion show that there is a benefit for the thrombectomy, so we should go for thrombectomy. And also that if the patient is in the time period of IVT, intravenous RTPA, and then we can still go and proceed to the EVP, endovascular treatment. Okay, and then the last, I hope that all the participants can enjoy the workshop, although that we cannot go with the live workshop, but it gives us a brief and clear presentation. Thank you very much for your attending, and I proceed this session to the committee again. Thank you.
Thank you.
NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections.
Okay, good afternoon, all participants of the second workshop of ACNS Congress. We will take a break from now, and then we will continue for the third session of the workshop. The title of the third workshop is the carpal tunnel syndrome surgery. We'll continue at 4 p.m. of Indonesian Central Time and 3 p.m. of the West Indonesian time. We'll take a break for 1 hour and stay tuned for the next workshop from Professor Christopher J. Winkree from USA. Thank you.
NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger, all these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections.
Pernah aku berpikir dan terbesit di benakku, mengulang semua kenangan indah tentang hangatnya di masa itu. Pulau Rama penuh dengan keistimewaan, menjemput rinduku untuk kembali. Pandemi tak merubah keputusanku untuk menyatakan rindu ini. Lombok, Sumbawa, aku kembali. New normal, Lombok, Sumbawa.
Holiday is Lombok, Sumbawa.
Pernah aku berpikir dan terbesit di benakku, mengulang semua kenangan indah tentang hangatnya di masa itu. Pulau Rama penuh dengan keistimewaan, menjemput rinduku untuk kembali. Pandemi tak merubah keputusanku untuk menyatakan rindu ini. Lombok, Sumbawa, aku kembali. New normal, Lombok, Sumbawa.
I see trees of green, red roses too. I see them bloom for me and you. And I think to myself, what a wonderful world. I see skies of blue and clouds of white, the bright blessed day, the dark sacred night. And I think to myself, what a wonderful world. The colors of the rainbow, so pretty in the sky, are also on the faces of people going by. I see friends shaking hands, saying, how do you do? much more than I never knew. And I think to myself, what a wonderful world. Yes, I think to myself, what a wonderful
when I need to escape, far from all pressures and fear. I found this place. When the eyes are open, I always found peace here. Nature, the place where I always come back. Nature is more than my comfort zone. Nature is great and awesome for me. Nature always makes me calm. I want to know it more and more. Like nature knows what I need. And Lombok teach me what is concern of nature. Do not care about background, colors, and differences. Lombok united for a better future. Now I know. I, you, and nature will never be separated. When world is changing, we should change immediately. And Lombok is more than a beautiful place. Lombok is a harmony. The harmony of nature and human that always makes me fall in love.
I swear by the moon and the stars in the skies, and I swear like the shadow that's by your side. I see the questions in your eyes. I know what's weighing on your mind. You can be sure I know my part, 'cause I'll stand beside you through the years. Your only cry swear by the moon and the stars in the skies, I'll be there. And I swear, like the shadow that's by your side, I'll be there. For better or worse, till death do us part. I love you with every beat of my heart, and I swear. I'll give you everything I can. I'll beat your dreams with these two hands. We'll hang some memories on the walls. And when just the two of us are there, won't have to ask if I still care. 'Cause as the time turns the page, my love won't age at all. I swear by the moon and the stars in the skies, I'll be there. And I swear, like the shadow that's by your side, I'll be there. For better or worse, till death do us part. I love you with every beat of my heart, and I swear. Ooh, the ocean hugs the shore. Hold me close, sway me more. Like a flower bending in the breeze. Bend with me, sway with ease. When we dance you have a way with me. Stay with me, sway with me. Other dancers may be on the floor. Deep in my eyes will see only you. Only you have the magic technique. When we sway I grow weak. I can hear the sound of violins long before it begins. Make me thrill as only you know how. Sway me smooth, sway me now. ¿Quién será que me quiere a mí? ¿Quién será? ¿Quién será? ¿Quién será que me dé su amor? ¿Quién será? ¿Quién será? I can hear the sound of violins long before it begins. Make me thrill as only you know how. Sway me smooth, sway me now. Sway me smooth, sway me now.
Good morning, Prof. Chris.
Good morning,
Good
Rohadi. How
afternoon
are
in
you?
Indonesia. Fine, and you? Thank you for your join now for our
Absolutely.
session.
Thank you for having me.
Okay, Dr. Wisnu, maybe we must continue to the third workshop for the topic with the CTS surgery, carpal tunnel syndrome surgery. Time is yours, Dr. Wisnu. Thank you. Dr. Wisnu from Bali, Dr. Chris from Bali Island.
Hello,
Good morning.
good morning, Dr. Winfrey. So my voice is clear?
Clearly. Thank you.
Okay, thank you. So according to our time, this is afternoon. Good afternoon to all participants. I would like to say thank you for your attendance until now. And for the third workshop, it is about carpal tunnel surgery. I will shortly introduce our distinguished speaker from United States, Dr. Christopher J. Winfrey. For the introduction, Dr. Winfrey is Assistant Professor of Neurological Surgery, currently at College of Physicians and Surgeons in New York City, where he specialized in peripheral nerve surgery, peripheral nerve cancer surgery, nerve and muscle biopsies, pain neurosurgery, and spasticity. His research interests including the use of peripheral nerve transfer to treat spinal cord injury and the use of neurostimulation to treat chronic pain disorders. As we know, he is a member of several different professional organizations, including the American Association of Neurological Surgeons, ACNS, CNS, American College of Surgeons, many more, including Sun's editorial board. And he recently completed his term as president of ACNS, CNS Joint Section on Pain. He has outstanding contribution in neurosurgery fields, about 73 publications with more than 2,800 plus citation. Very extraordinary. Thank you very much, Dr. Winfrey, to be able to share with us your knowledge today. And time is yours, Doctor.
Thank you. Let me just get set up here. All right, thank you for the invitation, the considered invitation to attend the Second Asian Congress of Neurological Surgeons. I am a peripheral nerve surgeon, as you heard, and I'm a member of the World Federation of Neurological Surgery Peripheral Nerve Task Force. I've enjoyed attending many of these international meetings in the past, and I hope one day soon to get to spend time in person with my colleagues and you all in the near future. And I'm sure the same goes for you as well. We're going to speak today about carpal tunnel surgery, carpal tunnel syndrome as a diagnosis and how it's treated. And, you know, as neurosurgeons, we are all pretty familiar with the disease. In my experience in the United States, most peripheral nerve surgery is not done by neurosurgeons. And most neurosurgeons have only a basic knowledge of the disorder and the treatments. And I'm not sure how it is around the world, but I'm going to try to give you a more in-depth understanding of the disorder. We will go over the basics, but we'll go over in a fairly deep dive some of the evidence and the literature that describes and lays out some of the treatment options, and really try to give you a more complete understanding of the disorder and how it's treated. I have no disclosures. I'll mention some of the different types of endoscopic techniques, but I have no ties to any industry, and I've never worked for any of these companies. I'm not even sure I'll mention any of the companies by name, but if I do, it's only for your assistance in sort of looking up some of these techniques on your own. I would like to specifically thank the Asian Congress for the invitation and the Indonesian Neurosurgical Society for putting together this meeting, as well as the medical faculty at Mataram University. I'd like to thank Rahati specifically for the invitation. I appreciate the honor to be able to speak with you today, and for Dr. Wisnu, right? Is that, or Dr. Wardana for moderating today's session. We're just meeting now, so if I did not get your name correct, I apologize.
It's correct, Dr. Wisnu, Dr.
So I would like to specifically call out our Japanese colleagues today for an incredible Olympics they have put on over the past couple of weeks. I know it's been a challenging time for everyone, and I know COVID has made things quite difficult, but you guys pulled it together and really did a great job. And from our end, at least in the US, it was a pretty spectacular Olympics, and you guys should be pretty proud of your efforts. You know, a lot of these athletes have spent their entire lives trying to get to the Olympics, and you help make their dreams come true, and that's very cool. And how about the Indonesian badminton team? I mean, for a country your size to just basically beat the pants off the rest of the world and get the gold medal, that's very impressive too. And you guys should be proud of your badminton players. That was very impressive, and that's a very neat thing too. On a personal note, my wife and I in 2010 actually went to Bali. We went to Indonesia for our honeymoon, and it was the most incredible trip we've ever done. It's almost a magical place, and I really wish I was with you there now in Indonesia, and I look forward to returning one day soon. So as an outline today, we'll be discussing carpal tunnel syndrome, how to recognize it, how to see patients, how to diagnose, and then how to treat it. We'll go over a number of procedure videos to illustrate some of the treatment techniques, mostly the endoscopic techniques, but we will discuss the open techniques as well. We'll spend some time reviewing the evidence supporting open and endoscopic techniques and try to give you a sense of how to choose between the two. And the take-home message is that it probably doesn't matter, and it's whatever you and your patients are more comfortable with, and that's the important thing. Carpal tunnel syndrome, as you know, is one of many compression neuropathies. Compression neuropathies occur when a peripheral nerve is under pressure from surrounding tissues, whether it's bone or ligament, muscle, or something else. Compressing a nerve results in nerve dysfunction. And the three most common peripheral neuropathies that we see, at least in the United States, are carpal tunnel syndrome first, ulnar nerve compression at the elbow, and peroneal nerve, also known as the fibular nerve, compression at the knee. And as a neurosurgeon, I treat these probably every week. Although, like I said, most neurosurgeons, at least in the United States, don't. There are very few here that treat these with regularity. Carpal tunnel syndrome is median nerve compression at the wrist. And in the United States, about 300 out of 100,000 people get this per year. So 0.3% incidence, which again, doesn't seem like a lot, but we have a population of 350 million people. And some of you are from countries with way more people than that. So you can imagine a lot of people get this disease. And what I'll do throughout this talk is show a number of references, which I would invite you to take a look at if you're interested in more in-depth review of the topic. A lot of these references are good. Some merely illustrate the point that I'm making, but some are worth a more time spent reading them. A basic review of the anatomy of the carpal tunnel. The carpal tunnel is at the wrist and proximal hand, and it is a tendon-filled tunnel with the flexor tendons of the hand and fingers, the median nerve, and it's bounded by the carpal bones or the wrist bones here on the floor, and then the transverse carpal ligament forming the roof. And within the transverse carpal ligament run a few structures, the ulnar nerve medially, the ulnar artery as well, and in most patients, the palmaris longus muscle. Looking here at this diagram off to the side, a number of bony structures help define the carpal tunnel, the trapezium and the scaphoid laterally, as well as the hook of the hamate and the pisiform medially. And this forms a trapezoid structure here, which is bounded or covered by the transverse carpal ligament. And again, the floor of that is the wrist bones, the carpal bones. And that's really the area we'll be talking about. Some other basic anatomy in the region, and these are book diagrams from Netter's really nice illustrations. Netter is an American anatomist who's published a lot of the papers that, or a lot of the pictures that we utilize in medical school in the United States. Anyway, superficially, if we look at the area of the carpal tunnel is basically centered on the interval between the middle finger and the ring finger. And if you notice, off to the radial side or the thumb direction here is this superficial sensory branch. It's the palmar cutaneous branch, which is a branch of the median nerve. It comes off the radial side of the nerve and it runs along in a direction towards the middle finger. That's the nerve that provides sensation to the base of the thumb. And it's one of the couple of branches that we are mindful of when we're doing carpal tunnel surgery. We don't want to injure that branch. A couple layers deeper, we see the palmaris longus muscle running on top of the transverse carpal ligament. And then underneath the transverse carpal ligament, we see the median nerve, which branches not long after it exits from the carpal tunnel. And this first branch off of the median nerve going towards the thenar muscles is the recurrent motor branch. It's called recurrent because it comes off and then goes in the backwards direction. It reverses direction. But this is important because, again, it is on the radial side of the median nerve, right over the middle and index fingers. And so that is another reason why during carpal tunnel surgery, we keep our incision to the ulnar or pinky side of our carpal tunnel, because we don't want to damage either the palmar cutaneous branch or the recurrent motor branch. You'll also note a couple of centimeters distal to the carpal tunnel is the palmar arterial arcade or the palmar arch. Again, this is an important vascular structure for the hand, and it's a structure you'll want to avoid injuring when you're performing carpal tunnel surgery. So during the endoscopic videos I will show you later, one of the important anatomic boundaries is putting the endoscope in and seeing the end of the transverse carpal ligament. And it's there we begin to see the palmar fat pad, which is in this area. Once you see that, you know you've gone far enough with your instruments. You don't want to push that further and injure this artery, because that would lead to a bad vascular complication, which would ruin your otherwise happy day. For a lot of this talk, I refer to some evidence. This evidence can be found in this American Academy of Orthopedic Surgeons document. It's called Management of Carpal Tunnel Syndrome, and it is a clinical practice guideline. It's over 900 pages long. I'm not suggesting that any of you read the entire document from beginning to end, but it does have a comprehensive and very helpful review of the available evidence. So if there's something that you want to know about carpal tunnel syndrome, I would encourage you to refer to this document. It has a really nice index split into chapters where you can look up whatever topic you want. So if you're interested in the evidence that would support, say, steroid injections for carpal tunnel syndrome, you can find it here. And it's very comprehensive up to at least 2016. My impression of the more current literature, I know this is 5 years old, is that things haven't dramatically changed. But I think as new technological advances occur and more experience occurs with diagnostic imaging, we will see some updates to this document or similar documents regarding MR neurography, ultrasound, and some of the more advanced endoscopic techniques. But right now, for the time being, this I think is really the best summary and best collection of evidence for carpal tunnel syndrome. So I would encourage you to refer to it if you ever have an interest in reading more about this subject. So who gets carpal tunnel syndrome? Patients can have a predisposition to getting carpal tunnel syndrome. And there's a variety of different things that predispose a person to getting carpal tunnel syndrome. There are metabolic factors, for example. And again, these evidence tables come directly from that 900-page document. And so an elevated BMI, body mass index, it's basically a measure of how big a person is in relation to their height. So overweight or fat people have higher body mass indexes. It's a way of calculating essentially how big a person is. So elevated BMI is the single greatest metabolic risk factor for carpal tunnel syndrome, which if you think about it, kind of makes sense. Remember, carpal tunnel syndrome occurs when the median nerve is compressed within a confined space within the carpal tunnel. And if a person is very heavy, they tend to have more fat within their tissues, and that fat can crowd the median nerve and put pressure on it. Undoubtedly, there are other metabolic factors, perhaps poor vasculature or other conditions that will exacerbate the physical crowding of the nerve. But just having that much fat around is probably the most important thing. And if you look, there is some additional evidence, albeit not as strong, which supports menopause and perimenopause being an independent risk factor for carpal tunnel syndrome in women. And rheumatoid arthritis is also a risk factor for carpal tunnel syndrome. Again, that makes sense. Patients who have rheumatoid arthritis have thickening of their tissues with inflammatory substances. And so that can thicken the ligament and put additional pressure on the nerve because there's only so much space in that carpal tunnel. And if it's filled up with ligament, there's less room for the nerve. When I was training, both as a med student and as a resident, we always thought that diabetes and hypothyroidism and pregnancy were also independent risk factors for carpal tunnel syndrome. But it turns out, I guess the evidence is not as strong for those. I still ask patients about it, but in review of the evidence, it would seem that maybe those three are not such an important risk factor for carpal tunnel syndrome, although I think there is some evidence to suggest otherwise. Occupational conditions can predispose a patient to developing carpal tunnel syndrome. Again, very strong evidence that repetitive hand and wrist motions are a risk factor for carpal tunnel syndrome. So anyone that does the same motion over and over, assembly line, hammering, painting, back and forth type movements, probably the biggest risk factor with elevated BMI, as we talked about before. There is also evidence, albeit not as strong, that suggests that computer work or grip work or anything involving vibration, even gardening, can predispose someone to carpal tunnel syndrome. So there are a lot of people across the world that are using jackhammers, that are typing at computers. And so that sort of activity over and over and over again for years at a time can help someone develop carpal tunnel syndrome. So we see a lot of patients who are laborers and spend a lot of time on computers getting this disorder. there are a number of anatomic factors that can predispose someone to develop carpal tunnel syndrome. Again, if you review this list of predisposing factors, the tendinopathies, right? So problems with the wrist flexor tendons, tendinitis, tendon calcifications, any sort of diseases of the tendons, tenosynovitis can, again, produce a mass lesion within the carpal tunnel that can compress the median nerve, resulting in the problem. Although we don't see this really in this evidence base, probably because they're less common, patients who've had distal wrist fractures, right, who've broken their wrist or the scaphoid bone and either undergone splinting or an open repair, in my experience, sometimes develop carpal tunnel syndrome, simply because there can be swelling, there can be scarring, there can be instrumentation, bony calluses, which can compress the median nerve, causing carpal tunnel syndrome. And although this phenomenon is not common enough to make that evidence table, we definitely see it in clinical practice. Patients can develop ganglion cysts within the wrist, either ganglion cysts that do not directly involve the nerve or intraneural ganglion cysts that do. That can affect the median nerve and result in carpal tunnel syndrome. And then once in a while, every couple of years or so, I will see a patient with a tumor in or near the carpal tunnel that results in carpal tunnel syndrome. And so again, not common enough to make the evidence table, but it's something I do see in my practice. So right before we get further, someone had a question in the chat room about which neuropathic drugs are safe in the first and third trimester of pregnancy, and for how long can we wait for a pregnant woman, painkiller, extension of wrist splint, and carpal tunnel decompression. So generally speaking, the neuropathic pain medications, the anticonvulsants and the antidepressants, are largely thought to be teratogenic, which means they can cause birth defects. And although some have a lower risk than others, for example, Lyrica, which is one of the gabapentin type medications, is called pregabalin is the generic name. That is thought to be fairly safe, although the recommendation in the United States is to discontinue these medications in pregnancy. And the recommendation for treating women who are pregnant with carpal tunnel syndrome, generally a steroid injection into the carpal tunnel is the recommended treatment to get them a month or 2 or 3 of pain relief so that they can avoid needing neuropathic pain medications and avoid needing surgery. So I hope that answers your question. Patients present with a variety of symptoms that are fairly characteristic for carpal tunnel syndrome. So pain, typically in the first 3 out of 5 digits of the hand, pain that's nocturnal. Patients often describe the discomfort, the numbness, the tingling, the burning pain in the hand. It wakes them up at night. The reason for that is many people sleep with their wrists flexed as they curl up in bed. And when one flexes the wrist, that puts pressure on the carpal tunnel, and that reduces the blood flow to the structures in the carpal tunnel, specifically the median nerve. So the nerve becomes ischemic and it becomes symptomatic. And again, that's why patients often wake up at night with the symptoms. They'll get up, they'll shake their hand, they'll straighten their hand out, and then the symptoms go away, and then they go back to bed. It's a very common pattern seen in these patients. These patients also get sensory loss in those same digits, and sometimes in the palm of the hand. They complain of weakness or clumsiness. And when you ask the patients, it's typically doing things like tying shoelaces or handwriting if it's the dominant hand, tying a necktie, anything that involves fine motor control. Patients will often complain that they can no longer do it as effectively, buttoning buttons, for example. On physical examination, one typically sees numbness in a median nerve distribution, which involves the first 3 out of 5 digits and it typically splits the fourth digit. Just a basic physical exam concept, when you see sensory loss splitting a digit, which we often see in carpal tunnel syndrome as well as ulnar neuropathy, splitting a digit typically indicates a peripheral nerve problem rather than a nerve root problem or radiculopathy. Radiculopathies tend to affect the pinky, like a C8 radiculopathy will affect the pinky, whereas an ulnar neuropathy will tend to affect the pinky and half of the fourth digit. So that's an interesting little physical finding that may help you distinguish a radiculopathy from a peripheral neuropathy. So this is the classic sensory loss for carpal tunnel syndrome. Note the sparing of the palmar cutaneous branch, which is the sensory involvement of the base of the thumb. And you can see that laid out here in this diagram. This is the carpal tunnel distribution numbness, and this is the palmar cutaneous branch, which, as you recall, comes off proximal to the carpal tunnel. And although it travels over the carpal tunnel, it should not be compressed in carpal tunnel syndrome. So we should see sparing of the sensation at the base of the thumb. Note also that the median nerve distribution covers the back of these fingers as well. So there's a little bit of an overlap with the radial nerve distribution here. So usually a careful sensory exam is pretty straightforward at delineating these issues. One will see atrophy on a physical examination, and the atrophy will typically involve the thenar or the thumb muscles, specifically the abductor pollicis brevis muscle, which resides here on the proximal sort of half of the thenar muscle group. And so seeing wasting of that muscle is very common in carpal tunnel syndrome. And in fact, there's an evidence base for this finding. So there's strong evidence supports thenar atrophy, which is atrophy of this muscle, being strongly associated with carpal tunnel syndrome. Obviously, it's not sensitive for carpal tunnel syndrome because many people have carpal tunnel syndrome that's not severe enough to cause atrophy. It's severe enough to cause pain, numbness, and tingling, but it's only the more advanced cases that develop atrophy. Most people treat the condition before it gets this bad. So that's why a lot of patients who have this finding have carpal tunnel syndrome, but a lot of patients with carpal tunnel syndrome don't necessarily have atrophy. Also on physical examination, as neurosurgeons, we'll have a tendency to check for a Tinel sign. That's when you tap on the area of entrapment, and that should reproduce an electrical sensation that radiates in the distribution of the affected nerve. So if you tap on the carpal tunnel in someone with carpal tunnel syndrome, they should feel electrical shocks into the first three digits and into the hand. Phelan sign is where you have the patient flex their wrist like this fairly aggressively. This replicates what happens when people sleep. Again, as I said before, that cuts off or reduces the blood supply to the median nerve, and it makes the nerve ischemic. And after a minute or two, most patients with carpal tunnel syndrome don't tolerate that. So that is a positive Phelan sign. So a lot of us do these maneuvers on our examination, but it turns out that as standalone tests, the Tinel sign and the Phelan sign are neither sensitive nor specific for carpal tunnel syndrome. So this is not something you should do as a standalone diagnostic measure. In other words, a lot of patients have Tinel signs that don't have carpal tunnel syndrome. And the reverse is also true. A lot of patients with carpal tunnel syndrome don't have either Tinel or Phelan sign. But looking at these physical findings in the broader context of a physical examination, along with subsequent diagnostic studies, is appropriate. Just don't rely on these alone to make your diagnosis. Electrodiagnostic testing is helpful to confirm someone who you suspect may have carpal tunnel syndrome. And basically going from less severe to more severe, one of the first things you'll see on electrodiagnostic testing is increased median nerve distal sensory latencies. So a latency is the delay in the onset of the signal through a nerve. The way I think of that is that a delayed nerve is a sluggish nerve. So a latency is a measure of the sluggishness of a nerve. So when you start to compress a nerve gently, it gets a little bit more sluggish. And so you'll see a prolongation of these sensory latencies. And that's one of the first findings you'll see in early carpal tunnel syndrome. More severe degrees of compression will begin to affect the myelin. That's the insulation around the axons. When you start to affect myelin, you start to reduce the efficiency of nerve conduction. And that will give you slowing of conduction velocities across the affected segment. So more severe degrees of compression will give you slow conduction velocities across the wrist. As you compress the nerve further, you start to damage the axons. When you start to damage the axons, the amplitude of your nerve conduction study, the strength of the signal, not the conduction velocity, but the actual strength of the signal, the amplitude will start to drop. So once you see that, you know you've got some pretty severe nerve involvement as those axons are dying off. So when you start to see dramatically reduced amplitudes, you know it's fairly severe. And then as your axons start to die off, your abductor pollicis brevis muscle will become denervated. And as you know, denervated muscle is irritable muscle. And when you stick an irritable muscle with a needle, you'll get fibrillations, you may get fasciculations. And when you start to see denervation of the abductor pollicis brevis, again, that gets you into the realm of severe carpal tunnel syndrome. So when we see that, we definitely want to think about surgical treatment. We don't want to do a lot of prolonged non-operative therapy at that point. So the electrodiagnostic studies not only help confirm the diagnosis, but help indicate the severity and the urgency of needing surgical treatment, if you will. What can be helpful in milder cases of carpal tunnel syndrome is doing something called an inching study. All that is a nerve conduction study that you would normally do for the median nerve, but instead of doing a nerve conduction study that's averaged over a long segment of nerve, say from the elbow to the wrist or elbow to the palm, you measure the nerve conduction across the nerve a centimeter or two at a time. And so what that does, it provides a very sensitive way of looking at conduction velocity drops that might be lost if you average that out over the entire length of the nerve. So what we see with an inching study is measurement of nerve conduction over a short segment. This is the normal nerve. This is the later nerve. And you can see how as you march down the nerve, this peak is about the same. And then when you hit the carpal tunnel, the peak flattens. And if you look at the amplitude drops. So it's a really nice way of picking up not only the presence of carpal tunnel syndrome, but exactly where along the nerve is compressed. And this can be a really nice technique for someone who presents to you with a median neuropathy, but you're not sure if the problem is at the wrist or more proximal at a forearm or elbow level. And we'll talk about that here in a minute. So inching studies can be a very nice additional technique to your electrodiagnostic studies. In the past 10 years or so, diagnostic imaging has really begun to play an important role in the diagnosis of nerve entrapments in general, nerve injuries as well, but also carpal tunnel syndrome in particular. And so there's a lot of literature on this. This is not necessarily the best paper, but this had a really nice figure in it where it shows the median nerve just proximal to the carpal tunnel. And you can see as it dives under the flexor retinaculum, the nerve becomes thinned and compressed. And again, these are the tendons, this is the nerve, this is the ligament. And again, very easy to see how the median nerve goes from a normal caliber to a compressed caliber here under the ligament. Again, you can also compare the normal side, which shows a fairly round nerve, compared to the abnormal side, which shows a flattened nerve. And again, it's very common in ultrasonography to compare the two sides to establish whether there's an abnormality. MR neurography is an MRI technique where the high resolution pictures of the nerves are obtained. These are usually done with stronger magnets. Most neurography uses a 3 Tesla magnet, which is twice as strong as most MRI scans here in the United States. And MRI usually utilizes T2 weighted sequences. And as you recall from your neuroradiology training, T2 is the best sequence for showing edema in structures, whether it's brain or nerve or anything else. And the reason that's important is when you compress a nerve, you'll not only physically flatten the nerve, as you see in this axial MR neurogram of the wrist. Here's the carpal tunnel. These dark spots are the flexor tendons. Here is the median nerve being compressed flat by this dark structure, which is the transverse carpal ligament. So you can clearly see the nerve flattened here, but you also see that the nerve is quite bright. A normal nerve is normally gray, like this structure, kind of a dark gray. But here you can see it's very bright. So clearly that nerve is irritated. What you can also see is some of the secondary changes in the muscles following a severe nerve entrapment. And so here we see the base of the thumb, some of the hypothenar the thenar muscles, specifically the abductor pollicis brevis, which shows denervational changes from the median neuropathy. So this patient has severe carpal tunnel syndrome, as evidenced by the denervation in the abductor pollicis brevis muscle. And so the neurogram not only shows you the structural compression of the nerve, but the effects in the muscles as well. Here's what a muscle normally looks like, a nice gray color. This is hypothenar muscle, not affected by carpal tunnel syndrome. I see there's another chat question. Thank you for the comment. The surgical scar. So we will talk later about some of the surgical techniques, but you're right. I mean, anytime you do surgery, there will be scarring. And so some of the endoscopic techniques are nice for minimizing scar after carpal tunnel surgery. So after we discuss the techniques, maybe we can get a little bit into the nuances of scarring in this area. Once you make your provisional diagnosis of carpal tunnel syndrome, obviously you know there needs to be consideration of other diagnostic possibilities. Patients who have a C6 radiculopathy, so a C6 nerve root issue from cervical spine pathology, can present with sensory findings very similar to the sensory loss and discomfort seen in carpal tunnel syndrome, affecting the radial portion of the hand in the first 3 or 4 digits. Radiculopathy patients commonly have neck symptoms. In other words, if somebody presents and you think it's a radiculopathy, very often range of motion testing of the neck will bring out additional symptoms. And that may sort of clue you in that this is a cervical spine issue rather than a peripheral nerve issue. But if you're still not sure, obviously electrodiagnostic studies, neck imaging can all be useful. A patient who has a cervical radiculopathy will exhibit some changes on their EMG in their nerve conduction studies that you won't find in carpal tunnel syndrome. So specifically, a C6 radiculopathy should affect the biceps muscle. And so one might expect to see fibrillations in the biceps muscle, which obviously will not be present in the setting of a pure carpal tunnel syndrome picture. Additionally, there will be fibrillations in the cervical paraspinal muscles, commonly in the setting of a radiculopathy, but not in the setting of pure carpal tunnel syndrome. Your high-resolution diagnostic ultrasound or your MR neurogram likewise will show normal carpal tunnel and normal median nerve in the setting of a pure C6 radiculopathy. The problem is, in practice, very commonly patients present both with cervical spine pathology and carpal tunnel syndrome. When they both occur together, it can be confusing. It can represent what we call a double crush syndrome, where the nerve root may be compressed up at the cervical spine, giving them symptoms into the hand. And they also have compression of the median nerve at the wrist, causing symptoms in the hand. So when this happens, and let's say the patient has both issues, we will often treat the carpal tunnel first because that's the simpler, less invasive procedure to see if that helps the patient. And if that doesn't help sufficiently, then we'll do the spine surgery to try to address the spine pathology. The exception to that would be if a patient is actually myelopathic. So if there's spinal cord compression, then the priority would be to treat the spinal pathology first and then see how the patient does. And if they don't improve fairly quickly, go ahead and release the carpal tunnel. So we have another question in the chat. In the case of a malformed structure causing carpal tunnel syndrome, what will be the priority of treatment? Well, hopefully this, I just answered that. I think you either treat what you think is most severe. Maybe if your judgment, the spine is more severe, you treat that first. If it's a toss-up, I would treat the less invasive one first and treat the carpal tunnel. But again, you might be safe doing both. It kind of depends on the patient. So a question about imaging studies being mandatory. So the standard of care does not require that we obtain imaging studies in the United States. I personally find them very helpful because sometimes the diagnosis is not so straightforward. But if you have a patient who's very straightforward and who has a history, a clinical presentation, a physical examination, and electrodiagnostic studies, all that show carpal tunnel syndrome, I personally do not think it's mandatory to get nerve imaging. At my institution, we have excellent ultrasound. So I routinely send them for ultrasound of the carpal tunnel. MR neurography is much more expensive. And so I do not routinely get MR neurography for patients that are straightforward. But I utilize neurography if it's a more complex clinical picture, such as somebody with potentially thoracic outlet syndrome, which we'll talk about in a minute. So I agree with you. Relying on the clinical presentation and electrodiagnostic studies is sufficient and is appropriate to move forward with a surgical recommendation. You don't have to get imaging in everybody. So there was a question about correction of malformed bony union or carpal tunnel decompression. So I guess the question is, if there's an anatomic abnormality in the wrist causing the carpal tunnel issue, would that warrant a repair of the structural anomaly? And obviously it depends on the specific patient, but my general recommendation is if there is an anatomic abnormality that's correctable, then I think treating the underlying abnormality, whether by a hand surgeon, orthopedic surgeon, or whoever, it may not be a neurosurgeon, I think that would be an appropriate treatment. So if I had a patient with carpal tunnel syndrome who had a ganglion cyst or some bone spur compressing the median nerve, I would probably not just do a simple carpal tunnel release. I would involve one of my hand surgery colleagues and try to address the underlying pathology. I hope that answers your question. Also in the differential diagnosis is more or are more proximal median nerve entrapments. Pronator teres syndrome is an example of one of these more proximal nerve entrapments. As you recall, the median nerve lies under the lacertus fibrosus on the medial aspect of the forearm. And when you incise that, underneath that is the pronator teres, the two heads of the pronator teres muscle. And the median nerve crosses the elbow and enters those muscles, goes right between them. And when you open up the pronator teres muscle, you will then see the flexor digitorum superficialis muscle. And part of that muscle involves this tendinous arch. And the median nerve goes right underneath this tendinous arch, also known as the sublimus bridge. And it is that area that tends to compress the median nerve. So as the nerve dives through the pronator teres muscle and under this tendinous arch, there's a number of vascular leashes as well, which can tether the nerve. And that's generally the site of compression at this level. Patients who have pronator teres syndrome will present very similarly to carpal tunnel syndrome. They'll look just like carpal tunnel, except that they will often have sensory loss in that palmar cutaneous branch. Remember that little branch, that sensory branch that comes off proximal to the carpal tunnel? Well, in carpal tunnel syndrome, that branch will be spared and that sensation should be normal. In the setting of pronator teres syndrome, it should be abnormal because the compression is proximal to the takeoff of that branch. And so on your physical examination, you'll likely see loss of sensation in that territory. And your nerve conduction studies will often show loss within that sensory territory as well. Remember the inching studies I described before. If someone has pronator teres syndrome, you may see a drop in conduction velocity across the elbow and proximal forearm, but the carpal tunnel conduction may be normal. So that's a nice way of distinguishing those two diagnoses. In more severe cases of pronator teres syndrome, you may see denervational changes within the flexor muscles of the forearm, both the finger flexors as well as the wrist flexors. So you may see fibrillations on your EMG in the forearm level muscles, which you would never really get with carpal tunnel syndrome. And again, in cases like this, imaging can be very helpful. So if you suspect a more proximal median nerve involvement, your diagnostic imaging can be very helpful. And there's examples both in the literature and just in one's clinical experience that shows that here's a patient with pronator teres syndrome with the nerve clearly getting compressed between the heads of the pronator teres muscles. The nerve is squashed flat in comparison with the normal side where the nerve is more rounded and more normal looking. Similarly, imaging, both X-ray and ultrasound in neurography, can show a supracondylar spur. Remember the condyle of the humerus, so above the condyle, supracondylar spur, which represents the origin of the ligament of Struthers, which is a ligamentous structure that crosses the elbow and can compress the median nerve. So you can see that here on your ultrasound and MRI studies if you have them. So again, your imaging can show some of this abnormal anatomy. And it's nice to have this imaging before you do surgery because you don't want to do a pronator teres decompression only to find out later the compression was up higher at the supracondylar spur or ligament of Struthers. So just briefly, I know the talk is not about pronator teres syndrome, but just to illustrate the anatomy, it's an incision across the elbow. This is the medial elbow. This is the ulnar nerve. This is the biceps tendon, so you're medial to that tendon. The median nerve crosses the elbow and enters the forearm. And so what we see is the median nerve entering the pronator teres muscle between the heads. So we split the heads of the pronator teres muscle. Here the heads are split, and we now see the nerve diving under the flexor digitorum superficialis muscle. This is the sublimis bridge, that tendinous arch. And when you place an instrument in there, you really begin to appreciate how hard and how firm that band is. And you can understand how that structure can actually compress the nerve. So all we do is split that structure right down the middle, and that fully decompresses the median nerve as well as the anterior interosseous nerve, which usually branches right at the area of entrapment. So when you do a decompression, this is what it looks like afterwards. And patients usually do really well. Just to wrap up the differential diagnosis, Parsonage-Turner syndrome, also known as neuralgic amyotrophy, can mimic any neuropathy, including carpal tunnel syndrome, or more commonly, anterior interosseous neuropathy. So if you see that, you could consider neuralgic amyotrophy as part of your differential diagnosis. Typically, though, you would see other findings, involvement of other uninvolved nerves in muscles in a patchy distribution, but sometimes it can mimic a mononeuropathy. So again, imaging is your friend here. If the nerve looks normal, then maybe it's not a compressive neuropathy. Also, the lower trunk brachial plexopathies, whether they're from thoracic outlet syndrome or a Pancoast tumor. Remember the apical lung tumors, lung cancer, right? Compressing the lower trunk of the brachial plexus right at the level of the first rib. These can mimic carpal tunnel syndrome. Here is that same patient before with carpal tunnel syndrome and atrophy of the abductor pollicis brevis muscle. If you look at a patient who has severe thoracic outlet syndrome, they also have atrophy of the abductor pollicis brevis muscle. So on first glance, these two hands appear to be similar. But as you know, a lower trunk brachial plexopathy, whether it's thoracic outlet syndrome or a Pancoast tumor, will also involve the ulnar nerve. So in a patient with carpal tunnel syndrome, the hypothenar muscles supplied by the ulnar nerve should be normal, whereas in the lower trunk plexopathy, you'll have atrophy of the hypothenar muscles. You'll have abnormalities in the ulnar nerve distribution. You'll have weakness of the hand intrinsic muscles. This patient is displaying what's known as a Wartenberg sign, which is a abduction of the pinky because of weakness of the interossei. So this hand is, although initially appears similar to a carpal tunnel hand, it's actually quite different. So getting into some of the treatment, now we've diagnosed our patient with carpal tunnel syndrome. What do we do with the patient? Well, the initial non-operative treatment is kind of similar to what you'd recommend for one of your spine surgery patients, right? Somebody who has a herniated disc or foraminal stenosis. You'd recommend that they avoid activities that aggravate their symptoms. So somebody that does a lot of jackhammering, who develops carpal tunnel syndrome, you might say, lay off the jackhammer for a while. Give the nerve a rest. Maybe physical or occupational therapy can be helpful. Some desensitization therapy, help them with the pain, or to help strengthen the affected muscles. All of these are appropriate initially. And again, this is really no different than what you would do in other areas of neurosurgery. Referring back to that 900-page evidence document, there is strong evidence that supports the use of actually a wrist splint in patients with newly diagnosed carpal tunnel syndrome. What the wrist splint does is it keeps the patients from flexing their wrist while they're sleeping. And what that does is that protects the blood supply to the nerve and allows the patient to get a full night's sleep without waking up with pain, numbness, and tingling in the hands. And so the splints can be very effective at that. And a lot of patients are able to avoid surgery by wearing the wrist splints. There is also reasonably strong evidence, moderate evidence, to support the use of neuropathic pain medications. Again, somebody had asked in the chat about the use of neuropathic pain medications. So you may have a patient with very modest levels of median nerve compression at the carpal tunnel syndrome, not enough to cause neurological deficits, but enough compression that causes pain. So there is an evidence base that supports the use of neuropathic pain medications to treat these patients. That can be very effective for treating carpal tunnel syndrome, or at least the pain associated with carpal tunnel syndrome. There is also evidence to support the use of oral steroids to get pain relief in patients with carpal tunnel syndrome. Now, as neurosurgeons, we're familiar with the use of steroids in patients, and we commonly use short courses of steroids for our neurosurgical patients, be they cranial patients or spine patients, and now carpal tunnel syndrome patients. But as neurosurgeons, we also know that steroids are very complicated medications, and long-term steroid use can be really problematic. So the recommendation is not for prolonged steroid use, but a short course of oral steroids can help patients with carpal tunnel syndrome, especially if they're trying to get through a particularly painful exacerbation of their condition. A more commonly used use for steroids in carpal tunnel syndrome is a steroid injection into the carpal tunnel. And again, people have talked about this for years, but it turns out that there's a very strong evidence base supporting the use of a steroid injection into the carpal tunnel in patients with carpal tunnel syndrome. Now, that doesn't mean we inject every patient who has carpal tunnel syndrome, but patients who are pregnant, for example, and don't want to have an anesthetic during pregnancy, patients that really don't want to have surgery, or patients that you think might be inappropriate for surgery because they're too sick or they've got other issues going on, a steroid injection might be a really nice way to get them temporary relief and sometimes more durable relief and help them avoid an operation. There's another question in the chat. In your experience, what causes the pain to recur after surgery and how to deal with it? So I'll get into this in some detail later on, but the most common cause of persistent pain after carpal tunnel surgery is failure to completely divide the transverse carpal ligament. So the way I personally would deal with persistent pain after surgery is to image the patient and see if there's any retained ligament causing compression. Imaging will also tell you if you've maybe missed the diagnosis. Maybe someone who has persistent pain after a carpal tunnel release actually has entrapment at the pronator teres, or maybe has thoracic outlet or a spine pathology. Or as we talk about later, some people just have pain. And even though you've decompressed the nerve, they have persistent pain. And we'll go over some strategies later in the talk to deal with those patients. So at this point, we have a patient who's been diagnosed with carpal tunnel syndrome. Maybe they've done some non-operative therapy, wrist splinting, injections, but they're still having bothersome symptoms. Or maybe their condition has advanced to the point where they have denervational changes or fibrillations on their EMG. So what do we do at this point? Obviously, as neurosurgeons, we will consider a surgical treatment. Well, is there evidence to support that decision? And it turns out there is very strong, high-quality evidence that supports the use of surgery in patients with persistent carpal tunnel syndrome after a trial of non-operative therapy. And it shows that the outcomes are actually better at 6 and 12 months for people who get surgery rather than prolonged non-operative therapy, splinting or medications or otherwise. So if you have a patient who's symptomatic from carpal tunnel syndrome and your initial efforts at non-operative therapy are not effective, it is appropriate to offer surgery. What's additionally revealed by the evidence is the type of surgery to do. And the indication is to do whatever operation needs to be done to completely release or divide the transverse carpal ligament. It really doesn't matter how one does that, which really gets to the crux of the talk today, endoscopic versus open. It turns out that outcomes, it probably doesn't matter. Your patients are going to probably do just about the same if you divide the transverse carpal ligament by whatever means you want to do. Now, we'll get into some of the differences and the nuances, but as long as you divide that ligament, there's strong evidence to support that surgery helps these patients. Historically, a lot of carpal tunnel surgeons have done additional procedures during the transverse carpal ligament division. And it turns out that doing this extra work, tendon exploration, epineuriotomies, internal neurolysis, tenosynovectomies, all of these are unnecessary and probably should not be done. So the evidence says that unless there's a distinct anatomic abnormality that needs to be addressed, like we talked about before, your best strategy is to divide the transverse carpal ligament and don't mess around with the other stuff in the carpal tunnel. So a quick review about the anatomy. Again, we went through some of this before. If you're planning a carpal tunnel surgery, it's good to have an understanding of what some of these structures are. Kaplan's line is drawn from the thumb to the distal end of the pisiform bone. And that line should represent the distal border of your skin incision. If you go much further than that, you risk injuring the palmar arterial arch. You want to be mindful of the palmar cutaneous branch, which comes off before the carpal tunnel, and the recurrent motor branch, both of which are on the radial side of the median nerve. So you want to keep your incision between the middle finger and the ring finger, which keeps you on the ulnar side of all this anatomy, helping you avoid injury to these nerve branches and keeping you centered over the carpal tunnel and not damaging something you shouldn't be damaging. So there's different types of surgical release of the median nerve at the carpal tunnel. When I was a fellow, my fellowship director, David Klein, used to do a formal open carpal tunnel release. It involved a fairly large incision, and it was pretty invasive. And just quite frankly, I don't think this really needs to be done routinely. I would not recommend doing this operation routinely in your patients. But just for the sake of completion and to illustrate the anatomy, an open carpal tunnel release is a really nice way to see the anatomy. Here's the median nerve proximal to the carpal tunnel. You can see the transverse carpal ligament here. I did this operation as a reoperation for somebody, so I needed a longer exposure. But I am not advocating that you do this for routine carpal tunnel surgery. But just to illustrate the anatomy, proximal to the carpal tunnel, one sees the palmar cutaneous branch coming off here and then going above the transverse carpal ligament. As we go through the carpal tunnel, there really shouldn't be any branching, but right after the carpal tunnel, we start to see the recurrent motor branch here. There's actually two branches in this case. And then we see the median nerve split into its digital branches more distally. I didn't actually see the palmar arch in this exposure, although that would have been a neat component of the picture. Again, I keep my mini open carpal tunnel release incision proximal to Kaplan's line here. So this is a much bigger incision than one would normally use. So in principle, what we want to do is do the minimal amount for a mini open carpal tunnel release, the minimum exposure to divide the transverse carpal ligament. So here's just a little schematic diagram. Here's the median nerve. Here's the ligament. You want to just cut it open with a scalpel or scissors. It's really that simple conceptually. And so to do that, what we want to do is have about a 1-inch incision just distal to the wrist crease, and I stop it just at Kaplan's line, which usually gives us anywhere from 2 centimeters to maybe 3 centimeters in length. This incision goes a little past Kaplan's line. Just I do that for illustration, but I usually don't use this portion. I just use what's proximal to it. Because again, you want to avoid injury to the palmar arch. And again, be mindful of, on the radial or thumb side, the recurrent motor branch and the palmar cutaneous branch. So what you'll see is about a 1-inch or 2 to 3 centimeter incision. Here's the transverse carpal ligament that I've divided, and here's the median nerve underneath. I'll then, with my loops and headlight, look proximal and divide the wrist fascia for another 4 or 5 centimeters just through this 2 centimeter incision by undermining the skin. And I'll cut distally until we see the palmar fat pad here. So again, those are the limits of your incision. You want to transect the ligament distally into the fat pad and proximally into the wrist fascia. Endoscopic carpal tunnel release, conceptually almost identical. What's different is you're using 1 or 2 smaller incisions, ideally not in the palm, although this diagram does show an incision in the palm. Typically, for endoscopic carpal tunnel surgery, the incision is in the wrist. And the main advantage, or the main reason to do that, is when you avoid incisions in the palm, patients recover faster and they go back to work faster. So here's, from a schematic standpoint, what an endoscopic carpal tunnel release does. A small incision, you identify the transverse carpal ligament, and you insert a trocar that gives you some working room. And that trocar has a groove in it, which will later be used to pass a blade to cut the ligament. But this trocar gives you some working space that you can then insert an endoscope so you can see the anatomy. And then you can insert, either at the same time or subsequent to that endoscope, a blade which you use to drag across the ligament to actually cut the ligament. And that's all done with a small port incision, usually in the wrist, proximal to the wrist crease. And then 1 or 2 stitches, and the patient can go home as an outpatient. Very straightforward procedure. So conceptually, that's what an endoscopic carpal tunnel release will involve. Now, this is an old picture, about 15 or 20 years old, showing an old 2-port technique, one of the earliest endoscopic carpal tunnel procedures, just to illustrate just the basic concept, where there's either a 1-port or, in this case, 2 ports. All that 2-port means is there's a hole here for the trocar, and the trocar pops out here, and it gives you a working trocar that you can access from both directions. And what you want to do is, once you get this in place, Underneath the transverse carpal ligament, you pass a curved blade, which we'll see later on, and that blade then cuts the transverse carpal ligament. Because remember, that's all you really have to do. You have to cut that ligament and decompress the nerve. And there's a bunch of different ways to do that. So that's an example of a 2-port technique. Here's a video of a 1-port technique to illustrate, again, some of the basic principles of endoscopic carpal tunnel surgery. And let me walk you through this video. First, you're going to see them mark the skin incision, again, just proximal to the wrist crease. Once the skin incision is marked, they typically inject a local anesthetic. In my experience, I do these with patients sedated. I don't normally use a general anesthetic, though you can for patients who don't want to be awake for the procedure. So you make a small incision with a scalpel. And again, the incision's not on the palm typically, it's in the wrist. And then what you want to do is identify the wrist fascia, and you want to incise the wrist fascia with your dissecting instruments, usually scissors. The reason you want to incise the wrist fascia is because the wrist fascia blends into the transverse carpal ligament. So the transverse carpal ligament is really the same layer as the wrist fascia. And since our endoscopic carpal tunnel surgery needs to be under the transverse carpal ligament, the best way to get under that ligament is to get under the wrist fascia. That space will take you right under the transverse carpal ligament into your working space where you will be operating using endoscopic carpal tunnel releases. So the best way to get there is to make an incision in the wrist fascia and access that space. So after accessing underneath the wrist fascia, one will then pass a series of dilators to make that working space bigger for you. So these dilators are getting progressively larger. This is the one maneuver that I think is most risky in carpal tunnel surgery that's done endoscopically. It's this blind passing of instruments into the carpal tunnel. Remember, the carpal tunnel is compressed, right? It's a tight space. And so this maneuver is the one that would make me most nervous. So just be mindful of that. So making your working distance a little bigger. And then at this point, we can now pass another instrument to really dissect that ligament from the nerve. It's a flatter instrument that allows you to separate the two. Now we bring in the camera. And again, just for the record, this is not my video. These are videos I got off of YouTube because I thought they were very well done. And I will give you the links to all these videos shortly, so you can actually look these up yourself. Anyway, what they do is they put the camera in. All of this is done through a single incision. And as they insert the camera under the transverse carpal ligament, you want to insert that in all the way until the end of the transverse carpal ligament. So you see them tapping on the hand here. That way they know they're past the ligament and you can see palmar fat. Once you're there, you engage the knife blade and you, under direct vision, will cut the transverse carpal ligament through its entire length. So as you make this cut, you can tilt the camera towards the median nerve and you can see the median nerve to make sure it's safe. You can tilt it to the other side and see the flexor tendons. And what you want to do is stay right in between, and you'll continue that cut all the way proximal to your incision in the wrist crease. So here's our incision. So we've now cut the entire ligament. So what you'll then do is stick the endoscope back in and confirm that the ligament is completely divided, the nerve is free, and all you see is fat and nerve. Once that's done, the surgery is over, and you put a couple of stitches in, and then the patient goes home. So what I'll do is I'll just play this again without me talking, so you can just watch the procedure now that you know what we're watching. Proximal wrist incision. You want to get under the wrist fascia so you can then get under the transverse carpal ligament. Now you want to start to create some space under the transverse carpal ligament with your dilators to give you some room to work. And as you get further distally, you need to use thinner instruments like this flat spoon-shaped instrument to really get the distal part of the carpal tunnel open. Once you have a working channel, you can bring in your camera so you can really see what you're doing. Now you get all the way to the distal end of the transverse carpal ligament, and then you can divide the ligament. You want to make sure you go far enough to get to the end of the ligament without hitting the palmar arch. Now we divide the ligament until it's completely divided. You can turn your channel to look at the median nerve. You can turn your channel to look at the flexor tendons. But the bottom line is you have to turn your attention back to the ligament and finish dividing it. And you got to remember to completely divide the entire ligament. And once the ligament's completely divided, you can put your camera back in and inspect your work to make sure you see that the ligament is completely divided and all you see is nerve and fat and cut edge of ligament. There should be no retained ligament left. And then the procedure is done. A couple of stitches and patient's ready to go. There are a lot of different endoscopic carpal tunnel techniques available. I want to illustrate here a slightly different technique. It uses a modification of the two-port technique. Remember the dilators I was showing you on that video, these big instruments you're putting into the carpal tunnel. You know, a lot of patients don't have room in the carpal tunnel to accommodate instruments that big. And so what I'm going to show you here is a technique from a company that I'm not sure they still produce this. This is from a few years ago, but it utilizes a much thinner dilator, one that's thin enough that you can use in patients who are completely awake, and you can use it with ultrasound guidance, and they actually have a variation where you can do nerve monitoring. So if the instrument actually touches the median nerve, it gives you a signal to let you know you're potentially injuring the nerve. So it's a way of doing the endoscopic carpal tunnel with a much thinner set of instruments, and it uses a little a wire, almost like a giggly saw wire, to saw through the ligament. So again, the whole point of this is to use thinner instruments, which some people feel is safer in a much tighter space. So again, thinner instruments to introduce this wire that actually cuts the transverse carpal ligament. So it's a two-port technique. So the wire comes out here, you attach another instrument, and you basically use that wire to saw through the transverse carpal ligament. It doesn't use a camera. You literally just push your finger over this and you can feel the wire go through the ligament. And again, two small incisions and a smaller instrument. So it, in theory, has less risk of nerve injury. Again, just an alternative technique for you to consider. Here is yet another technique that uses ultrasound to help guide the endoscopic carpal tunnel release. So what you'll do is use your ultrasound to establish the anatomy. Here is a transverse view of the carpal tunnel, showing the transverse carpal ligament here in white. The median nerve is this hypoechoic or dark structure here, circled in yellow, and the ulnar nerve off to the side, ulnar nerve and artery. So they're off elsewhere. So you want to stay away from there. So for the purposes of this surgery, your working channel is here, away from the nerve, but under the transverse carpal ligament. And so what this procedure does, it uses ultrasound rather than blind passage of those dilators and instruments that we saw before. So let me show you how this works. So here they've made the incision, proximal wrist, just like before. But what this person is doing is actually injecting saline and lidocaine. It's a technique called hydrodissection. So here is a longitudinal view of the median nerve. Here's the transverse carpal ligament, and they're actually injecting fluid to dissect out the space between the nerve and the transverse carpal ligament. And the purpose of that is to expand that space so they can then safely place their instruments down that space. So let me show you how that is. They're injecting and blowing up this space. And here's the transverse view, again, showing this big space they're creating in the carpal tunnel so they can put in their instrument safely. Again, back to the longitudinal view, now they're inserting their a blunt probe to dissect that space out more. So with the ultrasound, we're seeing the median nerve here, transverse carpal ligament here, and now this probe being inserted under direct visual guidance with an ultrasound. So they know they're not damaging the median nerve because they can see they're not digging into the nerve or distorting the nerve in any way. So watch them place this in this space without damaging the median nerve, which is right here. And again, they're going to place this past the transverse carpal ligament. And here we can see the Doppler signal in the palmar arch, which means they've reached as far as they need to reach. So once they see that Doppler signal, they know to stop. Once they have that space dissected, they'll now insert that curved blade, which is really the same type of blade I showed you in that old endoscopic carpal tunnel surgery. So again, the principles of all these procedures are the same. You create a working channel above the nerve underneath the transverse carpal ligament, and you somehow get a cutting device in there that allows you to divide the ligament. So now watch them insert this knife blade above the median nerve. You can see the nerve at every step. Here's the lateral or transverse view showing the instrument in your working space, not damaging the nerve, not damaging the ulnar nerve or artery off to the side. Again, inserting the blade to the end of the transverse carpal ligament. Again, we'll get the Doppler signal to make sure we're not anywhere near the palmar arch. And then once we're in the right position, we hook the end of the transverse carpal ligament and we just pull the blade through the ligament, dividing the ligament. And you just gradually, slowly withdraw the blade and cut that ligament. And if you want, you can actually feel it with your finger as you go, or use the ultrasound to visually confirm that the ligament's been transected. So once you pull this blade all the way through, you take your ultrasound and you check, and you can see the ligament divided there, and you just check the whole length of the ligament to make sure there's no bands of tissue compressing the nerve. 1 or 2 stitches and a compressive dressing, and the surgery is done. Again, this can be done as an outpatient like all the other carpal tunnel releases. The patients can wake up, you can do immediate testing and make sure there's no nerve injury. So again, I'll play this for you without me talking so you can kind of pay attention to the video and get a sense of how this is done. Hydrodissection, creating the working space. Passing your dissector to again create that working space over the median nerve. You want to get past the transverse carpal ligament without injuring the palmar arch. Now they're inserting the blade, again, past the transverse carpal ligament without injuring the palmar arch. Checking your transverse view to make sure you're not injuring the median nerve. Once the blade is fully inserted, again, mindful of the palmar arch, pull the blade through the transverse carpal ligament, dividing it. You can see the blade pulling through the tissue there. Gradually pulling through, cutting the ligament. Once the ligament's cut, confirm that it's cut with your ultrasound to make sure you didn't miss anything. Instruments come out, dressing goes on, examine the patient, and then they go home. So if anyone's interested in any of these videos, the graphics I showed to just illustrate the mini open and open carpal tunnel releases are here. This was the first carpal tunnel endoscopic procedure I showed you with the big dilators. So if you want to watch the whole video, that's the link. The endoscopic, I'm sorry, the one that used that little wire saw blade is the company called Manos. So you can get that video on their website. And then lastly, the one I just showed with the ultrasound guidance, this is the video link. And so if you're interested in watching that, I edited these for Brett, to shorten them. So if you want to watch the whole video with the narration and see the doctors that actually filmed them, you can watch the entire video. So I'd encourage you, if you're interested, to take a look. So now we have some more time. Let's go through some of the evidence. Now that you have a sense of how to diagnose carpal tunnel syndrome, you have a sense of how to treat carpal tunnel syndrome from a surgical standpoint, what are some of the evidence? What is some of the evidence for these procedures? So there's a number of different sources, including that big 900-page document I gave you. But rather than just refer to that document, I wanted to dig into some of the actual literature and show you some of the papers that you can read yourself to get a better grasp of how they came up with their recommendations. So the Cochrane database is a really nice series of thousands and thousands of papers that review different topics. So there's a Cochrane database review of carpal tunnel, endoscopic carpal tunnel release. And this looked at 28 clinical studies. Some were low quality, admittedly, but over 2,500 operated hands. So fairly good numbers here. And so what this study showed, this sort of meta-analysis of the studies, when looking at symptom severity, there's something called the symptom severity scale, but basically patient symptoms. Patient symptoms did basically the same after endoscopic versus open carpal tunnel. So a patient who underwent an open carpal tunnel release versus a patient that underwent an endoscopic carpal tunnel release, in the end, they had basically the same symptoms after the procedure. So what that tells us is it kind of doesn't matter what you do, both surgeries are effective. That's symptoms. Functional status, also, how much function does the patient get after a procedure? Again, looking at all these patients, all these clinical trials, basically the same results, endoscopic versus open. So this is important because when you're making a surgical decision, trying to figure out what's the best procedure, it turns out there's evidence that supports either technique. So in the end, the decision is going to be you and your patient, and you'll probably be, on a strong base either way. So you do whatever you're more comfortable with and whatever your patient wants. There are some differences, however. Short-term pain scores, so pain within a couple of weeks after the surgery, are going to be better, right, in those who undergo endoscopic carpal tunnel release. There is less of an incision. There's no palm incision. There's no dissection of the superficial tissues in the palm. And again, that's what patients find uncomfortable. And so patients who undergo endoscopic carpal tunnel release report lower pain scores in the early postoperative time points, think 1 to 2 weeks after the surgery. Long-term, however, this is not incisional pain now. This is long-term, 3 months down the line. Recovery of nerve pain is going to be the same in both, which is exactly what I was saying before. Clinical outcomes are basically the same in the long term, but your short-term pain scores will be better in the endoscopic patients. In terms of efficacy, return of function, so numbness improves in both open and endoscopic, again, which is similar to the severity scores I was saying before. It seems that endoscopic carpal tunnel release results in better grip strength. I'm not sure why that is. It may be because some of the open surgeries result in more pain or stiffness. I don't really know why that data exists, like why this is the result, but it seems to be. So grip strength seems to be improved in patients who undergo endoscopic procedures. And in the end, since you're avoiding an incision on the palm, patients get back to work over a week faster with the endoscopic procedure. So that really may be the one thing that sways you or pushes you in one direction as a surgeon, is what your patient wants. If your patient works for a living and if their livelihood depends on them using their hands, you want them to get back to work as fast as possible. And that may be the thing that encourages you to offer an endoscopic procedure for that patient. A lot of patients in my practice don't care. Most are retired. Most don't care about the extra few days. And so I do open carpal tunnel releases. But I'm not opposed to endoscopic carpal tunnel releases. And there's definite advantages in doing the endoscopic procedure and getting patients back to work faster. This paper is another meta-analysis similar to the previous, looking at 15 randomized controlled trials in over 1,500 hands that underwent endoscopic versus open carpal tunnel release. And their findings were very similar. Again, similar strength after endoscopic versus open. Again, their grip strength did not show a difference. So maybe the change or the difference we saw in the other study wasn't real. So maybe that's not a big deal. There was better pinch strength recovery in the endoscopic. Again, I don't have a good explanation for that, but that's what the data shows. Similar pain in endoscopic versus open. And again, that's long-term recovery, which again is similar to the prior study. And similar recovery of paresthesias. So again, functional recovery and symptom recovery in these patients is the same, which again is consistent with all the previous studies I showed. Again, just over a 1 week, so an 8-day faster return to work in the endoscopic patients, which is consistent with the prior studies. And they also looked at reoperation rates. So remember, the biggest cause of persistent symptoms after carpal tunnel release is failure to divide the ligament. So both open and endoscopic techniques have the same complication rate in terms of need to reoperate. So if you're going to miss the transverse carpal ligament with an endoscopic procedure, you know, there are people that miss it with an open procedure. So there's nothing magical about that. There's a question about how to avoid hypertrophic scar over the surgery site. I don't know that there's a good way to prevent scar. I know there's been a lot of research in a lot of different fields, burns, for example, plastic surgery, and even in nerve surgery. I don't routinely add any extra substances or procedures to try to reduce scar. I personally have not found scarring to be a big issue in patients with carpal tunnel release. I've done a lot of carpal tunnel releases, and I've never had someone develop so much scar afterwards that they needed another operation. I guess in theory, a person can develop keloids or, you know, other hypertrophic scar, but I've not routinely found that to be a problem. Whenever I do redo nerve surgery, so somebody has some scarring from a prior operation and I have to go in and do an internal neurolysis, and again, I'll talk about that later. I'll show you a video of what that's like. I will wrap those nerves with a scar barrier, and there's a variety of different commercially available scar barriers on the market, but I will only do that for reoperative surgery. I will never do something like that in a virgin or a first-time carpal tunnel release, so I don't think it's necessary. Again, the complications for open carpal tunnel surgery: failure to completely divide the ligament. That's going to be the most common. There can be injuries to the main trunk median nerve. Look, anytime you got a scalpel and surgical instruments with nerves nearby, there's a chance of causing nerve injury. The incidence rate's about 0.5%, so about 1 in 200 patients on average. Injuries to the branches, the palmar cutaneous branch and the recurrent motor branch, and then the digital branches and the distal portion of the carpal tunnel, right? All of these can be injured. The key to avoiding these branches is to stay on the ulnar side of the carpal tunnel, right? Closer to the ulnar nerve, further away from the thumb. Vascular injuries possible. Thankfully, none of this has ever happened to any of my patients, but if you're not careful and you go too far distal in the carpal tunnel, you can injure that palmar arch. Whenever you incise the transverse carpal ligament, some of the abductor pollicis brevis muscle fibers insert onto it. And whether you do open carpal tunnel release or endoscopic, there's a risk of cutting some of those muscle fibers. And as they heal up and scar down, it causes pain along the incision. We call it pillar pain. That will usually get better with time, but it definitely can bother patients, and they will sometimes complain about it. And then worst case scenario, patients can get complex regional pain syndrome, which is a really bad neuropathic pain disorder, which can be a complication of any procedure, right? It's not just something inherent to carpal tunnel surgery, but patients can get red, swollen, painful hands. It can be a real problem. And that can happen with open carpal tunnel release, probably more commonly than the endoscopic, although it can happen in both. Doing endoscopic carpal tunnel release are a number of complications that can occur specific to the endoscopic procedures. And if you're interested in reading about that, here's an interesting paper about it. Sometimes you can't pass the trocar. Remember those instruments you're trying to get in there, if there's scarring or if it's just too tight, sometimes you can't pass it. I don't really see that as a complication. It's just an indication to convert to an open procedure, which again, you tell your patient ahead of time, look, you're going to try to do this endoscopically. And if things just aren't working out, you open the patient up. I mean, I don't see that as a complication. It's just an alternative way of doing the surgery. Again, failing to divide the entire transverse carpal ligament, that can occur with any of these procedures. And failure to completely divide the full thickness of the ligament. Remember that dragging the knife through the ligament, sometimes if the ligament's really thick, you may just cut partway through the ligament. That's why it's important to use your camera and look up there to make sure you're seeing fat, because once you see subcutaneous fat, you know you've completely divided the ligament. There have been reports of main trunk median nerve injuries. Here's a median nerve transection after a endoscopic carpal tunnel release. You know, thankfully these are rare injuries, but they do happen, and especially if you're blindly passing some big instruments, and so nerve injuries can occur. Injuries to the main trunk nerve, the branches, and the vascular structures that we talked about. So all these can occur with the endoscopic procedures. But in the end, all these studies are looking at safety of these two procedures. Irreversible nerve damage seems to be higher in the open procedures, probably because you're just doing more dissection, you're exposing more tissue, and maybe you're cutting some of those branches and you're not really seeing it. That the risk of that seems to be higher in the open procedures. Reversible nerve damage seems to be higher in the endoscopic carpal tunnel releases. And that makes sense. Again, you're putting these dilators and you open up these working channels in a really tight space. So it's not surprising that the nerve in there will get bruised or beat up a little bit. Again, it's not enough to cause permanent problems, but the patients may have transient neurological deficits, numbness, pain, that sort of thing. And so those typically get better, but it's not surprising those will happen more commonly in the endoscopic procedures. Wound complications, not surprisingly, will happen with the open procedure. Wound infections, hematomas, wound dehiscence, where the edges of the skin fall apart. Obviously, with bigger incisions across the palm, the risks are going to be higher. If you can just do a 1 centimeter incision in the wrist, right, the risk of that wound having a complication is going to be much lower. So again, it makes perfect sense that the endoscopic patients will have fewer wound complications, and the evidence bears that out. Complex regional pain syndrome occurs more often in the open. Again, we talked about this before. That also makes sense. The open surgery involves more tissue dissection, more tissue injury, more likely to cause complex regional pain syndrome. Major complications, we talked about these. Again, clinical studies have shown that the incidence of major complications is basically the same in the two procedures. And again, the biggest differentiator is the presence of complex regional pain syndrome and some of those big nerve injuries. So again, the safety profile is real similar, but it's not identical. Transient nerve injuries occur more commonly in endoscopy. Again, this is just a different paper showing the same results we talked about before. Wound complications are higher in the open. Again, it's the same thing we talked about before, just a different reference. So there's multiple sources for this. You're not just taking the word of a single clinical trial. And again, the minor complications seem to be less, like the wound issues and things. So some people actually consider endoscopic carpal tunnel release to be a safer procedure in select patients. Now, I know in the United States, we have a reputation, and it's true, and again, it's kind of sad, but in America, we just spend obscene amounts of money on healthcare with seemingly little incremental benefit. And it's gotten to the point it's almost ridiculous. So in the United States, a lot of places don't really care how much procedures cost. Everything's expensive. Insurance companies pay the hospitals a ton of money. A lot of money changes hands, and it's kind of ridiculous. So in the United States, there's less of a concern about how much a surgery costs. Obviously, in some medical facilities, there is more attention paid to cost, but I do understand in most parts of the world how expensive a surgical procedure has an impact in whether the surgeon and the patient elects to undergo that procedure. So something to keep in mind when you're making these decisions on which surgery to choose for your patients. Endoscopic carpal tunnel surgery requires more equipment, it's more labor intensive, and it's quite frankly more expensive. Now, it may not be dramatically more expensive, but it is significantly more expensive than open carpal tunnel release. When I do an open carpal tunnel release, I probably use 5 surgical instruments, like literally scissors, forceps, a needle driver, and you know, a retractor. I mean, every carpal tunnel release, same 5 instruments. Dirt cheap, right? There's really, other than the disposable drapes, there's almost no equipment costs doing the procedure. If you're doing an endoscopic procedure, you've got the endoscope, all the endoscope maintenance. If you're using ultrasound to help guide your endoscopic instruments, that is expensive. That requires maintenance. So you see, understand how, you know, it's one thing to say that, you know, we've got this fancy new surgical technique, but you have to understand that it is more expensive. And I do understand that cost is an issue in most areas, and even some areas in the United States. So something to think about. So I think there was a question before about what to do if patients don't get better and what to do about scarring. I want to talk about a case where one does a nerve decompression and the patient doesn't get better, or the patient gets better transiently and then they get the entrapment again. I have found diagnostic imaging very helpful in these cases. I want to show you a case of a patient with an ulnar nerve decompression that, to illustrate the point. I don't have an identical case where I have a video and pictures involving the median nerve, but this can happen with any nerve decompression, and it can also happen with a carpal tunnel release. So in this case, the patient had an ulnar nerve entrapment, and I did an ulnar nerve decompression. All right, very simple, very straightforward. They got better for a while, and then their symptoms came back. So one may say, well, why did their symptoms come back? So we checked. Did they have a cervical spine issue? Nope. Did they have an entrapment elsewhere? Nope. The problem was at our operative site. So rather than just doing an exploration just without getting more information, we actually got a high-resolution diagnostic ultrasound, and it showed something very interesting. It showed narrowing of the nerve at our operative site. So if you look, here is a normal caliber ulnar nerve. This is the normal nerve distal to our operative site. See how thick it is. Here's the normal nerve proximal to our operative site. See how thick it is. And look how skinny the nerve gets where our previous surgery was. That is called an hourglass constriction, where you have circumferential scar that compresses the nerve. And so you can see that on an ultrasound. And the reason that's important is because if I go back in and reoperate on this patient and just do another decompression, that will not address this hourglass constriction, and that patient will not get better with the second operation. The only way this patient's going to get better is if I made an incision or a series of incisions across this constriction and release that internal scar. It's called an internal neurolysis, and here's what it looks like. You actually bring in the operating microscope, and you make several incisions in the epineurium, and you dissect between the fascicles to open up that constricted space. That takes the pressure off the nerve and it allows the nerve to heal. All right. This is not a procedure I do routinely for carpal tunnel or any other nerve decompression surgery. This is only a procedure I do if preoperative imaging shows that there's an hourglass constriction. But again, this is important to keep in mind when you're addressing patients who fail to get better after an initial decompression surgery. If you look for these, you will find them, and this procedure can help your patients. Sometimes patients, no matter what you do, still have pain. We're neurosurgeons. We all have patients that we've tried our best to get better with whatever surgical procedures, whether it's spine surgery or nerve decompression surgery, carpal tunnel release, whatever. Structurally, everything seems to be fine. You've decompressed the nerve. There is no more compression. There's no entrapment at another site. There's no spine pathology. Sometimes patients just have pain. And if you do a carpal tunnel release, endoscopic or otherwise, and your patient has persistent neuropathic pain afterwards, and all of your investigations fail to show compression at your operative site, don't decompress the patient. Don't operate again. You're offering a surgical solution for a surgical problem that doesn't exist. If there's no nerve compression, don't decompress the nerve again. I would encourage you to adopt a more functional approach with these patients. Don't do more surgery, treat the pain. Treat the pain with medications. Maybe involve your pain management colleagues, steroid injections, whatever it takes. But in the end, as neurosurgeons, you have other tools available to help these patients. And I would encourage you to consider something like a peripheral nerve stimulator, which is a wire that's placed non-surgically, just percutaneously with a needle, usually ultrasound guided, placed next to the nerve, and it can electrically block the pain signals arising from that nerve. So this can be a great minimally invasive treatment for patients with persistent median neuritis or neuralgia after a failed carpal tunnel release with no evidence of persistent nerve compression. It is also, and again, peripheral nerve stimulation has been around since the 1960s. This is not new. There are new equipments, right? Or, new surgical techniques. There's new hardware, new companies, but the principle is the same, and it's been around for decades. You are also on fairly safe ground in terms of an evidence base if you choose to do a spinal cord stimulator to treat residual hand or arm pain after a failed nerve decompression. Again, I would not do this without looking for areas of persistent entrapment or other areas of entrapment. But if you truly cannot find a structural problem with the nerve, I would encourage you not to do more surgery, but to do a stimulator instead. Treat the patient's pain, and you'll have a happy patient. All right, so in conclusion, I know we've been talking for a while, and I'm sure people have questions, but let's wrap this up. So open and endoscopic techniques are safe, they're effective, and they're evidence-based. You can choose whichever technique you feel is best in your practice. You can do what you feel is best for your patient, as long as you're good at it, as long as you have access to the procedures, the evidence will back you up. There is a learning curve, especially with the endoscopic techniques. So you may hurt a few patients in the process of learning how to do the endoscopic techniques. But if you're careful, if you learn from someone who knows what they're doing, and if you maybe employ some of the techniques utilizing ultrasound to help prevent nerve injuries, you can get good at these techniques and actually do a really nice job for your patients in the future. Your endoscopic carpal tunnel release patients will get to work faster in general than if you do them through an open technique. And there are some surgeons, especially those with a very large experience, a lot of experience doing endoscopic carpal tunnel release, they actually feel it's a safer procedure for their patients, for most of their patients. Now, endoscopic carpal tunnel release is not appropriate for patients with diabetes. Remember, diabetic patients have more fragile nerves. They're more susceptible to nerve injury. So anytime you're creating that working space in the carpal tunnel in the setting of a compressed nerve, there's a risk of damaging that nerve in a diabetic patient. So I would urge you not to do the endoscopic procedure in diabetic patients. Endoscopic carpal tunnel release is not appropriate for patients who've already had carpal tunnel surgery, right? Remember, passing those dilators blindly through the carpal tunnel through an area of scar will dramatically increase your risk of injuring the nerve. Don't do it. It's not worth it. It's only for people that have not had a wrist surgery before. Endoscopic carpal tunnel surgery is probably more expensive than the open technique. So if cost is an issue where you practice, keep that in mind. But in the end, the surgeon working with their patient can decide what's best for the patient. And like I said, there is an evidence base to support either technique for most patients. Ultimately, if your surgery, whatever surgery you choose, endoscopic or open, if your surgery fails, really try to do your patient a favor and figure out why. Diagnostic imaging is your friend if you have access to it. Maybe the ultrasound shows that you've got some residual transverse carpal ligament. Here is the median nerve above and below with a normal caliber. See the nerve narrowed here. Here's the transverse carpal ligament that you didn't divide at your first operation. So maybe that's the cause. Or maybe if the transverse carpal ligament has been divided, maybe scarring has produced an hourglass constriction. Again, imaging is your friend here. Maybe your neurography or ultrasound will actually show a nerve injury after your surgery. We all like to think that we're good surgeons and don't cause things like this, but sometimes bad things just happen. Maybe doing a carpal tunnel release results in a hematoma inside the nerve, something that you couldn't prevent. It's not necessarily a technical issue, but if your patient doesn't get better, get them imaging and find out why if you have access to imaging. If there is a neuroma, repair the nerve. If there's an hourglass constriction, do an internal neural lysis and decompress the nerve. And if there's still a residual ligament, go back in and divide it. Again, if your patient doesn't do better after your procedure, which should have about an 80 to 90% success rate, consider an alternative diagnosis. Maybe they have pronator teres syndrome. Maybe they've got a lower trunk brachial plexopathy or Parsonage-Turner syndrome. And remember, not all pathology is surgical. You can operate on your patients. Maybe they get better, maybe they don't. But if there is no compressive pathology, don't keep operating on your patient. Consider a more functional procedure like neurostimulation, peripheral nerve stimulation, spinal cord stimulation, or even just have one of your pain management colleagues use medication and injections to provide pain relief for that patient. I hope everything was clear, and I hope everyone enjoyed this talk and learned something from it. I know we covered a lot of basic things that we should all know as neurosurgeons, but I hope you were able to get into some of the evidence and some of the videos you may not have been familiar with to help you make the best decisions possible in treating your patients with carpal tunnel syndrome moving forward. So I'll stop sharing, and I'm happy to take any questions if there are any.
Thank you very much, Dr. Winfrey, for the deep, concise, and very clear presentation, including immediate response to all the questions. I also thank you for Dr. Muhammad Tahir, Dr. Veda Makiah, Dr. Bam for the questions. While waiting I see professors of neurosurgery participate in this workshop. So while waiting for all another question from them or any seniors, so I make some summary for your lecture. So I think Dr. Winfrey already informed about concepts, the very important literature for the carpal tunnel syndrome surgery, the increased BMI, repetitive use, the anatomy factor are the predisposing conditions that can lead to median nerve compression. The presentation also highlighting very important physical examination, electrodiagnostic testing, ultrasonography, MRI, wide range of differential diagnosis. The operation techniques, nuance, and complications also comprehensively already present. Evidence that we need to know to distinguish this syndrome from other pathology, as well as the treatment efficacy, also already elaborated by Dr. Winfrey. We already really appreciate your help and contribution in this workshop, especially on your early morning, Doctor. I think now 6 a.m. Yeah, in New York. So
well, we're all surgeons. We're all used to getting up early, so it's really not a problem. And it was an honor to spend the morning with everyone today. And I thank you again for the invitation. It was very considerate, and I can't wait to get back to Indonesia. I really love it. It's the best place I've ever visited, and I truly mean that.
I surprised you.
Thank you, sir.
Picture of Bali also. So, is there any question from the participants, or maybe Dr. Hadi maybe have questions, maybe?
Okay, thank you. I want some question for the Dr. Chris. First, about the treatment. In your presentation, you suggest to the steroid injection, yes, Dr. Chris. Some report about the side effect of the steroid injection in the local to the median nerve is atrophy. How about that? Because patient a very long time with the neuropathic pain. Maybe if a patient cannot do surgery. Second question about the diagnostic from the anamnesis and physical examination, and to the continue the advanced diagnostic with the neurological tests, for example, EMG and NCV and MRI. If how about your recommendation? Enough about the EMG and NCV, or to the continue with the MRI in the T2 MRI? And maybe other topic, sir, about the differential diagnostic with the CTS, for example, for the thoracic outlet syndrome. In your presentation, you about the loss and some report about the operation in the thoracic outlet syndrome. How about the effectivity of the exploration in scalectomy? So it is evidence of the scalectomy for the TOS. Thank you very much, Dr. Chris.
So I'm going to try to remember all these questions. So the first question was complications of steroid injections. And so especially with repeat steroid injections, there are a number of reported complications. One can get an injection injury into the median nerve, which is thankfully rare. And in most people who do steroid injections now, I believe, at least in the United States, are using ultrasound guidance. Not everybody does. I mean, you do it with an awake patient. And so when you do an injection, you put the needle into the carpal tunnel and you do a test injection where you just pulse very gently to make sure that your needle tip is not in the nerve. And so when the patient's totally awake, you can do that with a very high degree of safety. Now, using ultrasound guidance can give you an additional degree of safety, so you can see the tip of the needle and make sure you're not in the median nerve. Nevertheless, though, steroids can be complicated. Steroids can cause elevated blood sugar in patients with diabetes, and steroid injections can actually result in a very low incidence, but a non-zero incidence of tendon rupture. So remember, you're injecting into an area full of tendons. So in theory, you could weaken a tendon and cause a tendon rupture. This is not a common complication. I mean, the steroid injections are pretty safe, but these things can happen. Some patients can develop scarring after a steroid injection. I operate on a lot of nerves all over the body, and I've seen when we do an open decompression, it could be any nerve anywhere. Patients who've had a lot of steroid injections usually get these yellow calcifications. And again, that may be evidence of the steroid or the preservatives, or maybe just some bleeding that the injections cause. So definitely they're not totally benign procedures, but they tend to be safer and less scar generating than, say, open surgery, right? So that was the piece about the carpal tunnel injections. Now you had a question about the use of diagnostic imaging, right? Was that the next question? So yes. I personally routinely use diagnostic imaging, specifically ultrasound, in every one of my nerve entrapment patients. And the reason for that is I'll sometimes get surprised. Ultrasound here is safe, it's easy, it's accessible, and it's fairly cheap. I don't think that everyone everywhere, even in the United States, much less the world, needs to use diagnostic ultrasound. But I will say in New York, where I practice, patients are very quick to sue their doctors. So medical legal considerations are important. So if you have a patient with a nerve problem and you fail to diagnose it, or you operate on the wrong spot, you're on the hook for a lawsuit. And that's a real problem in the United States. And that's a problem that a lot of other people in other countries don't have to the same degree. So I ultrasound everybody. And once in a while, I get surprised. I like to tell the story of a patient of mine who I diagnosed an ulnar nerve entrapment in, and her electrodiagnostic study suggested that the entrapment was at the wrist. So I was ready to do a Guillen's canal decompression here at the wrist to decompress her ulnar nerve. I decided to get an ultrasound instead. And the ultrasound actually showed scarring of her ulnar nerve at the mid-forearm level. This woman was like 80 years old. She's in my office. And I asked her, have you ever had an injury to your forearm? And it turns out she was a Holocaust survivor. She was actually in one of the German concentration camps during World War II. And she just remembered, she hadn't thought about this, and she was 4 years old in the concentration camp, but she remembers a German guard handcuffing her and dragging her across a field with a handcuff across her forearm. So she said, I haven't thought about that since I was a little girl, but that must be how my nerve got injured. And it turns out the ultrasound showed a neuroma with compression of the ulnar nerve at a forearm level. And the only way we would have discovered that and revealed this story is with an ultrasound, right? Because I was ready to go in and decompress her nerve distally without even imaging. And that would have been a mistake in her. And so I think, ever since then, I've really gotten ultrasounds in everybody, and you'll be surprised sometimes. And again, I don't know that a person has to, it's not standard of care, but it's something I definitely do in my practice. Neurography is more complicated, it's more inconvenient, it's more expensive, and I don't routinely use neurography for every nerve entrapment patient, but I do use ultrasound. So moving on to the differential diagnosis question, there's no doubt, and I showed an example of that, how a lower trunk plexopathy can mimic advanced carpal tunnel syndrome. But usually, you know, as neurosurgeons, we're pretty astute at examining patients, and you'll quickly realize that your patient with the hand issue has ulnar nerve distribution deficits as well. And so if you see the combination of median nerve and ulnar nerve, you need to be thinking a couple of different things. One is something called a Martin-Gruber anastomosis, and I'm not sure if you're familiar with that, but the median nerve and the ulnar nerve will very often have communicating branches that go from one to the other anywhere along the course of the arm, forearm, and hand. And so you can have a circumstance where there's an isolated ulnar nerve entrapment that also involves the median nerve through one of these Martin-Gruber anastomoses. And the reverse is also true, where you have a median nerve entrapment that results in ulnar nerve deficits. But a more common thing, or at least another thing you should consider, is a more proximal brachial plexopathy, lower trunk brachial plexus, or medial cord of the brachial plexus that can involve the ulnar and median nerves. So in that case, you would do an investigation to look for thoracic outlet syndrome. And so in my practice, I use MR neurography for that. I think the neurogram is the best way to look at the thoracic outlet. The ultrasound is good, but it misses some areas because there's shadows under the clavicle. There's shadows near the first rib. So it's really hard to see everything with an ultrasound. I think the neurogram is a better way to rule in or out thoracic outlet syndrome. You had some other questions. I'm apologize. I'm forgetting what some of the other, there was a lot of questions to unpack, and I think I'm missing some. What else were you asking about the electrodiagnostic studies?
Yes.
So I think I said before, you'll be on pretty safe ground as a provider if you do a history, you do a physical, and you get electrodiagnostic studies. And if all of that shows carpal tunnel syndrome, I think you're on safe ground offering an operation. I am not recommending that everybody get routinely imaged, either with neuro MRI or ultrasound. But I think if you have access to them and there's any clinical uncertainty about your diagnosis, it's reasonable to at least screen with an ultrasound. And I have no problem with that. Like I said, I do it myself, but I'm not telling the rest of the world they have to do that by any means.
Okay, sir. Thank you. Dr. Wisnu.
So we have there's a chat. If both hands have carpal tunnel syndrome, do you do the release at the same time or one hand first? So it is common to see patients with bilateral carpal tunnel syndrome. I do the surgery through a mini open approach. And so because of that, the patient's hand is out of commission for about a month. They're not in a splint, they're not immobilized, but they are restricted. I don't allow them to lift more than 5 pounds at a time with the hand. And so what that means is they can't carry things like groceries or do work. And so you need to have one good hand so you can drive, so you can walk the dog, so you can carry your children or whatever. So I do one side at a time as a rule. And I allow that patient 6 weeks to recover so they have full use of their hand. And then I do the opposite side. Now, if you are doing endoscopic carpal tunnel releases without that kind of restriction, I think you could either shorten the time period between surgeries or just do them both at once. Another thing to consider, though, is if there is an infection, right? Maybe your endoscope is contaminated, or maybe the person has a surgical site infection. It'd be a shame to get bilateral infections, right? I mean, the chances of you getting bilateral infections doing surgery a month or two apart is pretty low. But if you get them both at the same time, like that's a real problem. So again, I do one side at a time, always.
Thank you, Dr. Winfrey, for the answers and Dr. Dodan for the questions. Is there any participant that want to ask?
Maybe last question for me, Dr. Wisnu.
Sure. Dr. Hadi.
How about earlier physiotherapist on rehabilitation after surgery, sir? It's recommended or not? Or physiotherapist, rehabilitation.
So like physical therapy, rehabilitation
Yes,
therapy?
yes,
Right.
after
So-
surgery.
Exactly. So I see patients 2 weeks after the surgery to take out their stitches. And I basically see how the patients are doing. If the patients have weakness, I send them for occupational therapy to help strengthen the affected muscles. If the patient has pillar pain or sensitivity along the scar, I send them for desensitization therapy with occupational therapy. And so what they do is they just do some gentle scar massage beginning at 1 month to try to break up some of the scar tissue that seems to help pillar pain. Also, I encourage patients to use the hands. And if they're very active and they go back to their workout routines and they're motivated, they usually don't need formal occupational or physical therapy. But some patients are, quite frankly, lazy. Some patients have a lot of stiffness or weakness. And some patients really want to have a therapist work with them because they're not motivated to do the work themselves. So it's really dependent on your patient. So you talk to the patient, you examine them, and you see what's really best for them. I try not to be too dogmatic about it. In other words, I don't do the same thing for everybody. I tailor it to the patient's needs, and that's how I approach it.
Thank you, sir.
Thank you very much.
Well, I know it's dinner time where you guys are. I personally wish I were out getting Indonesian food because I love Indonesian food and think it's a spectacular cuisine. I'm jealous of all of you who are able to go get some nasi goreng and some, papaya salad and all the rest. I wish I were there with you.
Nice.
Yes, in the future, yeah, we may meet. And I have one question, Dr. Winfrey.
Sure.
About your experience for the carpal tunnel syndrome release, is there any difference between any technique with the, what time the fastest that you let the patient do the normal? Some patient wants to do sports, some patient want have a very active, like typing. So is there any ideal time in your experience?
Well, so I think patients who want to get back to activities, whether it's work or sports or whatever, if time is really an issue for them, then I think the endoscopic carpal tunnel release is the way to go. But I think, like I said, most patients that I operate on are retired, they're older, time's not an issue. So I don't do the endoscopic carpal tunnel releases. But I think if you have patients who are young and want to get back to work as quickly as possible, I think it's totally reasonable to do an endoscopic carpal tunnel release. In the end, it's up to the surgeon and the patient to make that decision together based on the surgeon's experience and patient preferences. And like I said, there's an extensive evidence base that will support whatever decision you make, as long as there's not an obvious contraindication that we talked about, diabetes, prior surgery, et cetera.
Yes, I think I agree also. Yeah, answer, because so many evidence-based that supports our decision that that need to be individualized, I think. So so I don't see any more question, and lots of appreciation from the participants, and 125 actually that very enjoy lecture until now 6 to 21 p.m.
Dr. Wisnu, before we end the session, we must make a photo session with Dr. Chris.
Yes, please let the committee do.
Yes.
So
maybe any participation live on.
Please open the video, the cam, so we can make a capture. We can capture the. Yeah, please. Please the committee already.
Okay.
3, 2, 1.
Okay. Second. Okay, finished. Thank you. Thank you, Dr. Chris. Thank you, moderator, for.
All right, thank you again. It was an honor to spend the morning with you, and good luck and enjoy your dinner, everyone.
Okay. Good luck, Dr. Chris.
Thank you.
Nice.
You too.
Thank you. Good morning, sir, in USA.
Yes, so I returned to the yeah, please.
Thank you for an
Committee.
amazing information from our speaker and Dr. Dewa Putu Wisnuwardana for leading this session. Distinguished guests, honorable speakers, delegates, ladies and gentlemen, now we're entering the closing of pre-conference Second ASEAN Congress of Neurological Surgeons. During this day, we have been given such wonderful, insightful knowledge by the speakers. We truly hope that you have had a meaningful experience of learning, sharing, and networking. We would also like to apologize for any inconvenience that you experienced during this day. See you tomorrow. Have a nice day and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger. All these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections.